Welcome back to the Insurance and Real Estate Committee's Tuesday, February 21st, 2023 public hearing. We are going to give this another shot. If we do have technical issues again, we can talk about another day to continue the public hearing. For now, we will move on to order number 1, Jared Koski, the Deputy Commissioner of the Connecticut Insurance Department.
Good afternoon again. I will first by again saying thank you to Senator Cabrera, Representative Wood, Senator Wong, Representative Pavlock, D'Amato, and all the members of the Insurance and Real Estate Committee. Again, I am Jared Koski. I'm the Deputy Commissioner of the Connecticut Insurance Department. You all heard what I said about the core mission of the department, so I'll skip to that part and get right to our agency bills. So the first is Senate Bill 1038, an act concerning captive insurance companies. So this bill allows protected cells of captive insurance companies to establish and maintain separate accounts and transfer risk to such accounts. It also exempts a dormant captive insurer from the minimum premium tax applicable to active captive insurers generally. So this proposal follows on the heels of last year's captive insurance bill, keeping Connecticut competitive with other states in this space. Our second agency bill, SB 1039, makes various technical changes to the insurance statutes. For our health insurance statutes, it corrects multiple dependent coverage sections by removing accident-only type coverage from those sections. This proposal also updates language in the infertility statutes to comport with federal law. The financial regulation piece of our technical bill would add 2 additional fees to the existing fee structure for certified reinsurers and reciprocal jurisdiction filings, and permit the commissioner to require payments be made electronically. The insurance licensing proposal updates insurance producer licensing for out-of-state applicants consistent with new state-based system, the new state-based system for producer licensing function. And finally, I'd like to speak in support of SB 983. This is the governor's bill, an act limiting anti-competitive healthcare practices. So this bill not only promotes competition, but it serves to stem the unsustainable rise in prices in our current healthcare delivery system. Slowing down or reducing the costs in our delivery system has a direct impact on our health insurance premiums. Eliminating anti-competitive contracting between health plans and providers is one mechanism in this bill that will help drive down the healthcare cost structure. The bill also seeks to reduce out-of-network rates. Keep going. Okay. The bill also seeks to reduce the out-of-network reimbursement rates to providers to lower healthcare costs, while also encouraging providers to join health plan networks. With this expansion of healthcare networks, consumers will have greater access to care throughout Connecticut. So thank you very much for the opportunity for me to speak in support of the department's bills. Thank you. Any questions?
Great. Thank you, Deputy Commissioner. I do have a few questions.
Sure.
Regarding 983, the national, I think it's a MASHP model. Regarding the reimbursement, are we okay? Okay. Regarding the reimbursement, I believe it's tied to Medicare.
Yes.
The national model is higher than the Medicare reimbursement. Can you explain the reasoning for the reimbursement rate that you put in here?
Well, yeah, so we've been working closely with other agencies through the executive branch on these bills, but the 100% Medicare rate was determined to be a good example, a good way to bring the carriers and the providers to the table on this one. Certainly, I know we're working on language with other bills out there as well, but this was the consensus of the group, the 100%.
So is there room for additional discussion on that?
I'd leave that to the governor's office.
Okay. And I also wanted to ask, how are we determining that the savings are going back to the consumers?
Specific to that
Yeah,
part on the
Yeah.
out of network coverage. Well, presumably by reducing the costs of care as well, as we've spoken at many times before, the overall cost of care is directly tied to the premiums that people pay. And that by reducing the cost of care, it should correlate to a direct reduction of the premiums as well. And there's many mechanisms by which we can determine this. But certainly, I think that is an ongoing conversation that we're having with regards to the two bills that are out there on this discussion, is how do we ensure that that does in fact happen? And we're more than willing to sit down and have those conversations as we've have been.
and just the last question regarding the surprise billing language. How is this in line with federal law? Does it contradict federal law? How are these working together?
Currently, we are currently analyzing that right now. We've been through this process before last year when the federal no surprises bill came out, and we do have the bill on our books that's specific to the fully insured market. So with the advent of this, we are looking into making sure that it does comport to the federal law, and there may be some tweaks that need to be made, but certainly that is being analyzed by our department in conjunction with the governor's office and sister agencies as well.
Any other questions from the committee? Any questions on Zoom? Thank you very much for your
Thank you.
testimony. Second up, we have Commissioner Deirdre Gifford from the Office of Health Strategies and Kelly Cinco from Office of Health Strategies.
Good afternoon, Representative Wood, Senator Cabrera, Senator Wong, Representative Pavlik D'Amato, and distinguished members of the Insurance and Real Estate Committee. Thank you for the opportunity to testify in support of Governor's Bill 983, an act limiting anti-competitive healthcare practices. I'm Deirdre Gifford, Executive Director of the Office of Health Strategy, and I'm joined by my colleague, Kelly Cinco, our Director of Innovation at OHS. The reason why the governor has proposed this bill and others in this session is because he believes that the time has come for concrete action on healthcare affordability. Its impact to the residents of Connecticut is stark. You may be aware that in 2022, a survey of Connecticut residents indicated that half of our residents reported a burden of healthcare costs in the last year. And nearly 4 in 5 Connecticut residents are worried about their ability to afford healthcare now or in the future. In a recent Gallup poll that was nationwide, Gallup cited the highest percentage of Americans ever who were avoiding needed care because of concerns about cost. Furthermore, we know that people of color and people impacted by disabling healthcare conditions are disproportionately impacted by issues of affordability. You all know as well as I do that businesses, small and large, are constantly concerned about their ability to afford healthcare for their employees and their ability to provide high quality, affordable care for their employees. In the United States, we spend over twice as much per person on healthcare as other developed countries. And unfortunately, these other countries often have better healthcare outcomes, better maternal mortality and infant mortality, better life expectancy, better chronic disease outcomes and management. Medical debt is now the #1 cause of personal bankruptcy in the United States. Think of that. Healthcare costs are driving people into bankruptcy with all of the physical and emotional stress that goes with that. So the governor is proposing these bills to start to tackle healthcare costs in Connecticut from multiple different directions. Bill 983 contains 2 proposals that will begin to address issues of healthcare costs. Specifically, the bill proposes market reforms that enhance competition, encourage innovation, and reduce costs. The governor is proposing to limit out-of-network costs for inpatient and outpatient hospital services to 100% of Medicare. And in addition, to prohibit the use of some anti-competitive contracting terms that can impede competition, leading to higher prices. Sections 1 and 2 of the bill are based on, as you mentioned, the NASHB model legislation, specifically targeting 3 types of anti-competitive contract language: anti-tiering clauses, anti-steering clauses, all or nothing clauses, make that 4 types, and gag clauses in contracts between healthcare providers and insurers. Section 3 of the bill, also based on a NASHB model legislation, would limit out-of-network provider rates with the assumption and based on modeling and some evidence that a fixed and reasonable out-of-network rate can accomplish several things. One, of course, it would bring down the cost of out-of-network care for consumers and insurers and employers. Second, it encourages providers to stay in network so that there are broader networks available for people in that insurance plan. And third, it has the impact of actually lowering in-network costs because it levels the playing field a little bit more between insurers and providers in the contract negotiation. In order to implement these provisions, the governor's budget proposes 5 new staff for the Office of Healthcare Strategy that would work on oversight, particularly on the out-of-network costs. And you brought up the question of the No Surprises Act and the overlap. We are, as Jared mentioned, we are working closely with CID to ensure that the bill language proposed here would not be in conflict. So far, we think that the 2 are complementary, but we want to continue to analyze that question. So in closing, we respectfully request the committee's support for Governor's Bill 983, and we look forward to working with all the parties involved to craft the best possible version of these concepts. Thank you very much.
Thank you so much for that testimony. I wanted to I was reviewing some of the testimony in opposition of 983, and some of it had to do with transparency regarding the tiering. And I was just wondering if you had any comments on that. Some of the comments were requiring payers to be transparent with the standards that are being used to adopt the different slotting into the tiers and having CID, audit that process. I was wondering if you had any comments on that.
Well, I'm not sure if the comments were in favor or opposing that kind of transparency.
They were looking for more transparency, so that the suggestion was to have a little more transparency allowed in that tiering process.
I see. Well, I think it's worthy of further conversation. It's certainly challenging for a provider who has been placed maybe in a not favored tier and not be able to understand because of proprietary methodologies, not being able to understand what they could do or have done to be included in another tier. So certainly I think it's an important conversation to have, and both consumers, employers, and the providers who are impacted should really be able to understand and evaluate how that tiering happens.
And then just for those regarding the out-of-network capping, can you just talk to the committee about guaranteeing continuation of care? This wouldn't limit someone that was, say, within a network that needed to get out of network care. What if they needed that? How do we continue to make sure that they are still able to get the services that they need?
A couple of things. First of all, as I mentioned, we think, and the evidence suggests that this proposal would actually increase the likelihood of providers remaining in network. So it would broaden the availability of providers in network for insurance products. But in the event that an individual needed to seek out of network care, this would actually make that more affordable by capping the amount that could be charged for that out of network care. Right now, sometimes we see prices in the range of 400 or 500% of Medicare being charged for out of network services. By capping those costs, consumers and providers would have a more predictable way of knowing how much that out-of-network care would cost. Does that answer your question, Representative?
Yeah, I'm just, do you think a provider would be hesitant to taking someone because they're out of network?
Well, you brought up the target cost of the out-of-network cap, and I do think that's a conversation that needs to be ongoing. We need to make sure that the prices are sufficient to ensure that individuals are willing to, that out-of-network providers are willing to see individuals that aren't in their network, but also that we don't see the exorbitant out-of-network prices that we're seeing now.
Great, thank you. Any questions from the committee? Representative Meskers.
It's as much a question and a comment, because I believe the issue on debt forgiveness on medical debt was also broached in our Finance, Revenue and Bonding Committee meeting. And I just want to express reservations on two aspects of that is I want to make sure that we validate the bills, that the bills are accurate and reflective of services provided, because there's a jumble that you always hear with the insurance companies in terms of processing bills for debt that's unpaid and unclaimed. And the second thing is there's got to be a certain amount of discretion and management of the process. I've worked in the markets for a long time, and the minute there's an opportunity to retire debt at the government's dollar, that the value of the debt tends to go up before the purchase and it's extinguished. So I'm going to be looking very closely at the legislation in terms of the competitive nature, so that we maximize the tax dollar, maximize the amount of debt that is purchased and retired for these poor individuals, and that we also made work to exclude whatever we think is ineligible or unacceptable debt, because I think we have to make sure that the claims are valid. Because at that point we have a trust issue with our constituents about using the dollars wisely. I think it's a good public policy issue, but there's a lot of people involved in this that are not, how shall I say, angels. So I want to make sure that we have the right process there. And I haven't seen the details yet to feel very comfortable.
Thank you, Representative Meskers. We will pass that feedback along and make sure that it's incorporated as this rolls out. As you may remember, that the implementation of that program will rest with the Office of Policy and Management. So Kelly and I will be sure that we're sharing your concerns.
And I would love that to bring in as whether we can find a paid or free consultant of people who deal in distressed debt and defaulted debt. There are agencies that collect it and package it and the algorithms they use, because I want to maximize the benefit if we embark on this endeavor. Okay.
Thank you.
Thanks.
Senator Wong.
Thank you, Madam Chair. Good to see you. I keep on wanting to call you Commissioner. I'll keep on doing that. Can you share with me in regards to the out-of-network restrictions for both our hospitals and out-of-network physicians? That seems to be the push in regards to the challenge of reducing cost. I know that, but what are the justifications for that? And do you have the data points to quantify that this would be a substantial reduction in cost? Is there abuses in that?
So Kelly has done a lot of research on this, and I will ask her to supplement my response. But there is evidence, Senator. First of all, we know that out-of-network charges can be very, very high. And there is not always a strong incentive for a large provider in particular to remain in network because the option of remaining out of network and not having caps on what could be charged makes it an unlevel playing field between the insurer and the provider when they're negotiating. So having a reasonable cap on out-of-network costs provides more incentive for large providers to remain in network, because there's not as much of a financial incentive for them to go outside of network. That's one thing. The second thing that's been learned is that somewhat paradoxically, or maybe not, or unexpectedly, It also can help drive down in-network prices because of this same leveling up the playing field phenomenon. And third, and importantly, it saves money for the consumer who may have higher out-of-pocket costs when they see an out-of-network provider. So there is evidence from Medicare Advantage that this type of a cap can save dollars. And we think that it could have a real impact both on in-network prices and participation. Do you have anything to add, Kelly?
Yes, thank you. Kelly Cinco, Director of Healthcare Innovation, Office of Health Strategy. In addition to the Medicare Advantage evidence that Commissioner Gifford just referenced, there's also a RAND study done at 3 different levels. If there was one, if the cap was at 125% of Medicare, even higher, 200% of Medicare, or even at the state's current average payments, it showed that there would actually be savings if you did out-of-network cap on the in-network end. And the only other state that's really done something like this is Oregon in their state employee health plan. And they actually estimate that their savings was about 59 million in 2020. So we do have some evidence, and I'm happy to forward that along to you, Senator Wong, if you'd like to look a little deeper into that.
I appreciate that, and I actually did start reading the RAND report. But my counter to that, to 2 points on that, for the physician side and the hospital side. And the hospital side, one of the challenges is you talked about the 200+%, but it's also a reflection of the very low rate of reimbursement of Medicare in the state of Connecticut. What do you say to that? That is there any consideration to increasing Medicare reimbursements? Because we're looking at that 250% margin that you said, but how does our Medicare reimbursement rate compare to other parts of the country? Is it par or is it below?
Senator, just to clarify, are you referencing Medicaid, our Husky reimbursement rates?
Medicare, yes, ma'am.
Medicare. Okay. So
Medicare.
Medicare reimbursements are, they are adjusted for state-specific factors, but those rates are set nationally for the entire country. So based on some adjustment factors like for cost of living and cost of labor, Connecticut's Medicare rates might differ slightly than other states, but in general, there's a federal commission that makes recommendations to the Center for Medicare and Medicaid Services, and they annually set hospital rates for Medicare. In addition, Medicare Advantage, which is 30 to 40% of the market, which is a private option of Medicare, as you know, they may have slightly different rates than traditional fee-for-service Medicare, and those are privately negotiated between the MA plans and the providers.
Is there any flexibility, even if the rates are set by the federal government on the formula? Is there any consideration as this gets implemented, if it does get implemented, is there any flexibility from the state side to adapt our Medicare reimbursement?
I think as we have mentioned, and as you heard from CID, the bill proposes 100% of Medicare as a starting cap on out-of-network costs. Kelly referenced a couple of studies that use different levels, and I think we certainly should continue the conversation about where the appropriate level of cap is set with respect to the Medicare prices.
Thank you for the answer on the hospital side, but on the physician side, you're still looking at the cap out of network as well. Look, COVID has wrought such challenges, but one of the things we've seen is we have shortages of physician providers. What you're kind of creating is this capping system. Are we worried that this would drive physicians out of our state that would go elsewhere? Number two, and what about the possibility of physicians going into a concierge system? Some of the more talented, more qualified, or more specific expertise can say, I don't want to participate in this out-of-network capping. I'll go concierge and I'll still have a steady base of fee-for-service type of work. Has your consideration contemplated that in the impact of an already shortage of physician providers that would rather than comply, walk out of our state or not provide the services that are necessary.
Kelly, do you want to comment on what is and is not included in the out-of-network caps?
Yes, so where the out-of-network cost caps are going to apply to is for inpatient and outpatient hospital services. So it's only limited to those hospital services. If that's helpful.
And Senator, with respect to, the question of physicians opting, not to participate, I think that goes to actually the incentives that are maybe misaligned in the current system, where there may be incentives for providers to stay out of network because of the potential financial benefits. And what this proposal contemplates is that the in-network rates will become more attractive for providers to want to stay in network, which will benefit both consumers who have a broader network of providers in their insurance product, and the providers who would have a in-network rate that was negotiated and clear, and they wouldn't be dependent on out-of-network non-standardized rates.
Thank you for that answer, and thank you for your time. I know the governor's proposal is an attempt to address affordability. It's a work in progress, and I appreciate your hard work and look forward to continuing to work with you on this issue. Thank you.
Thank you, Senator.
Any other questions? Thank you very much. Senator Anwar.
Thank you so much for your testimony, Doctor. So just wanted to ask on the same line as Senator Wong was speaking of. We touched on this briefly today. If the insurance industry is having a conversation with a group, a medical group or a hospital group, and they know that by law, as proposed, there is no opportunity to have a downside for them because out of network would be resulting in a Medicare level of payment. There's no incentive for them to come to the table. And that creates an uneven opportunity for negotiations of contracts. And they do not come to the table. Every year you get a letter from one insurance company or the other. How do we see that consequence? I don't know if it's intended consequence or unintended from the governor's bill, but would love to see how we can overcome that challenge.
Thank you, Senator. It is an important consideration. As Kelly mentioned, the bill is limited to hospital services. So that's one thing. It wouldn't be to the extent that the physician service is not affiliated with a hospital, it wouldn't be impacted by this out-of-network cap. That's the first thing to remember. The second thing is that there is imbalance now in the system of negotiating between highly consolidated and large provider networks and insurance companies who are faced with the threat of a provider not remaining in network and making it very difficult to come to agreement. So the goal here is to find the sweet spot in balancing and leveling that playing field, which we agree is an important part of the conversation. But it's not as if the situation that exists now where the power is concentrated in one party is ideal, because we know that that's driving up costs. So what the intent of this legislation is to level that playing field and make sure that there is not excessive incentive to remain out of network, nor is there, as you're pointing out, incentive to not offer adequate reimbursement to the provider network, such that the network is not adequate. To that point, there are network adequacy, as you know, network adequacy requirements of health plans. So it's not as if they can walk away from large, important provider groups and say, well, we're going to just keep you out of network. That's important to remember, that they have requirements on network adequacy that will also play into these conversations.
Thank you so much.
You're welcome.
Thank you, Madam Chair.
Thank you, Dr. Gifford. Thank you, Kelly Cinco, for joining us.
I'm sorry, Madam Chair. Representative Nuccio has her hand up online.
Representative Nuccio, you're on.
Thank you very much. And thank you, Commissioner, for coming and testifying on behalf of this bill. I've been a legislator now. This is my third year. And the one thing that I keep saying is either we're going to get serious about healthcare costs or we're not. So I am grateful for the governor's bill here because I think the governor has recognized that the all-payer claims database and the benchmarking and the tools that have been put in place are showing exactly what you're talking about here. There is an imbalance. People like to paint the insurance companies as the devil in the room, but the imbalance is definitely with these large hospitals, and the negotiating power is in their hands. So we're seeing higher instances of care and lower instances of care and higher cost for that lower instances of care. I've asked for us to review the CON of these organizations and make sure that they're actually meeting the requirements that they said they were going to meet when they combined. This here is very important. In being in the industry for 20-something years, there are out-of-network providers, especially in the hospital arenas, that are getting 400 times the Medicare cost, or 400 times the cost that Medicare pays. This does absolutely get to the expense of healthcare, which then translates to the expense of insurance. So I agree with everything that you said pretty much there, that the threat from these large providers, especially when they go out of network, there is no negotiating power. And if we were to put some sort of caps on the amount that they could be reimbursed, it would absolutely encourage them to be in network where they have more negotiating power than they do if the amount that they can charge is capped. There's reasonable and customary, there's percent of Medicare, there's so many different formulas that are used to try to make a deal with somebody who's out of network when they're providing services. And I like that you guys are starting small and looking at the large providers. They definitely have the most amount of negotiating power. And as we've seen with consolidation of hospitals, they're gathering all the physicians under their groups, which then loops those physicians also into that negotiating power. I don't think we're going to see a mass exodus of people here because, as you mentioned, there's network adequacy. There's all kinds of different pieces that come into play with maintaining a good, healthy network. And this just puts the power back a little bit into the hands of the consumers here by not having an unregulated, you can charge anything you want because you stay out of network. And it also shifts that power back to a negotiation point. So I'm happy to see this bill come forward. I'm supportive of this bill. I think, as I've said before, I just want to thank you and your team for doing this work. Either we get serious about the cost of healthcare, and that's the cost of how much it costs to go see a doctor or how much it costs for an aspirin in a hospital, or how much it costs to actually receive those services, or we're just going to continue to see these increases. So I'm looking forward to the information that you have there. Please send that over so I can review it also. But overall, I just wanted to thank your team for doing this work and bringing forward this bill. And I look forward to working with you on it.
Thank you, Representative.
Thank you, Senator Anwar.
Thank you so much, Madam Chair. I just want to make a comment. It's more of a broader comment. It's not specific to you, Dr. Gifford. Almost 100 years ago, there was a pandemic. And then what came out of that pandemic was that we set up one of the most, the best healthcare systems and hospital systems in the world. That served as a backbone for our healthcare at that time, and legislators around that time, they were focused on making sure that the hospitals would survive and thrive, be able to serve as a backbone if should there be a disaster of any kind. This pandemic has shown that the hospitals continue to serve as that backbone. And prior to the pandemic, they were having difficulty surviving and financially, because we have evidence that smaller hospitals could not survive. It was not out of the love that they actually were bought by somebody else. They had no choice, but they actually had to be bought because The economy of scales was a reason they had to be bought by somebody else. And that was the prime reason. No hospital ever was very happy to say, we don't want to function in independent manner. The ones who are independent, they would love to be independent. What this pandemic has done is that it's highlighted that the hospital systems have been struggling, except for maybe the large ones. But we have to make sure that we don't hurt the backbone of the healthcare system. And then, because if we do, going back and fixing it would not take a few years, it would take decades. So I just want to make sure that there are going to be unintended consequences of some of the policies. And if you look at the bottom line of what's the financial status of many of the hospital systems, it's not as exciting as some of the other industries do have. They don't have that much of a capacity to take more punches, if you will. So I just wanted to put that out there, just as we think that there are going to be some consequences of what we decide. Thank you.
Senator, thank you. And very important points that you are making. The governor and I have both been very clear that this problem is very complicated and is going to require lots of different approaches to solve it. And it's going to take everyone coming to the table, including hospitals, but not only hospitals. And that that either, we are part of the solution or we're part of the problem. I believe that vilifying a party is not going to get us progress. We need to work on this collaboratively. But the goal is addressing the very serious concerns in affordability that I started my comments with. And I think that's something that we can all agree to. The reason why the governor is starting with these particular proposals is because of the work that my predecessor and Vicki Veltri and Kelly and others have done on the cost growth benchmark, which shows that the three largest contributors to rising healthcare costs in Connecticut are drug costs, hospital inpatient, and hospital outpatient. So as I said, we won't be able to tackle our increasing healthcare costs in Connecticut if we don't tackle those challenges. But I also agree with you that we have to take a multi-pronged approach, and we have to all work together collaboratively. Every party in the healthcare ecosystem or environment needs to be part of the solution.
Thank you, Dr. Gifford. Thank you.
Thank you both for your time today. Next up, we have Julie Vasile, or Vasile. Sorry if I didn't say your name correctly. Is Julie?
Hi, Julie Vasile. Thank you. Good afternoon. Thank you for allowing me to testify in strong opposition to SB 983 because of the detrimental impact requiring out-of-network physicians to accept Medicare rates would have on my practice, and the net harm this would result in patient access to highly specialized reconstructive surgery. I live in Connecticut. My practice is in Stamford, Connecticut. It's 100% breast reconstruction for women with breast cancer or at elevated risk for developing breast cancer. I'm a minority, women-owned small business in Connecticut that employs 3 single mothers who are the sole providers for their families. I specialize in perforated flaps, which is a type of breast reconstruction that transplants a woman's own fat to her breast to achieve the most natural, longest lasting, and least long-term complication type of reconstruction. It requires a delicate dissection to carefully separate small vessels from the muscle, and then to connect those vessels under a microscope to different vessels in the chest to establish a new blood flow circuit that keeps the transplanted fat alive. I offer the absolute latest in surgical technique, and I take on complicated women that could not be reconstructed by any other reconstructive surgeon. Women who were disfigured or suffering with non-healing wounds and radiated scarred tissue. I have continued to advance this highly specialized surgical field, and I did, to my knowledge, the first in the world combination of a buttock with upper back perforated flap in women who had no other option for reconstruction. These complicated patients take a lot more time to do. It's really time consuming. It takes me several hours to plan the whole day and evening in the operating room, multiple days in the hospital in which I have to be available to return immediately to do a reconnection of a blood vessel, and then weeks follow up as I monitor for complications and healing. The surgeries are intense. It requires all my concentration and is inadequately compensated with a Medicare fee schedule, which reimburses $2,749. Unlike other smaller surgeries, I cannot try to do more volume and schedule more of these surgeries in one day. I would not even schedule a complicated case the following day. If this bill passes, I would have to just stop doing these highly specialized breast reconstruction cases because I wouldn't be able to support my practice, the rent, and the staff. I would shift all my patients to New York for reconstruction. If I maintained a presence in Connecticut, it would be for breast cosmetic surgery. This provision to require out-of-network surgeons to accept a Medicare rate is not in keeping with your intent, which is to protect patients. It'll result in women having actually less access to the highest quality care as physicians gravitate towards procedures that are less complicated, shorter, and or shift their practice away from reconstruction. I also question the legality of a provision that requires an independent professional to accept a specific payment amount. The government does not require any other profession that also provides necessary services to accept a specific fee for their work.
Julie, I'm
always-
sorry to interrupt, but your 3 minutes of eclipse, please summarize.
I've always believed that I could make the most impact on the health of women by offering the best options for breast reconstruction. I would like to have Connecticut women continue to have these options within the state of Connecticut. Thank you for allowing me the time to present.
Thank you, Julie. We do want to ask some questions. I thought that the clarification to Dr. Gifford was that this was for it wouldn't be for the small practices, but I'd love to further dive into that and try to clarify those parts in the governor's bill. We do have a question from Senator Anwar.
Thank you so much, Madam Chair. I have two questions. One is I just wanted to have you finish your testimony, but I also wanted to ask you, I've received messages from people who are breast reconstruction surgeons in Connecticut who are speaking about Cigna dropping the transverse rectus abdominis flap surgery for breast reconstruction. Have you heard anything about that? So they're saying that they will not cover breast reconstruction surgery for women in our state. And then if you can speak to that, but also finish your testimony too. And thank you so much for coming today.
Thank you for allowing me to speak. I'm sorry, I have not heard that specific thing that Cigna would be dropping the trans rectus abdominis perforated flap breast reconstruction coverage. It really goes against really the federal law that's supposed to allow women the option and the choice to choose the type of breast reconstruction that are best for them. And removing access for women to have the surgery within the state of Connecticut, it means that women either have to travel across state lines, and that's not always possible for women. Women have to work too, they have to take care of their families. And for some of them, it would just not be possible to get the care that they really need and they deserve.
Thank you so much. And my second question was, I think you were in the midst of finishing your testimony. If you would not mind finishing that too, please.
Oh, I think I presented the main points. Thank you, though.
Any other questions? Julie, thank you for your testimony. Next up, we have Ted Doolittle from the Office of Healthcare Advocate.
Thank you, Representative Wood and other honored members of the committee for the opportunity to testify today. My name is Ted Doolittle. I'm the head of the State Office of the Healthcare Advocate. And for those of you who don't know, the Office of the Healthcare Advocate is this independent state agency. We're not part of the gubernatorial administration. And we have a team of nurses, attorneys, paralegals, and others who can help people who are fighting with their health coverage. It can be Medicare, Medicaid, or commercial If you have a simple problem like trying to get the billing address changed for your health premium bills on up to a very complex trying to get an experimental cancer treatment covered, we have case managers who can help you. Please don't worry alone. Call us up. And I know the members of this committee are good colleagues and partners with my office, and in many cases have referred many cases to us, but I wanted to make sure people knew about our office. We had the honor in this building in December, and then again this month hosting a session, 2 forums focused on the healthcare cost prices and spending crisis in this state. And one of the messages that came through clearly from the national experts and the local industry experts that we were able to have is that the issue is medical prices. The premiums don't go up magically on their own. They're driven by high prices. Your high deductibles are again driven by the actual prices for specific care. And as Director Gifford laid out, that comes down to, in many cases, hospital inpatient and outpatient and drugs. So I've been the healthcare advocate for almost 6 years, and I've been trying to focus this state on the affordability crisis. It is so wonderful to have some of these bills here. And I'm going to first comment briefly on Senate Bill 983, and I'll address my comments as well to 6620, which is a somewhat of a parallel similar bill. First off, let me just say that any reform that purports to address the spending crisis, we know from the scholarship that was presented at the forums, there is no reform that doesn't deal with the actual underlying prices. And with respect to Senate Bill number 983 and 6620, folks, the cavalry has arrived. These bills are price bills. And whenever you're looking at a bill, you should look how closely focused on the underlying medical prices is it. This really hits the ball out of the park. And I have to give so much credit to the governor's team, including Johnny Dack, Director Gifford, and the Governor Lamont and Bicewicz as well, to have this type of strong bill. I won't go through the provisions, but to hit on a few, this is a bill focused on anti-competitive practices that the hospitals have engaged in because of their large market power. We are a highly concentrated state, other states are, but we're among the highly concentrated states. And we find, and it was exposed at the forum, that the even large purchasers like the state of Connecticut employee and retiree plan, even large carriers simply can't negotiate internationally normal prices with the large systems. And that's what this is addressed toward. So big kudos to the folks behind these bills. A couple of specific things I wanted to mention. First, I think this references just HB 6620. That has a provision where the insurance commissioner could waive some of these protections. We don't think that's called for. 983 doesn't have it, and you should keep all of the providers who are potentially affected inside the ambit of this bill. Secondly, to build on some of the comments that Director Gifford and Kelly Cinco made earlier with respect to Section 3 of SB 983, that's the out-of-network caps provision. This doesn't come out of thin air, as Director Gifford mentioned. This has been operating at scale in the Medicare arena, where, believe it or not, the very same companies that have to charge, that have to pay rather 200 or 300% of Medicare, their Medicare Advantage.
So it doesn't sound like we are going to.
You're fine. You can continue.
The Medicare Advantage plans pay very close to the actual underlying Medicare rate. And that's because they have this exact type of out-of-network cap. And so it works well, and we can talk about it more. And in terms of the actual numeric value of the cap, 100%. Other states have similar things with different caps. We can talk about that, but I think the really exciting development is to get that type of price justification installed in Connecticut. Every other wealthy country, every other country that has high quality healthcare, and this came out of the forum, has some type of price justification. I don't call it price setting because sometimes medical care is very expensive, such as the doctor who was just on. Some things are very expensive and we should pay expensive rates for the right procedures, but we need to understand that it's justified and it needs to be discussed in a public forum. So three cheers for SB 983 and also 6620. I wanted to talk about one other bill, 6710. That's the Act Concerning Association Health Plans. This is not a price bill. If you look through it, you don't see a link to the underlying medical prices. I have a nuanced position on this bill. I hope we can come to an additional choice that would be beneficial for the businesses of Connecticut. But I do have concerns about the underwriting, medical underwriting aspects of it. And for those who don't know, medical underwriting is essentially health insurance speak for discrimination based on your health condition, whether at the start before you enroll or during the policy period. At the end of the period, if a small group has a family has a baby that gets sick or escalates in price, the premium for the next year could, under the way this bill is currently written, be much higher. So I think I want this choice for Connecticut businesses, but I think we need to work on things like making sure that the folks aren't going to get kicked off the plans as soon as they get sick and right when they need it. For instance, and I must commend CBIA, the Connecticut Business and Industry Association, for their dialogue with my office. I have suggested potential improvements to them, such as making it so that the term of the policies is not just 1 year, because if you have a 1-year policy and somebody's baby gets sick at the 9-month mark, you're going to have 3 months of insurance, and then you're going to have your rates go up and probably have to go back on the exchange. If it was a 3-year plan, that same family would have a couple more years in the plan. So there are ways, is what I'm saying, to improve this bill and make it a real addition. I also, as I mentioned, it's not a price bill. It could be. You could add some type of reference pricing to this bill. That again, I have a nuanced position here. I'm not opposed to it at all, but I want to make sure that it really adds to the products that are out there right now. So I did want to comment on that. Those are the bills that I wanted to comment on there before you today. And I just want to, again, commend this committee and the governor's team, especially on Senate Bill 983 and House Bill 6620. I'm available now or in the future to answer any questions the committee might have. Thank you.
Thank you so much for your testimony today. And we definitely hear your concerns on the association health plans. This is a first draft of the bill, and we will be making improvements to it, and having your office provide those solutions is really important to those of us on the committee that are working through this. So we appreciate you working with us on it. Any questions from the committee? Senator Anwar, followed by Senator Lesser.
Thank you so much, Madam Chair. Thank you so much for your testimony, and thank you for all the work that your office does. You guys are doing some amazing work. We truly appreciate it. I just wanted to ask you, you made a comment that other states are doing this. My understanding is no other state has a 100% cap.
That could be true. I was talking more globally about using reference prices, which means a target price that cannot be exceeded in terms of reimbursement. In terms of the numerical value, I think you're probably right.
And so if let's say this was an experiment, it's a very dangerous experiment because it's not shown to be effective in any other place on the impact. The reason also is that we know that Medicaid payments are barely minimal, if at all. And Medicare payments are also not even
Yeah.
making it for them. And the commercial are the only survival options for some of the institutions. And if we remove the commercial component out of the picture, it will have significant financial consequences if you do the math. And in some of the communities which many of the healthcare systems serve, Medicaid is a pretty large population, and with our aging population, Medicare is a very large component as well. And the margins are very minimal in the commercial. If that goes away, we have the smaller hospital systems die. We can't have the bigger ones be negatively impacted. And they are also the largest employers in the communities that they serve. So I just want to make sure that we just think this through. Because the downside is quite significant if we don't think this through.
So Senator Anwar, I appreciate your comments. Everything you say is true. I will add, we know, everybody in this room knows, everybody at home knows, the commercial prices are too high. The commercial prices are too high. And with respect to getting it right, that's why I never use, and you should not use, in my view, the term price caps or price setting. It's price justification, right? It's what it takes to have the hospitals thrive, but also to give the state and the people of the state, more importantly, and the businesses of the state, the first ever chance to try to have an impact on that discussion. Because right now, the discussion is between the commercial carriers and the hospitals and the drug companies, and that is no conversation at all, as came out very well in the forum. The small hospitals get told what the prices are by the carriers, and the big hospitals tell the carriers what the price is, and there's nobody in the middle that actually can negotiate well. And that's what this bill tries to rectify.
Thank you so much, Madam Chair. Thank you so much for your testimony. And again, thank you for the work your office does.
You're welcome. Thank you.
Senator Lesser.
Thank you, Madam Chair. Thank you, Mr. Doolittle, for your testimony. It's good to see you here today. I've got some questions about the association health plan bill. We did receive some testimony from a number of parties with concerns about adverse selection. I didn't know if you had any comments on that.
Yes, that is a concern. So what can happen is that if a family unfortunately has an illness or gets sick mid-year, the premium goes up the next year. They can't get back on the plan. They will then get their insurance from the Obamacare Exchange, ACA plan. We call it Access Health CT in Connecticut. So what you wind up with is the healthier families stay in the association health plans, and healthier families are cheaper to insure, and the sicker families get shunted over to Access Health, and they're more expensive to insure. So that's what they call adverse selection.
Isn't that the point of the association health plan idea, right? There are other things we can talk about in terms of putting consumer protections in there, but that specific adverse selection idea is what the proponents are, as I understand it, looking for. Is that?
You know, I wouldn't characterize it that way, but what you said is not unfair. I think it's a fair way to characterize it.
So just to be crystal clear, what we're talking about is cherry picking lower cost risk and leaving a potential.
If it's not properly designed, that could be the result. Yes.
Is another word for that adverse selection issue a death spiral?
People do say death spiral. Yeah. When the sick people get sicker and more expensive and get herded into a smaller and smaller group, then it becomes financially impossible to insure that population.
One last question. Did I understand from your testimony that the current language of the bill allows pre-existing condition discrimination?
It allows medical underwriting. That's, at least that's my understanding. I stand to be corrected, but my reading of the bill is that it allows medical underwriting, which means that they can charge you a healthy group a different premium than an unhealthy group.
Thank you, Madam Chair. No more questions.
Senator Wong.
Thank you, Madam Chair, and thank you, Mr. Doolittle, for the good work that you do in the Office of Healthcare Advocate. I appreciate your testimony that you've written for 6620 and 983. Will you be submitting testimony on your comments on 6710?
Yes, we will. We've been hampered by the connectivity issues, but it should be, I hope, to you soon.
Great, thank you. So I heard you raise some questions, and I heard the Madam Chair comment that we would very much like to have you work with us. Maybe it's due to connectivity questions. Have you had a chance to read through the entire bill?
Yes.
Okay. And I think one of the questions that's critical for me, under the Affordable Care Act, there is no denial of pre-existing conditions. And I don't believe that this plan, I'm fairly certain, has no pre-existing condition declines. So I think what was said earlier was kind of leading to that there may be, quote, cherry picking, but I wanted to have you an opportunity to clarify that, because the Association Health Plan, as it's written, does not preclude any pre-existing condition exemption.
My understanding is that they would offer you the plan, but that you know, I don't know what the premium's going to be. The premium could be very, very high. That's my understanding. But you're absolutely right to make that clarification that they would not bar somebody based on that.
And you raise a second point that is interesting for me, is under this association plan as 6710, it does have to go through an audit process. It is a private plan handled by outside insurance companies, but it has to go through an audit review process through the Department of Insurance. Would that be correct?
Yes, and I don't understand. I don't, it's correct. There's a process. I don't understand what that process looks like or would be like in real practice. I don't know.
But it'd be governed by statutory guidelines and going through the Department of Insurance. Now, you offer testimony on 6620. It's kind of interesting. I agree, promoting competition, but I'm sure you also read the bill. There was one clear exception to the audit and review process, and that would be the partnership plan. So tell me, how would that be different? If you're concerned about where premiums may go and where the allocation of funding and how programs are functioning, in one step, you're supporting 6620 and exempting specific programs. And then under 6710, even though you don't know the numbers yet, you raise concern in regards to premium and potential jumps. But I feel the comfort on 6710 because there is a clear and professional audit process that is conducted by the Department of Insurance, whereas other plans do not have such a program. And I wasn't sure if you picked that out in your support of 6620 with that exemption.
So in terms of 6620, I appreciate your comments about the partnership audit exemption. I haven't dug deeply into that one to give you a comment. Overall, I think it's a great bill, and maybe there can be some again, some amendments, and we suggest some in our testimony. So I'm not here to defend every single nook and cranny of the bill, but the approach is sound.
And I appreciate that. And you've been a tremendous advocate, as so many of the advocates are, in transparency and accountability. And every single product that is an insurance product in the state of Connecticut runs through a professional audit process by our valued Department of Insurance. But it seems surprising to me that you would allow an exemption of a transparency and a professional audit process on a significant plan.
Mhm.
And you kind of said it's an exemption. And that to me is a significant cost factor, and the allowance that it's not an insurance plan and there is an appropriate process, but I'm looking for an approval and a professional audit process. I would hope that you advocating for transparency and respectful for every dollar that's spent related to healthcare would support such an audit process. And I hope you would reconsider that and offer your weighted expertise in matters related to health insurance by the panels that you've held, that the simple rule should be transparency, accountability, and a professional audit process for all programs.
Agree with the thrust of your comments. I will say that my office is independent of the gubernatorial administration. 983 is not our bill, so to speak. I'm here supporting it as an independent advocate. So in terms of the questions you raise, they should be addressed. My office isn't in a position to give you a definitive defense or explanation of what is and is not in the four corners of the bill.
And I appreciate that. I appreciate the good work, as I mentioned earlier, that your office does in advocating for proper patient care. And I'm hopeful that you'll work with us on 6710. But also, I hope that you will be consistent and support a professional audit review process for every single dollar that's spent, and making sure that we maximize the quality care that's necessary, but also respect every dollar.
Yeah.
Without an audit process, we don't have that on a clear transparency. And you've been such a champion of transparency. And I hope that you will side with the people that are looking for audits of every potential health insurance program that's provided and impacting people's lives and costing taxpayers money. I hope you'll come around and jump on board and be fully supportive of an audit process for every insurance plan. So thank you, Madam Chair.
Yeah. Let me just state that, my office is excited about the overall bill. And I take your comments to heart. I appreciate them and appreciate your expertise and your passion for affordable healthcare, which I share with you. I will say that my staff and I have not borne down on that particular aspect of the bill, but I pledge to you that we will, and we will get back in touch with you when we complete our review, which again is going to be, although we are the state healthcare advocate, we're independent of and different from the gubernatorial administration.
Representative Meskers.
So I want to speak to two aspects of your commentary today. Basically, and in preference in plainer English for me and for my constituents. Your objections or concerns related to the group plans are concerns, the association plans are essentially about potential of bias or continuity of a renewal of policies. So you're going to be looking to see in the language that people who form an association and buy policies have an adequate ability to remain within the policies regardless of their future medical condition, right? You want to make sure people aren't kicked out of an association.
Yes, I would want to be satisfied that this was not a temporary health plan for healthy families that then were not able to continue with it.
Right. So you'd be looking, if I think about it conceptually, associations of firefighters, well, they're municipals, they're insured, but the equivalent of someone who's jumping off buildings versus someone who's an association of candy store operators, presumably they would be used on a medical assessment of the risk factors of a profession in some level, and that the association risks and the weightings would give them basically a pool and ultimately cheaper insurance than if a 10 or 15 person group were to buy a policy. I mean, that's essentially when we talk about pooling of risk, what we're looking at doing is at some level, smoothing the risk profile, reducing the insurance company's ability to price 5 people in 4 policies differently than the way they would assess the risk on 20 people in 1 policy, or in magnitudes, one group of 20 versus a group of 100. I mean, the pooling should overall lower the risk and the premium assessments because they're better able to measure the risk. Is that not what we're trying to achieve here, I think?
Couple comments. First, you mentioned a firefighters association. My understanding is that there could also be a much wider association. The Connecticut Business and Industry Association has a lot of different members from a lot of different industries, and so that could be an association health plan, right? So it might not be so niche.
Might not
is what
be
you're
as
saying.
niched on risk, but I'm
Right.
saying that broad risk will be covered by a larger pool of people. And if you were to segregate it out, the way I understand the math is that they charge a higher risk premium on smaller groups. And that's why association plans may offer, for the exact same quality of insurance, a lower price.
We want to make sure that that the risk of that the rates aren't set, or rather, one of my concerns is that the rates are set at the level of the employer member, so that a particular the Connecticut Association, whatever it might be, if I would rather see a community-wide rating system where one group of 5 would get the same premium as another group of 5, regardless of the particular characteristics of that group, whether it's age, whether it's medical condition. That would be a true pooling of the risk. My understanding of the bill as it's written is that the rates for for each individual firm, for each individual employer, are set separately. Okay, and that there's nothing wrong with that, so to speak, but that makes it very similar to the self-funded plans or level funded plans that are available to small businesses now. I would love for this to be a much more innovative solution rather than just a Tweedledum and Tweedledee versus what's already available in the marketplace.
So you wake me up to the process, which is that we need to focus on the pooling. We need to
Right.
look at the groups, and if they are of an adequate size to provide for a reduction in premiums, so that we have a large enough pool of a population in any one of the groups, right? In other words, if it's 5 firefighters or 500, presumably the risk factors and how you judge them are different when you can pool. So you're looking at either how the association does it or how the individual firms are priced within the pooling, because you want to make sure that the pooling reduces the cost. I mean, that's certainly our goal, is to reduce the cost,
Right.
right? So presumably your concern is about the nature of the pooling and the nature of the entry.
Right.
Okay.
As I say, it's easy now to charge more for a group that has more sick people, right?
Right.
I mean, and one of the beauties of the ACA, which is not a perfect piece of legislation, right? But it made it so that they could only vary the premiums based on either 2 or 3 factors. One was age and one was tobacco use. There might be a third one, but I think it's those 2. Other than that, Bob gets the same premium as Sally, that's in the individual market.
But that's the problem basically that we're facing.
That's the
That's
problem,
The group
right.
market, and that's what we're trying to address.
And what I'm saying is I would love to have the risk pool be as large as possible. And that's the best for the community of Connecticut. Now, that might not be the cheapest policy for that particular company in that particular year. And that's because the risk pool shrinks down to the one tiny company.
Well, I look forward to further conversation. And if I could
I
ask,
do too.
okay, if I could ask the chair for indulgence. My second question is about the observations that have come across about the hospitals and hospital care and costing. We've spoken in the past about medical insurance overall cost of healthcare in the United States versus any of the OECD countries. And could you at least, do you have any data, or from your memory, can you tell me more or less what hospital care in the US costs versus Switzerland or France or OECD or England or any of the other places you've looked at?
Yeah, I mean, there's going to be different, there's not one global answer to that. But generally speaking, if you're in a place like Germany or France, the care is going to be at least twice as much. And the interesting thing about that is Germany and France, if folks have ever visited there, I haven't recently, they're not cheap countries, right? But the medical care is half the price. So it's not.
You're saying the US is twice as much?
Yes,
Okay.
yes. The US is twice as much. The lowest sort of NATO or OECD country, I think, is Italy, and we're generally 3 times or more what Italy does.
And so then the point you were making when we look at the hospital industry is we have 3 major carriers, as I understand it, in Connecticut that own the hospital system in almost its entirety. So what you said to us, and so I want my constituents to understand, is that they are price makers, not price takers. So when the insurance company who sends me the bill that I love to yell at because they send me the bill, they are basically negotiating with one hand tied behind their back in terms of the prices that they get from the hospital system.
Yeah.
I mean, that's essentially the issue, right?
Yes. So there's what came out in the forum really nicely was there's 2 types of hospitals in Connecticut. There's the independent hospitals. For instance, Bristol, Kurt Barwis participated. They get told by the carriers what the price is. And then there's the large hospital systems, pick your brand name, and they tell the carriers what price they're going to pay. And there's no hospitals in the middle that have an even negotiation. So you're either getting bullied or doing the bullying, so to speak.
And so do you think the governor's bill helps to address both the bullies and the victims? Is my question.
I hope so. What I do know is that, our prices, which are 2 and 3 times the other OECD nations, it didn't always used to be that way. We were much more even in 1980. Something has gone wrong in our country in the past 40 years, where these other very high price countries, you go to get a latte in Paris, I'm assuming it's going to set you back $10 or something like that. You go and get a knee replacement, it's going to be half the cost that we pay here in Hartford. So it's not like it's a cheap country, but yet their healthcare is a much more manageable part of their gross domestic product.
Okay, thank you. No further questions.
Representative Nuccio.
Good afternoon, Ted. Thank you for coming. I have a question. I kind of want to dig in a little bit onto what Representative Meskers was just talking about. I so far I'm a fan of the AHP plan. I think it does something that we need, which is gives small businesses an opportunity to pool together to get better insurance policies and better rates. So when you mentioned it allows medical underwriting, I want to kind of get an idea, dig in a little bit on what you're talking about that, because as Representative Meskers mentioned, if we look right here in our own state at the partnership plan, that is a plan that is leveraging all of the state employees for town and municipal employees to create rates, to get negotiated rates for services. But then they, within that plan, have recently started, because they've been so insolvent for so long, they've started actually rating different municipalities that have higher costs higher within that. And I think that's fair, right? If they're continually higher cost, then we would want them to, them to kind of be paying their fair share of the healthcare cost, because the whole point of this is kind of conglomerating everybody, getting a better rate, and then monitoring the healthcare outcomes from that. So I'm wondering if you could kind of give a little bit more of what's super concerning about that in relation to just because that's kind of how the state's been doing it anyway. So just get a little bit more info from you if I can.
Sure. Thank you, Representative Nuccio. So I guess I would say that, you know, the issues on the partnership plan are very good data point. But to make a little slightly different point than what you drew from it, to me, it tells you that a large purchaser, the state of Connecticut, can't negotiate good rates. That's why they're retrenching on that. So I would say that this came out at the forum as well. Even as, you know, and the state of Connecticut, I believe, is the largest employer in the state.
They are, sir, they are.
If you listen carefully to the testimony that Mr. Wojcik, Josh Wojcik, gave at the forum, they're working on a lot of value-based proposals, which are terrific, and I support. But they did that after they found out that they couldn't budge the large systems on the underlying prices. So this was a fallback plan. And by the way, that very same comment was made by Lou John Quinto as well in the first forum. The local CEO of one of our health insurance plans, he made the same point, that they were all in on the value-based stuff because they couldn't negotiate good rates. So this was what they could try to accomplish. There's no way, the market is broken, and there's no way we're going to fix it without some type of partnership coming from the state. And I'm not saying that SB 983 is the only way to do that, but it is a way. It's a way forward. And we have to get into, again, price justification. You know, the fact that that the state of Connecticut can't negotiate better rates than a, you know, another smaller employer should be all the evidence we need to conclude that the market is broken and needs some type of public-private partnership.
So I understand what you're saying. And I agree, you know, the state of Connecticut being the largest employer in the entire state, and the negotiating power that I don't want to say them, right, that Anthem has on their behalf, it's evident. And I think that gets back to the governor's bill, the 6620, which just looks at the out of network cost, which is not even the biggest piece of it, but it is, you know, a substantial piece. So we're kind of like dancing around these bills kind of make sense to each other, but I'm really I'm looking for a way to make this associated health plans work, because when we have the small businesses able to kind of group together to get better rates, that's going to make small businesses more successful. It's going to reduce the cost of their doing business and their employee benefit costs that they have. So I'm really kind of trying to figure out, you know, if there's something here we have to really look at. I can say I don't know how I feel about the I wrote down allows medical underwriting, and put after it, you know, very similar to exactly what the partnership plan does. So I guess I'm just trying to see if there were something put in that said, for instance, I believe it's the partnership plan. It's like you're in for a penny, you're in for a pound. Once you commit to it, you have to stay in it for 3 years. You can't drop out of it without paying a massive fine. And then after that 3 years, you can get out of it. If there was some sort of clause put in there that kind of guaranteed if this one small business, I'm thinking, you know, it's a small business, 10 people, 2 people have NICU babies, that's going to spike their claim cost massively. And I can see what you're saying. If CBIA at that point was allowed to raise the rates of just that individual business, it might price them out. So how could you see this working in a way where we could still accomplish creating this association health plan that would be beneficial to the small businesses, but yet kind of ease your conscience a little bit on the underwriting piece of it? Because I still think that the underwriting piece of it should be allowed. I'm just trying to figure out how we get there.
Mm-hmm. Well, open to conversation, open to suggestions. The one I put forth, I think you alluded to, I'll mention again, is perhaps an opportunity to extend these out from being one-year plans to being multi-year plans. That would provide more protection for the families. What we're looking for, Representative Nuccio, in terms of satisfying the Office of the Healthcare Advocate to move from a nuanced position here to a supportive position, is some protections for the families, right? To make sure they're not whipsawed and don't have to come off of the plan on December 31st after the year that they get sick.
Okay. Well, I think I'm very interested in having those conversations because, as you know, I said, I'm very interested in this association health plan, and I think it's going to be a good thing for our small businesses, and I think it's also going to be a good thing for our overall market, and it will allow them to negotiate the cost of healthcare, which kind of leads me to my last little question here. You've mentioned a lot. We've asked a lot of questions, and you've mentioned a lot about the cost of care in other countries, and I want to kind of dig into that a little bit because I think it's the cost of care, right? We're getting back to the same exact dance that we're having over and over again is the cost of care. I don't think, doctors and hospitals specifically have the kind of revenue generating opportunity. They don't charge as much. So that's why the cost of care is low. Would you like to elaborate on that a little?
Excuse me, you're saying that the cost of care for individual providers is less than at the hospitals? I didn't quite.
And hospitals, like in these other countries, I think, we talk about the difference between how much healthcare costs in America and how much healthcare costs in Germany or Italy. And I think we overlook the word that it's cost, how much it costs. So what is the driver? Like, what can you kind of quantify what you think the driver is for why it's so different in those countries than it is here?
Yeah. There's I'm not the sort of healthcare economist scholar that can give you probably the best answer in the United States, but I do know, for instance, some of the easy answers that people look to. Oh, it must be that our doctors get paid more. Well, our doctors do get paid more. Some doctors get paid more, but that's not where the bulk of the difference is. There seems to be, Representative Nuccio, some type of embedded cost in the cost structure of the pharmaceutical industry and the hospital industry that has grown to be higher in our country than in other countries. And it's been going on for 40 years. So it's very tough. You can't turn this battleship around overnight. And I think we do have to be sensitive to that, right? If we're talking about a reference price, we want to make sure the cap is such that the businesses and the hospitals can remain vibrant care providers, vibrant employers, and all the rest of it. But the point is that let's try to make 2023 an inflection point, right? That's when the aircraft carriers started to turn.
I appreciate that, Ted. And I look forward to any information that you get. I'm with you on that. I think, our own all payer claim database shows that. I think across the board, we know where these costs are, and hopefully this year we're serious about actually starting to conquer it. So thank you for your testimony. I appreciate it. Thank you, Madam Chair.
Thank you, Representative. Senator Anwar.
Thank you, Mr. Chair. Thank you again. I wanted to just, Mr. Doolittle, run a few thoughts by you on the association health plans. And now, as the leader of the health advocate for our state, if I was to share information with you and say that if there was sound data to show that the association health plans are associated with selection and changing the risk profile of the community to just take the low risk individuals be part of the association, and the high risk individuals, including the minorities in the community, will be left on the sideline. As a result, there is going to be worsening of the existing healthcare disparities that we see in our state, which are the highest, one of the highest in the country, if not the highest. And if I was to also share with you the data and information that the American Academy of Actuaries say that this would cause that, And I also was to share data with you or information about the fact that these plans have resulted in defrauding millions of people across the country for millions of dollars and their health, and have destroyed healthcare systems. As a healthcare advocate, would you support this concept?
It depends how the bill's written, right? I mean, those are problems that need to be addressed. You're 100% right. And if they're not addressed, I would not find myself supportive of the ultimate legislation.
So you feel that the concept is okay, but you want to improve the concept, even though it has not necessarily been as effective, according to the people who have studied this and have looked at the concept is associated with changing the risk profiles and putting individuals who are in the minorities at a higher risk.
Yeah, that is a problem. That is a problem that we need to grapple with. It would be great if we could come up with an innovative plan. I would say that in terms of, I'm not an expert in how association health plans have played out in some other states, right? You're absolutely right that the history is very concerning, right? History is very concerning, and that's why you really need to study this bill very carefully, in my opinion, and you should not pull the trigger on it unless you are fully satisfied, and that may take some time for this committee to get comfortable with those answers.
Thank you for your answer. I appreciate that, and I think it's relevant because we already are in a pretty complex landscape to begin with health disparities, and if as a committee we come up with a solution which is associated with worsening what historically in the rest of the states, and we say, oh, well, in every other state it caused problems, so suddenly in Connecticut it's going to improve the problem in the state where the problem is one of the highest, doesn't sound like a very scientific way of solving the problem that we are dealing with as a state. So that's my perspective.
Yeah. So proponents of the bill, CBIA and others can probably be better positioned to answer, but I share your concerns, and those are the exact concerns that you should be looking for answers to.
And I just wanted to make a quick comment, Mr. Chair, if you'd allow me. There was a conversation about the cost of healthcare. I do think the messed up system that we have in healthcare in our country and perhaps in our state as well is that we have episodic care. We don't prevent. And when we don't prevent, we wait for the illnesses to develop, and it's far more expensive to deal with the illness than to prevent the illness. And then we have been a lopsided throughout. And unfortunately, 75%, this is studied, this is not my data, this is well-studied, books have been written on this, that 75% of the illnesses that we deal with are unfortunately self-inflicted between tobacco, alcohol, lifestyle, and some of those, and that have resulted in why our numbers are so much different compared to some of the other developed parts of the world. So these two basic things, if we were to able to focus on them, we have an opportunity to bring the cost of healthcare down. This has been well studied, but I just wanted to put that because that was a conversation that some people had. So thank you for your testimony. I appreciate your work that you do, sir. Thank you.
Sure, Senator Anwar. It's our pleasure. I will mention that if you go back and look at the wisdom that was gleaned during the two forums on healthcare costs, the issue here in the United States is not volume, okay? It's not utilization, as they say. It's not how much healthcare we use. We, in many respects, use less healthcare than other countries. What it is the underlying price. That's what's driving the cost. So.
Thank you.
Just want to make that comment.
Thank you, Senator. Any other questions? Seeing none. Thank you, sir.
Thank you for your time.
Appreciate it. Up next is Ms. Kate LeBlanc, followed by Doremius Williams. Is Ms. LeBlanc in the room or on Zoom?
I'm on Zoom.
Hi, how are you?
Hi, thank you. Hi,
Welcome.
Senator. Good afternoon, Senator and members of the Insurance Committee. My name is Kate LeBlanc, and I am proud to be the Executive Director of Resolve New England. Resolve New England is an independent nonprofit organization that provides emotional support, education, and advocacy for all those in New England that are struggling with fertility or family building. My husband and I personally experienced infertility, which has made us passionate advocates for anyone struggling to become parents. And I'm joining you today to testify in regard to raised Senate Bill 1039, an act concerning the insurance department's recommendations. It has a long title regarding financial regulation, life insurance, and insurance licensing requirements and technical corrections to the life and health insurance statutes. I'm just here specifically to say that I am grateful to the Connecticut Department of Insurance for including language in Senate Bill 1039 to remove the age 40 limit that is in the current state infertility statute in order to be compliant with the Federal Affordable Care Act. I believe that the removal of this age limit had already actually been done administratively through a department bulletin. But obviously we support it being done through this bill as well, because the age 40 limit was and is arbitrary. And it shows that, a core belief that we have, which is that decisions about healthcare should be primarily made between the provider and the patients and based on the most current scientific knowledge. So this change is just one area of the existing infertility statute in Connecticut that needs updating to make it more equitable. Currently, infertility is limited to a very heterosexist definition that excludes many people in your beautiful state of Connecticut. As such, our organization is strongly supporting another bill, House Bill 6617, that's currently before the Human Services Committee, that would further improve access to fertility care for individuals and LGBTQ couples and more, as well as for people covered by the Husky program in Connecticut. I understand that the Insurance Committee may see additional suggested changes to Senate Bill 1039 related to infertility in the coming days and weeks. And I would just ask that patient advocates, providers, and other stakeholders have an opportunity to weigh in on any proposed language to a statute that is so dear, I think, to many of us, and I hope is a source of pride, as it should be for all of you in Connecticut. But we can always do better. As we learn over time what we can do better, I think we should do better. So thank you so much for listening to my testimony today, and I'm happy to be with you virtually.
Thank you. Any questions?
Representative Nuccio has her hand up online.
Representative?
Thank you, Mr. Chair. And thank you, Katie, for testifying. And yes, this is a bill that I've been working with DOI on regarding the fertility piece of it. Still working on it, and I'm familiar with 6617. This would be this bill's a little different in that it's truly just focusing on the insurance aspect and opening up fertility rights to anybody who is insured, regardless of sexual orientation, gender, or anything else. So we're working on that language, and we right now are looking at what other states have done and trying to mirror that. So the change will incorporate same-sex partners, and again, like, it will be much more inclusive than the current statute that is there now. So thank you for coming and testifying on this. It's a matter that's pretty near and dear to my heart also. And I can assure you that there will definitely be language coming forward very soon that will address your concerns.
Because thank you. And we certainly, like, as I said, we want to be part of it and make sure that the best possible language comes out. And we understand that will only be the private insurance aspect. And as I mentioned, we are interested in expanding access to Medicaid, because there are many people that have Medicaid as their primary insurance that cannot currently access coverage for fertility treatment if they have infertility, or fertility preservation if they have a medical need to preserve their fertility for future parenthood. But we appreciate, being creative about looking for solutions. And again, are grateful to keep talking. We want to be it to be a collaborative experience.
I will tell you that we have definitely, I've been working with the advocates on this, with the language that's come over in that. So it's not me just putting it out there. It's definitely working with the Fertility for All and a couple other key people that been, like I said, there's been a couple of years that we've been working on this. So have been looking at that. Then again, though, thank you very much for your help. For your testimony. I appreciate it.
Sure.
Thank you, Representative. Any other questions? Seeing none, thank you very much for your testimony today.
Thank you, Senator.
You're welcome. Up next is Doremius Williams, followed by Wyatt Bosworth. Is Doremius Williams on Zoom? Or she?
Doremius, we can't hear you.
You're muted.
We still can't hear you. I'm not seeing that you're muted, but
No.
there may be a separate issue.
All right, why don't we move on to Mr. Wyatt Bosworth? We'll come back if we need to. Mr. Bosworth, good evening.
Chairs Wood, Cabrera, ranking members Wong, Pavlak D'Amato, distinguished members of the Insurance and Real Estate Committee. My name is Wyatt Bosworth and I'm assistant counsel with CBIA, the state's largest business trade association. I'm joined by my colleague Ken Komodo to my right, who is president of CBIA Service Corps Division of CBIA. Thank you for the opportunity to testify in support of House Bill 6710. We applaud the committee for recognizing health insurance is becoming increasingly difficult to afford for many Connecticut small employers. Just last fall, the insurance department approved a wide range of premium increases on small group plans averaging 8%. In Connecticut, the average single annual premium per enrolled employee for employer-based health insurance rose nearly 18% between 2016 and 2021. And as a result of these increases, as well as increases in the past, two major insurance carriers recently exited the market, further consolidating the market, providing in less competition. Additionally, the small group market is becoming more expensive due to healthy groups opting instead for level funded and self-funded arrangements with private carriers. The cost shift is currently happening. HB 6710 recognizes this problem and addresses it head on. This bill does two things, and I've heard a lot of testimony today focusing on the self-funded authorization. But the bill also clears the way for trade associations that meet certain requirements, including the Federal Department of Labor's rules concerning AHPs, to aggregate their small business members and purchase fully insured ACA compliant large group health insurance from a health insurance carrier. These are products only offered to employers with greater than 50 employees today, and there's a numerous amount of benefits for small employers who can purchase these plans. Economies of scale can allow the group to negotiate directly with the carrier. The scale will also allow them to incorporate digital health programs that many large employers have today. Members would have meaningful and substantive control over the plan, and a higher medical loss ratio of 85% means that these large group plans are more affordable for the same benefits, since a smaller portion of premiums can be spent on profit. The meat of the bill is Section 2, which is what most of the testimony has been on today. And this would allow trade and industry associations of significant scale to offer a self-funded multiple employer welfare arrangement. Virginia, on a bipartisan basis, passed similar legislation last year and joined a number of other states in recent years, empowering these larger associations to offer self-funded arrangements. Under ERISA, the state of Connecticut possesses near absolute ability to regulate these plans. The bill provides that the Connecticut Insurance Department, through regulation, has the right to develop solvency standards, filing requirements, oversight, audits, transparency measures, and more. We welcome that regulation, as it was the key thing missing from the public option proposal in the past.
Wyatt, I'm sorry to interrupt. Your 3 minutes are up. Please summarize.
If you would just indulge me. When large associations are able to offer these self-funded products that tens of thousands of employees can join, then we can truly move the needle on bringing costs down and improving healthcare outcomes, like the healthcare advocate just said. Important work that the state employee plan and larger employers are implementing today can be achievable for a self-funded arrangement here. Small businesses can truly become active purchasers and influence benefits and services focused on better outcomes and lower costs through incorporation of value-based insurance design, price transparency tools, pharmacy savings, wellness incentives, centers of excellence strategies, and more, all while providing a plan of scale with appropriate stop loss and oversight to ensure both good and bad risk groups can benefit.
So I'd be happy to take any questions. Ken as well is here to answer any questions.
Thank you.
Thank you for the time.
Thank you. Any questions? Representative Wood?
Thank you, Mr. Chairman. Thank you, Wyatt and Ken, for being here. I was wondering if you can address some of the comments that were from earlier speakers regarding risk and not covering people and kicking people out should they get sick on these plans.
I guess that's why I'm here. So, you know, the way we would think about this, the idea of medical underwriting for a group, yeah, that's a concern for everyone in the room. But the reality is that's what's going on today. By our estimates, better than 30% of the small group market has already moved to self-funded plans via underwriting. So, you know, having that as a component of the plan, addressing that issue first, is simply the way to put these on par with what's happening out there. You know, there are two elements here. One is to provide an opportunity for small businesses and to do it in a way that gives them the leverage and the active purchaser opportunity of a large group. And even in the large group fully insured market today, underwriting is a component of that. So really that element is the starter. And what that leads to is the opportunity to build a pool. And this is really where the value of an association health plan comes into play. It's building that pool and giving small businesses the active purchaser opportunity to do the kinds of things that Mr. Doolittle talked about. So value-based insurance design, navigation to help people get to the best outcomes and lowest cost, centers of excellence deployment. These are the kinds of things that large companies are doing today for their populations, but small employers simply can't. They don't have the voice to be able to do it. They don't have the leverage to put those tools in place. So yeah, underwriting adds a component at the front end that allows you to build a group. And the reality is you have to meet the solvency requirements that the DOI is most certainly going to put in place, and we would welcome to address another element of the issues that came up, to address you know, concerns about bad players in the past. So those kinds of elements are there. That kind of oversight is there to do that. But in building it, you're creating that active purchaser voice.
And I would just add on that, Ken, too. I heard some comments about individuals being kicked out of the plan.
Yeah, I think
ERISA incorporates major components of the Affordable Care Act. Things like exclusions for pre-existing conditions, cost sharing caps on preventative services, covering dependents until the age of 26. These self-funded plans are not the Wild West of insurance plans. They incorporate key provisions that the ACA requires of fully insured plans and large employer self-funded plans today. I think what we're talking about with the underwriting is it's one of many components that would be used to rate a plan. Things like age, geography, you know, industry type. All of these things go together in forming a base rate for the pool. And then adjustments are made on an employer level to kind of avoid the problems, for example, that the partnership plan is having today. You know, I was interested to see in the most recent financial report given to all of you in January that they are seriously looking at utilizing group-based underwriting to fix the problem that has occurred of better risk groups leaving the plan, which has in turn left the partnership plan incredibly sick. And that's what we call a death spiral. And it appears that the comptroller sees the value in underwriting at the group level. And we would certainly echo that same sentiment here today. But there's more to this plan than just medical underwriting, right? Like Ken said, it's about the scale that you can achieve by getting tens of thousands of employers together under a single umbrella with a stop loss policy that is able to take that bad risk and spread it out in ways that those small employers can't spread out today.
And you're talking about, you know, the self-funded plans. We're also allowing under this bill, under the association health plans, a fully insured product, which would comply with the Affordable Care Act regulations and other values in the state that are very important to us. So I think that given the size of our state, the amount of level funded plans or self-funded plans would probably be one or two, at the most. And most of these small associations would be going in the fully insured space, correct?
Absolutely, we would see that as the case, but even in that fully insured option, there would be an underwriting element. But simply, what the self-funded arrangement allows is to further reduce cost, further wring out expense under the nature of that, but by being able to take on a broader amount of risk.
Thank you.
Thank you, Representative. Senator Lesser?
Thank you, Mr. Chair. So is the main way that this proposal reduces costs by allowing underwriting or higher costs for people with pre-existing conditions? Is that the main cost component of this bill?
No, it's not the main cost component. It is an element that would allow you to reduce initial cost, but over time, the real payoff is that active purchaser element I was talking about. So the ability to structure benefit plans, designs, navigation that hold down cost over time. And that's really where the savings comes from. So you hold down the cost curve, the medical trend line, the unit costs that were discussed earlier, hold that down over time. That doesn't come from underwriting. That comes from policies, procedures within the plan, things to incent people to seek the best outcomes at the lowest cost.
So in the 13 years since the country adopted or the Congress passed the Affordable Care Act, we have come to view pre-existing condition discrimination as a thing of the past. If that's not the main cost control component, would CBIA support removing that provision that would allow under this bill higher prices for people with pre-existing conditions?
Well, there is no pre-existing condition limitation in it. The underwriting would happen at the group level, so it would be influenced by a number of people. And once a group's in the plan, you're going to have a pool level to help moderate that risk over time.
I understand that, but I didn't hear an answer to my question. So as I understand the bill, it allows underwriting based on medical underwriting that would allow higher prices than are currently allowed for people with pre-existing conditions.
It isn't necessarily an element of pre-existing condition, but I certainly will answer your question. I think it's an important component to this allowing to move forward because simply that's happening in the market today. And, there was discussion earlier of adverse selection. This will be subject to exactly that without the ability to have the exact same tools that are already being deployed across the small group market today.
Would CBIA support language that would restrict medical underwriting? Yes or no?
I have a position on it. Why? I would say we would not. I think it would put the association health plan in a position that it simply would not be able to stand up and provide opportunity to those individuals over time and provide those small businesses with the active purchaser opportunity they need.
So some of the testimony that we received through you, Mr. Chair, was specific to the experience that other states have had with association health plans, and they specifically pointed out problems about fraud and insolvency. Did you have any opportunity to look at that testimony and see how these MEWAs would be structured differently?
I did, yeah. And, just by way of background, Senator, before 1983, MEWAs, right, there was a ton of litigation and fights between the states and the federal government on whether these MEWAs were technically an ERISA covered plan, right? Similar to how single large employers today, the state can't really tell them what to do. They can regulate the stop loss and whatnot, but they operate under ERISA primarily. There was a lot of litigation in the 80s about who gets to regulate these things. The states back then wanted to regulate these things because they were fraudulent. Bad associations were setting up. They were defrauding their association members. And what happened in 83 was Congress recognized this problem. And under ERISA specifically allows the states to have near absolute regulatory oversight and authority over these multiple employer welfare arrangements. So what that means today is in states that we've talked to, states like Maine, states like Virginia, states like Georgia and Ohio and Missouri and Washington that have all authorized these MIWAs to exist, what you see to mitigate the problem you raise is extensive oversight by the Connecticut Insurance Department. That means constant audits, constant transparency requirements, filing requirements, both with the DOL, who have to receive M1 and 5500 forms when these MIWAs crop up, but also filing requirements for the state as well. And most importantly, capital and surplus and reserve requirements, right? We're not saying we want this plan to be unregulated. We want to work with the Connecticut Insurance Department to set up a regulatory scheme to make sure that our association members are protected, that adequate reserves are being reserved for, that we have the money to pay out claims, and that we're subject to constant oversight and audits and penalties for not following that. That's how you mitigate the problems of insolvency. And that's what other states have done successfully.
But with respect, and I appreciate that answer, but with respect, the language of the bill as I read it does not require these plans to be licensed by the Connecticut Department of Insurance. In fact, it gives that as an option. It requires like a registration, I believe, but it doesn't require licensure. Would you support requiring all of these plans to be licensed by the Connecticut Department of Insurance?
100%. And I believe lines 30 to 31 require licensure. And then the tail end of
under the same provisions that apply to commercial insurance plans that are currently regulated?
No, that's kind of the issue of why these plans can't exist, is because nonprofit associations don't have the assets and liabilities from the get-go that a domestic stock insurance company has, right? So what other states have done, like Virginia, for example, they have some very aggressive reserving requirements. They require a $500,000 security payment to be made to the treasurer. They require from startup $4 million in positive net worth, and that $4 million has to grow relative to the size of the MIWA moving forward. They have to obtain a guaranteed letter from a creditor. And they have to maintain terminal stop loss policy to make sure the claims are covered in case of insolvency. There's a ton of oversight on these plans. And of course, they should be licensed by the insurance department. But there's ways to regulate these things different than how they regulate insurance companies, because it's impossible to prop up a plan if they're treated as an insurance company.
With respect, I just don't think that comes with the same level of consumer protections that we're accustomed to in the state. One last issue, where do you think the folks who aren't able to participate will go? Are you concerned at all about a death spiral that Mr. Doolittle talked about and the impact on your members who currently operate the commercial insurance plans on the exchange?
You want to?
So the two carriers on the exchange, right? If you have a death spiral, as Mr. Doolittle talked about, and you have higher prices and for the fully insured market, and for plans that are dominated by women, by people of color, as Senator Anwar mentioned, sicker populations, where are they going to get health insurance, and how is that going to affect the remaining market?
Yeah, Senator, that's a great question. What I would say is if association health plans don't come into play, or approval of a MIWA to allow associations to take advantage of it, those same issues exist. Your same questions exist. That's happening today. Underwriting is happening today. And what we're looking to do is provide a solution that broadens that choice. So if you have a pool that has an association that's running it, thinking about its member companies, they can think of it in a more broad way than just 110 life group or 115 life group. But what I would say is, you're absolutely right. That is going on today. We're suggesting a way to create additional competition, maybe drive new innovation to think differently about these kinds of things.
I apologize. I don't mean to repeat the question, but I did not hear an answer to my question. What happens to the folks who are not able to participate because their risk is not attractive to an association health plan?
That secure insurance in the same way that they do today. So exchanges are out there, commercial insurance companies are out there in the fully insured market, in the small group segment, and those opportunities will continue to exist.
So you actually agree with Mr. Doolittle that will lead to a sicker, older population and potentially higher prices for people left on the exchange. That may have a significant adverse effect on the solvency of the exchange market, potentially impacting the two carriers that are there, Connecticut and Anthem, and their ability to provide affordable care on the exchange.
I think that that is one solution that's out there, but I have had multiple conversations with Mr. Doolittle. I don't think that that was exactly what he said. We agree on many things in terms of the opportunity that it can exist from an association health plan and the opportunity to reduce costs and go at it in a different way by being able to deploy things like navigation and centers of excellence and value-based insurance design, the kinds of things that can't be deployed in the small group insurance market today, whether it's on the exchange or off the exchange. It's just not happening.
And if I can, Senator, if I could just follow up to your question. This issue of adverse selection, it's happening today. Okay. Those 15 life, 20 life groups that are quote unquote healthy, they're not in the small group market anymore. They're with Connecticut or Cigna in a level funded plan where they purchase a stop loss policy, they have fixed premiums every month, and they're experience rated, right? So the question is, and those plans are expanding, okay? There's going to be more and more healthy groups leaving the exchange as the years go on. And that's why you see carriers leaving that exchange and investing in level funded products. The question is, what do you want to have be there when the exchange eventually reaches a critical point? Because I would argue those sick employer groups that we're talking about, right? The employers that have a higher percentage of cancer claims or pre-existing expensive claims, they're not able to purchase those self-funded products today. If we design this plan right, there would be a place for them to be in this self-funded plan, okay, where the risk is spread across 40, 50,000 members. Stop loss policy mitigates the effect of high claims. And then we could give those groups value-based design, as Ken said. We can give them navigation and the things that the state employee plan is doing. But you have to come to the realization that that adverse selection is already happening.
I just don't believe that, right? It's not that I don't think that there are problems with the market, and there's certainly been problems with the small group market, but it's hard for me to see how the benefits of making it easier to bring value-based care to some small group plans outweighs the cost of imploding the infrastructure we've set up in this state since the passage of the Affordable Care Act, and the harm that that would cause, seeing a huge spiral in the price of individual health insurance on the exchange when we dump the sickest people in the state onto that plan because they're no longer able to afford their small business plans. I respectfully disagree with that, and I appreciate your comments. I think this would be extremely disruptive to what market we have at this point. And I want to thank the committee for its time.
Thank you,
Thank you,
Senator.
Okay, go ahead, Representative.
Yeah, just a quick question to follow up on the good senator's question. I was under the impression that I think somebody might have mentioned this, that was already happening, because I'm looking at a text from Connecticut that they're exiting from the fully insured group market, right? And now there's only Anthem, I believe, that's left. So I'm not sure, if we're already experiencing that, then again, trying to give other options and choices. And, if we're already going through that now, I guess I'm a little confused why we're not addressing that. If it's working so well, then why are all these carriers exiting, as we've seen over how many past years?
And why have we seen double-digit rate increases? Okay, why have we seen the migration of healthy groups saying, I can't get a good rate in the small group market anymore, I'm moving to a self-funded product? The market is not doing well, and we have to recognize it's not doing well and offer another option.
The other point I'd add, and the exchange today, of course, has very significant enrollment in the individual market. But the small group market on the exchange is actually quite small. I believe it's, I don't want to misspeak, but I think it's less than 2,000 members that are on that today. It would make it quite insignificant. So, what's not happening today is small employers are going to the small group version of the state exchange. They're staying in the markets today. So the idea that this would exacerbate, a problem with the small group exchange, the shop, I don't see as an issue.
Thank you, Representative. Want to have Representative go first, then Senator Anwar. Then thank you.
You yielding to me?
Go ahead, Senator.
Thank you, Mr. Chair.
He's a
Thank
gentleman.
you, Representative Denning. Thank you so much for your testimony. I've been taking notes and it's very helpful. I appreciate you guys coming in and supporting this proposal. This is what I heard, and maybe I wanted to hear what I wanted to hear, and I'm going to clarify. What you have said on multiple occasions is that the adverse selection is already happening. So let's bring a plan that is going to, and I'll say what I hear is that have another plan which is going to exacerbate the adverse selection. And then so that just because 30% of those market is already happening, let's move it to adverse selection of 40% and expedite the death spiral. I mean, that's the argument. I don't buy that argument that, well, it's already happening, so let's do more of it. Please help me.
Yeah, I know that's where we certainly have focused with much of this discussion, but I believe the bigger opportunity is for the pool to be able to do other kinds of things. You're only going to get, when you take a large employer that moves from the fully insured market to the self-funded market, they're typically going to save 6 to 8% with that. That's pretty typical savings. That's not the big opportunity. The big opportunity is to have these pools that then has someone who's looking out for that pool, or a group that's looking out for that pool, to move it in a different kind of direction to hold down cost over time. The only importance to that vehicle of underwriting is to put it on a level playing field with the other tools that are being deployed, not to exacerbate a problem.
Okay, I'm not yet convinced, but thank you for your answer. Yeah, because at the end of the day, we are trying to. You made another very profound statement. It's going to be based on age and geography, and that's one of the biggest determinants, right? Of what the risks are. This is one state where you drive 5 minutes and the lifespan changes by 17 years. So no other probably state can say that, well, 5 minutes of drive, the lifespan changes by 17 years in the country, most likely. So that's the reason why I'm afraid when geography and age and a workplace is going to determine your risk pool, then the high risk will be left worsening and the outcomes will get even worse. So 17 is going to become 21. That's my fear. There's a question in there. There's a question in there, and then I'm letting you answer that if you could. In other words, I'm not. What I'm saying is you're not solving the broader. Look, I respect the fact that the business industry is going to look at what is going to be good for you. I respect that, but I have to also say that I want to look at the business industry doing well, but not at the cost of rest of the state and the minorities and the community and the seniors dying. Mm-hmm. So that's my dilemma, that I look at your plan and I say, okay, it's good for you, but what about the rest of the state? How are you going to survive?
Sure. So geography is a factor that often is an indicator of underlying cost, not of the individual, but of the medical providers in that community. So the contracts associated with that geographic area, that's generally where that comes into play in terms of rating. As far as where this is a difference maker, and I know I keep saying it, but the issue becomes that a 10-life small employer that is in a self-funded product today has to take it or leave it. And the same thing in the fully insured world. And so the benefit plans that are offered to them, or the benefit plans that are going to get, the opportunity to negotiate price does not exist. And the chance to put in other kinds of things that will help their employee population isn't on the table for them. That's what's important about this plan. The underwriting is simply an element that as I said before, gives it a chance to stand up and be on par with the other vehicles that are out there today. The true defining component here is to get to the kinds of things that I heard you talk about earlier around helping people seek the best care and getting them to the right places and to the right experts along the way. And in many cases, those often become lower cost because they're the best at doing it. So they're most efficient, most effective, and they get the best outcomes. So that's more what this is about over the long term. And you can't solve it overnight. So you have to have a place to start to be able to build that plan and then move it in the right direction. This is a vehicle that will allow you to do that. Those vehicles don't exist out there today. Large employers can think over a multi-year strategy and drive to those ends, and they've been successful in holding down costs as a result. There is not a way for small employers to do that other than through the kind of opportunity we're talking about.
Who will pay when there's an insolvency of a associate health plan?
Yeah, the insolvency, again, that's an issue that we're really very interested in continuing to talk with the Department of Insurance about and what they're comfortable with, but who would pay would be the participants in the plan. So the employers that participate in the plan would have the underlying responsibility for the plan they're
So,
participating in.
If the bill were to say that taxpayers directly, indirectly, in any shape or form would not be involved in anything, and those individuals who are part of this and through the insolvency will never be part of Medicaid, would that be fair?
Can you repeat that, Senator?
Yes.
I'm just saying that if you fail, we will have a ton of people on Medicaid. And the state will be in a bit of a trouble because somebody's going to pay when insolvency happens. And then that's what some of the other states, the people and organizations went bankrupt. So who will pay when things don't seem as nice and good as you're suggesting it would be?
Yeah. In a self-funded plan in the private sector, the employers that would participate in that plan would be the ones ultimately responsible. So that would certainly be the case, but that's why you would have capital solvency requirements and as well as surplus requirements and so on that would be monitored, audited, put in place. We built that into our thinking in terms of our suggestions around this bill in order to address exactly those issues.
And I know you're saying that you guys are very open to all the guardrails, protections for all the failures that have happened everywhere else in this country, and you want to create a new situation where we'll hopefully learn from every single failure that has happened in the rest of the country and then make a plan that is going to be Connecticut specific, which is going to make sure the minorities are protected, everybody's protected, and it will be overseen by our Department of Insurance. And when Department of Insurance is going to listen to us speaking about that, they'll say, we'll need 50 more people. Who's paying for that?
Senator, I would be happy to connect you with the chambers across the country that have these plans running successfully today, that are regulated by the Department of Insurance, that have adequate stop loss, terminal excess stop loss, that have the money in the bank to make sure, the IBNR is paid out. These plans are successful, and no doubt there has been problems with these. But in the last few years, what we've noticed as a business association is there are chambers across this country, and you'll hear from the credit unions today who have a fantastic self-funded trust up in Maine, who are providing great healthcare for their credit unions up there. There's successful plans in Georgia and Ohio and across the country. I'd be happy to connect you with the plan sponsors there. And I think, this is not an easy concept. That's why we've been talking with the healthcare advocate. We've been talking with the Department of Insurance. We've been talking with both sides of the aisle because this is complicated stuff. And in Connecticut, consumer protection is incredibly important, no doubt. And we want to make sure that you are comfortable that these plans are operating. We want to make sure that our association members are comfortable joining the plan. Because at the end of the day, that's who we have a duty to. We have a duty to our thousands of members who are both healthy and sick, right? We need to provide a plan that both sides can benefit from.
So back to my question, with respect to the insurance department, they will need a lot more personnel to be able to oversee and make sure that these plans are doing what they're supposed to do and negative things are not happening. Who is going to pay for the extra people? the taxpayers?
I go ahead, Ken.
I think that the way in which this can be rolled out could be certainly controlled by the Department of Insurance. They can decide that whether they want to have 5 million of these or, a small number to start and understand. I think that there would be a number that would stand up in a way that they would be able to manage that. But certainly that should be part of the conversation.
Okay. Well, thank you so much. I may have more questions, but thank you so much for your responses. Thank you.
Thank you.
Thank you, Mr. Chair.
Thank you, Senator. Representative, you've been very patient. Thank you.
Thank you, Mr. Chair. I always find it amusing when insurance companies say they give great health care, and I was a provider for 40 years. I never saw you. You were never inside the hospital. Nothing personal. But so I'm just trying to understand this clearly because I'm not an insurance specialist. So these new association plans are for associations. They gather their members together. You give them a great price. They're able to control their costs because they can maneuver what they want their clients to be doing, moving them towards better healthcare, weight loss, gym clinics, whatever you want to decide, you cut their costs. So, and I love that idea. So my question is this for one association or can two associations separate come together? And if not, why not have all the associations under one association so that everybody could join? And then make it so that the pool keeps getting bigger. The people managing it become, and what you're telling me is economy of scale saves more. Therefore, the more that we have, the better off you are. So am I getting this right?
Yeah, so that is exactly what's happening in Virginia right now. The Virginia Chamber of Commerce has retained Anthem as their TPA for the plan. Anthem covers a lot of these chamber self-funded MEWAs across the country. They have worked out an agreement with other associations in the state, some kind of revenue sharing agreement for participation by other associations in the plan. And absolutely, I mean, ideally, there would be one or two of these plans that have significant scale that, aren't small, that can spread the risk across. So I think that's a great idea. I think there's more power in numbers, and I think that's what Virginia recognized, and they're working with all the trade associations in the state to partner on one big self-funded plan.
And are they keeping all of the requirements of the Obamacare about no turnaways, no age restrictions?
Yeah.
They're just excuse me, they're just determining on those three same levels that Obamacare allows, correct?
Yeah, like I said, Representative, portions of the Affordable Care Act were codified in ERISA when the ACA passed. So things like I said, dependents staying on parents, all of those things are codified there. The market reforms are not, right? The rating requirements for the large group and small group market, those are not codified in ERISA. That's why large employers can use a number of rating factors today to rate their pool. But absolutely. I mean, even one thing that was missing in the bill that Virginia had that I wish this bill had that I would urge the committee to put in is make sure these self-funded MEWAs are guaranteed available and guaranteed renewable. I mean, that's what I've seen across other chambers to make sure that someone applying for the plan gets access to the plan.
And we could apply, would it be okay if we applied our own requirements for the plans, such as what the Affordable Care Act cannot do on the federal level, we could do on the state level?
Absolutely. I mean, you as long as ERISA says, as long as you don't conflict with Title I of ERISA, you're free to do virtually anything. You could require it to be guaranteed renewable. You could even require it to follow small group rating requirements if you wanted. Obviously, that would be pointless. It wouldn't work. Things like Mr. Doolittle was saying about having a lock-in for 3 years, that's something we could talk about and put in, price justification, et cetera, whatever we can come to an agreement on with all the advocates, we can design this plan how we want to, so long as it does not conflict with Title I of ERISA.
Thank you very much. Thank you, Mr. Chair.
Thank you, Representative. Representative Meskers.
I try to filter through the arguments and the conversation on the plan. And in simple terms, it looks to me like there's a conversation about that I heard in our press conference. There's a conversation about people with a $5, $10, $15, or $20,000 deductible who basically own catastrophic insurance, who are currently there. And what I'm hearing in concerns from people as opponents are that it will draw people from the Affordable Care Act, from the individual component, to take group policy under the association. What kind of history have you seen in Virginia? So are we, because if the majority of the effort is to bring people to a non-catastrophic insurance, which is garbage. I mean, if you have to spend $15,000 in a deductible, you better hope you're losing your leg because nothing else is getting paid for, right? So if it's to reduce, it's to take you into a real insurance product, and it's not just going to cannibalize the healthy and the Affordable Care Act, you know, it probably would be good to get some of that data as we go forward and look at it, because the concern is that ultimately is what I'm hearing is the concern is the rating the Affordable Care Act insurees. And I'm looking at the group insurance as being part of the solution to catastrophic insurance, which is worthless, this high deductible plan. And maybe a component is to think about if the Affordable Care Act were going to affect the pool. One of the things I think some of our colleagues have mentioned is maybe having a catastrophic loss or first loss underwriting, the state writing some kind of policy to guarantee some of the catastrophic loss in the Affordable Care Act pool so that we can continue to make it an insurable pool. But I just like your thoughts or comments on my comments.
I guess I'll start at the end. You know, there certainly was a high risk pool here in Connecticut for many, many years. That went away with the ACA. I know there's been conversation about rethinking what a high risk pool could look like for those claimants that are simply, you know, a struggle across the entire marketplace. So, you know, I think that there could be more conversation on that front and maybe some opportunities around that. As far as the plan design issue, you know, in the marketplace today, both you know, in the exchange, in the commercial market outside the exchange, as well as, you know, in the self-funded plans that are available out there, there's a broad range of plan designs, and those are to meet many price points. I would think that any successful plan would need to offer a broad range of plan designs, and even in those where there's higher cost sharing, you can find other ways to deliver value through that. So in some ways that allows you to get people to the right places because they have incentive to say, oh, you know what? I know with that provider, I'm going to be well within reimbursement levels. I'm going to go there. I know their outcomes look good. That's the place I want to be. And you provide them the tools to be able to do that. But I think the answer is a range of plan designs to meet a range of family needs and desires. For some folks, they say, geez, I'd like to have the highest deductible I can have in a qualified high deductible health plan because I want to leverage the health savings account in the best way possible. For others, that doesn't work at all. You need to provide other options for them that have less cost sharing and you know, higher reimbursements. So it's a range of options for a range of people.
And if I might, and Mr. Bosworth, just the concern about adverse selection in terms of what the history looked like in Virginia. Was it out of the Affordable Care Act, or was it going from high deductible plans? Do you have any background on where everyone was drawn to the plan?
So just to clarify, Virginia, the law passed last June. The regs were issued by their respective DOI about 2 months ago.
Okay.
The plan is being set up. Okay. We've spoken to chambers, you know, in Georgia and Missouri and Maine, not a chamber, but the credit union trust up there. I have asked them, has there been any noticeable degrading of the ACA fully insured market? I have not seen any data or any anecdotal evidence to point there. But that's something we need to look into, obviously, because it's a serious concern of Senator Anwar's and Senator Lester's, and we need to make sure that we're not doing harm here. But based off of my experience speaking with the people who run these plans, who are engaged in those markets, we don't see that coming to fruition.
And that might give rise to my second concern, which would be to look at the potential for any underwriting of catastrophic risks on the Affordable Care Act exchange to make it not to affect its pricing and survivability. But I think I'm horrified if I have to listen to one more person tell me about their high deductible healthcare plan, who have no business being on a high deductible plan because of their financial situation. I'm just, what we're doing in this country is unconscionable. So at least I thank you for this effort. And as you can see, we still have questions, and I appreciate it.
Thank you, Representative. Senator Wong.
Thank you, Mr. Chair, and thank you both for being present. Take me through a little background history. People have said in this panel discussion that this is something new, that it's unproven. But take me back. These were, in essence, association plans that existed before the ACA took it out of play. Would that be fair to say? Can you kind of go back in a little history lesson that this is not something conjured up and it's kind of new, but it has been shown and proven as association plans in the past before the ACA?
So it's happening in Connecticut today, but put aside the level funded plans. The legislature years back allowed municipalities to come together and block purchase self-funded insurance plans. Today, municipalities are forming these blocks, essentially analogous to association plans. They're called the ACES Collaborative, and there's other collaboratives across the state that compete with the partnership plan. But those municipalities are underwriting at the group level, they're underwriting at the plan level, and they're authorized by the legislature today. I can speak to, of course, the plans we talked about across the country are operating today. But I just want to stress the point that municipalities can do this today. The partnership plan is thinking about implementing underwriting in its latest financial report due to the insolvency that the lack of underwriting has caused. Ken, I don't know if you have any additional comments.
No, not at this point.
Okay.
Thank you. It's been a long day already. We hear about Virginia, but Virginia is the latest state to approve and implement the program. I'm looking through your presentation. Your testimony is well-versed. It's 29 pages. Thank goodness we're not printing up paper anymore. But I cite in your testimony, Georgia, Maine, Missouri, New Jersey, Ohio, and Washington. You gave a chart, and I encourage people to take a look at that. And I'm reading through it. Correct me if I'm wrong. In every single one of those states that adopted this association health plan, there is a proviso that it is reviewed and audited for solvency and reserves by the Department of Insurance or regulatory body in those states. Is that correct? Because there is a concern about insolvency, liability, but this is in essence audited by departments of regulations to ensure that it is functioning, solvent, and operational.
Yes, and I just want to tell the audience, I did not write 29 pages of testimony. I gave you all data I think is pertinent to this conversation. I think my testimony was 10 pages, which is still too long. But yeah, you're absolutely right, Senator. And the reason I provided that table is to give everyone a look at how other states are regulating these BWAs, because every state is different. Every insurance department is different. The populations are different. The chambers are different. So what you'll see in that chart is, yes, so, we can look at Missouri, for example, right? For reserves, a plan must establish loss reserves for all incurred losses, both unreported, unreported, and for unearned premiums. And for a surplus, they must establish a surplus account equal to greater the following. For plans which do not yet have 1 year's experience, 3 times the estimated monthly premium or $600,000, right? There's different calculations that insurance departments have put together that meet the needs of their state chambers and trade associations. And if this is something that the committee feels is worthwhile pursuing, let's take the best practices from other states. Let's make it Connecticut specific. And let's make sure that the Department of Insurance and those skeptical of the solvency is adequately protected against. And you could do that through regulation. That is why the federal government delegated the jurisdiction over these things primarily to states, because states know best how to regulate these plans.
And I'm encouraged that it included Massachusetts and New Jersey as adopting these plans, and they're not just across the country, they're right next door. Your testimony is very helpful, and you anticipated some of the critics and concerns, and they're very important to address and to answer, particularly the American Cancer Society, I think, is one of them, or the lymphoma advocacy that concerns about the inability to that may leave people with chronic conditions with higher healthcare costs without stable access to the plan, right? So I'm going to refer you to your testimony on page 8. You emphatically state that this is false. I'll give you a moment, if you could, to answer those sections. You gave very, very clear and succinct answers to addressing these issues. And truly, if it was adversely impacting pre-existing groups, it will raise concerns about this plan. But you paid attention to that issue. So can you take us through the 3 explanations that you gave to allay these concerns?
Yeah, and I just want to start by saying, because this is such a serious issue for the business community, we've been reaching out to everybody to talk about this. I think the bill has had fragmented support and opposition in the past. So one of the first groups I reached out to, and some of my coalition partners reached out to, were some of the patient advocacy groups, because their problems in the past primarily relied on the notion that these AHPs don't cover state benefit mandates and essential health benefits. We want this self-funded plan to cover those things. Those are important. Yes, they're a cost driver. Yes, a lot of companies that go to the self-funded market sometimes evade some of those requirements, but that should be a non-starter. Those should be covered, and we wanted to address that concern right away. And to the concern about kind of premiums being adjusted and being prohibitive for groups that may have higher claims experience, if we build this plan right, I know we sound like a broken record, but we can give those groups access to a plan or a type of plan that they can't access today. If we do this right, if we work with the Department of Insurance to develop standards for stop loss, to develop standards for underwriting and rates, we can really spread that risk across, Senator, and mitigate those renewal price increases that may come from a bad year of experience or two. Ken, I don't know, do you want to expand on that?
I think you said it pretty well. Again, it's going to, part of the issue is going to be what does come out in terms of, working with Department of Insurance around capital and surplus requirements and so on. And we'll work with that, and when we'll design plans around that to make it work. It's hard to do that before you know all the rules. But we welcome that discussion.
And just for a record, you mentioned 3 components to addressing this issue. I think the first one, you say that Section 2 requires the self-funded MEWA plans to cover essential health benefits and state benefit mandates, correct? The second, you cited that these plans will allow higher cost individuals and employers to benefit from a plan designed to spread risk across tens of thousands of lives. So higher costs, small employers that can't be underwritten under these will be able to use that. And I think third, you shared that medical underwriting is a key rating factor among those many other factors that a vast majority of the employee sponsor programs utilize today. So I think it's important to kind of reiterate for those advocacy groups, which I greatly value and respect, that you are addressing their concerns and that they will be covered under this plan? I just need you to
Yeah,
kind of validate that.
Absolutely. They should be at the table. I mean, they do great work for the patients they represent. And they have an interest in making sure their patients don't get bad health insurance. The argument we're trying to make is the health insurance they're getting today isn't that great. The health insurance they're getting in the small group market, because that population is getting sicker every year because healthy groups are being siphoned off to the self-funded, level funded markets. There's going to be a day where those plans are just not going to be affordable, even for the most vulnerable populations in this state. So, we would like to prop up a plan that can compete with those existing self-funded products, but also be a place where, some of these groups that maybe can't self-fund today can benefit from the plan designs that we're talking about that can lower the cost of insurance, that could, help those cancer patients or diabetics, stick to their medication regimens and go to high value doctors, right? For example, stuff the state employee plan is doing today and is doing well.
Thank you. And there's so much to discuss and learn, but I think I leave and my acknowledgement of your efforts on this, because at the end of the day, you're providing an alternative to lowering access costs to health insurance. And you're doing it with built-in associations like chambers that are very active in small businesses, credit unions, realtors, microbreweries. You're going right to the grassroots of helping these kind of affinity and associations to be able, and small businesses, which I mentioned earlier, that drives our economy truly, to be able to afford health insurance for themselves and their value employees. It's a workforce issue, but you're able to leverage that by providing an alternative solution. So I want to thank you for doing that, and I appreciate your time. Thank you, Mr. Chair.
Senator, if I may just follow up on that. I was listening to the governor's budget address, and he began to speak about healthcare and some of the bills that you heard earlier. And I think he said, and I don't quote him on this, but employers, health insurance carriers, pharmaceutical companies, hospitals get together and figure something out. And this is the business community's proposal. This is what we're putting forward. It's not perfect. The bill isn't perfect right now. But we're open to working with all of you to address those concerns. And maybe some of those concerns may never be addressed, but that's okay. But we want to talk to you. This is something that is working well in other states. It's something that's providing tremendous relief. You'll hear it from some of the speakers today. And we want to work across party lines to come to some consensus on how to figure that out. With that being said, all of the other stuff you guys are doing, as far as the healthcare benchmarking that we supported wholeheartedly, right? Getting to the bottom of cost drivers in healthcare. The governor's primary care initiative to boost spending in primary care, which has been shown to improve value and lower costs for consumers if they can get that preventative care before they go to a specialist. Those are all things we need to keep working on in tandem with this, whether or not this thing moves forward or not. And we're here to work with you. We're here to work with you on all of that.
Thank you for your time. Thank you, Mr. Chair or Madam Chair.
Thank you, Representative Delnicky.
Thank you, Madam Chair. You raised my antenna up there when you made a comment about municipalities, because ironically, in the town of South Windsor, we've got that type of self-funded plan. And we took advantage of it as a municipality. And it has provided substantial savings. I know the first year it was put into operation, we saved about $2 million, and we continue to have an effective plan. It's built a reserve, and it serves the folks that are employed by the Board of Education and the folks that are employed by the town. And we've got the stop loss policy and all that other stuff that we've talked about here. Can you tell us how many municipalities in the state of Connecticut actually have that type of a plan currently in operation and I'm taking a risk here because I don't know the answer. Usually I like to ask a question when I have the answer. And how many of those plans have failed?
Oh, man. I
Just
do
to the
not
best of
have,
my
I do
knowledge,
not
I
have
don't
the
know
answer to that. What I can tell you, Representative, is, you know, there's brokers and health benefit consultants out there that, you know, specialize in specifically municipal block arrangements. For example, Brown and Brown. They do a tremendous job blocking towns together in a format similar to how we're talking today. The state of Connecticut, let me repeat, lets towns come together and form private self-funded arrangements. That's happening today. And it's working well. It's working well for your town. It's working well for a lot of towns down on the coast where medicine is expensive. Long answer to your question, I can get you that information. I can put you in touch with the people who run those plans and design those plans if you'd like.
And I asked that question not knowing of any that have failed, and prior to knowing that we were going to have the public hearing, I reached out to my old town manager, Matt Galligan, and said, hey, Matt, I got to pick your brain because we're talking about this, the same type of policy that we have in the town, municipality, and allowing the business community to have that kind of a plan. And he was the one that, and I recalled after I spoke to him that we had substantial savings. We've built up reserves. We've had good success there. And to the best of my knowledge, it worked and continues to work. And I'm glad you mentioned municipalities having that opportunity to be able to do that. Because if anything, in a municipal environment, you have a variety of folks at a variety of ages, a variety of health issues, and you have new folks coming in. You've got older folks retiring, and there's a turnover. And I think that's something we've got to keep in the back of our heads, that municipalities have had success with that here in Connecticut. And I'd like to know, and if you could get the information, if any of them have failed, and how many there are that actually have that type of insurance. And I want to say that it had to be about 20 years ago or so, when a much younger Tom Delnicky on the town council was there. So that would be good to have those answers. And I can attest to the fact that it has been successful in my community. Thank you.
Yep, I will get you that information, Representative, and I just leave you with, you know, if municipalities can do this today, why can't small businesses?
And that's the point of the issue.
Yep.
If municipalities are doing this and they're successful, then why aren't we allowing the business community to do this and be successful? Thank you, Madam Chair.
Thank you, Representative. Representative Nuccio.
Thank you, Madam Chair. And thank you, Wyatt, for coming today. I seem to be following people who have similar ideas to me. So Representative Delnicky just brought something up. My town, one of my towns, belongs to what they call ECHIP, which is a mix of a bunch of different municipalities, boards of eds, and such for their own ASO self-funded plan. And in that plan, while they get to leverage the entirety of the populace for rates and for negotiating and such, they do have also selective underwriting in there. So when my town uses more of that, more of the reserve and more of those dollars, their insurance rates go up to compensate for that. So we've now heard, you know, we know the partnership plan does this, where we know that the municipalities do this and that. And I think we've all heard you quite a few times now say that you're looking for that same sort of thing with this AHP. So what I just wanted to kind of get for you to say on record, straight and forward, is you are willing to work with us and with the Department of Insurance. I'm sorry, my dog is down here and he's being really loud. That you're willing to work with us in the Department of Insurance to ensure that this plan is written in a way that has ample protections in it, that meets the desired needs the DOI has for making sure that this is a reserved well, an asset backed and a monitored plan. And you're going above and beyond as an ASO plan to say that you would also be contributing to all of state mandates and also all of the other filing requirements. So am I clear in that understanding that you are willing to work with us in the DOI to make sure we are building this plan and opportunity in a way that's going to benefit small businesses and also kind of quiet the reservations people have in regard to how the plan is going to be structured and the rules that you're going to follow?
Yes. We have been working with those entities for the past few months, and a bill like this cannot pass, cannot be successful unless we continue working with those entities moving forward. This is not the final bill. This bill needs a lot of work, but let's work on it together.
I appreciate that. I appreciate you bringing it forward. I appreciate what you're trying to do for the small businesses. And I appreciate that you are listening to the feedback and are willing to work with us to make sure we've got a product here that is truly going to meet the needs of small businesses in the state of Connecticut, which I think is something that is incumbent upon us as legislators to do, because when business does well, we all do well. So thank you very much.
Thank you, Representative.
Thank you both. We appreciate your testimony.
Thank you.
Next up is Jeremias Williams. Okay, next up is Jim Icabellis.
Good evening, distinguished members of the Insurance and Real Estate Committee. My name is Jim Icabellis. I'm the Senior Vice President of Government and Regulatory Affairs at the Connecticut Hospital Association. And I'm pleased here to testify on two bills, 6620 and a portion of 983, the contracting provision. We'll have someone else testify, my colleague Paul, on the out of network. But before I get started, as I do in almost every hearing, I want to spend a minute to acknowledge and thank the over 110,000 hospital and health system workers who have been through 3 years of month after month of an extraordinary once in a century pandemic. And we need to, as we go through these conversations about the healthcare system, keep the patient and the providers who work with these patients in the front of our mind. So I want to talk about these contracting bills, and there are versions of what we saw last year. And I want to raise the same concerns that we had last year. Both of the bills have provisions which prohibit the inclusion of an all or nothing clause. And where we have concerns, but we need to think through is, will this impact continuity of care? If you are being discharged from a hospital and the next stage of your care is not part of the network, will it make the continuity of care harder? We need to think that through. Secondly, is the provision on tiering. There's a provision that says you can't put a provision in the contract which would ban tiering. We're going to ask the committee to do 4 things related to that tiering, and Representative Wood mentioned them to Dr. Gifford, and they're really important. They have to do with transparency. To require the payers to provide the standards to the providers on how you go in each tier. What is it that will put you in a preferred tier or a not preferred tier? Because we would all like, obviously, to get the highest grade and be in the highest tier. But if we don't know how to do that, then how can we move in the direction of improving care? Require the payers to notify providers of these changes or any changes to the tiers within 90 days. Establish a process for the providers to have conversation and have in disputes, if you will, with the payers on how we move between tiers. Why am I in this tier versus another tier? Allow that conversation. It shouldn't be unilateral. And fourth, require the Department of Insurance to have the ability to come in and monitor this process. We also asked the committee, and we do this on a lot of pieces of legislation, is to not reach our hands into the contracts that are existing and have them start on contracts that go forward on and after the effective date of the act. Let's not reach into existing contracts.
James,
And lastly,
oh, sorry, I heard you were about to conclude, but I just wanted to let you know your 3 minutes were up.
thank you. Lastly, we asked the committee to consider this. When we look at contracts, that if we're going to be doing legislation that it impacts contracts, to make the contract something that has some certainty to it. Not that a provider signs a contract with a payer, and then within a certain length of time, the provisions are changed by simply a policy order coming from the payer. So I thank you for your time. We look forward to working with the committee on these bills as we've done in the past. But I think the transparency provisions and these other provisions are important and will go a long way in improving this legislation.
Thank you very much. We did get some answers from Dr. Gifford, who is definitely willing to work on that language. So that was refreshing. We thank you for your comments. Any questions from the committee? Any online? Great, Jim, thank you for being here.
Thank you.
Next up, we have Paul Goleen. Is he on, Justin? Paul, you're on. Okay, we'll come back to Paul. Next up is Doris Maldonado Mendez. Next is Boris Goldman.
Yes, hi, good evening. Can
Hi,
you hear me?
Boris, you're on.
Hi, thank you. Good evening. Thank you, committee members, for allowing me to testify today. I'm a board certified plastic surgeon. I come before you today as a physician that provides both in and out of network care, a section chief at a local community hospital, and a small business owner. I hope to share with you how Bill 983 will limit patient access to specialty care and harm our community hospitals and small businesses. My practice is largely made up of breast reconstruction after breast cancer treatment, breast reduction for neck and back pain, and facial reconstruction post-skin cancer excision. I have expertise in minimally invasive breast reconstruction techniques using microfat grafting, which decrease hospital stay and lower costs. Like most physicians, I choose to participate or not participate with an insurance network based on their having a fair and reasonable fee schedule. If this bill passes as written and all out-of-network physician reimbursements are fixed at Medicare rates, I will not be able to provide specialty care in Connecticut, or will have to significantly contract the services I offer. I lose money on every Medicare patient I treat. Medicare reimburses far below my overhead costs. In fact, it reimburses at about 20%. I accept this financial loss for Medicare so that I can care for our elderly and needy, but I cannot accept this loss for all out-of-network procedures on behalf of a for-profit insurance company. And I understand that United Healthcare posted a profit last year in the billions, not earnings, but profits. Fixing out-of-network physician fees to Medicare rates eliminates a physician's ability to negotiate a fair in-network fee. This ultimately will result in a drop of in-network fees to the same Medicare benchmark proposed for the out-of-network fees. My private practice is a small business. I employ 6 people. I offer them health insurance and 401k. My health insurance premiums continue to increase 25 to 30% each year with higher deductibles. Have done so for at least the last 7 years. Yet my insurance reimbursements as a professional continue to decrease. This bill seeks to lower these further. So I would respectfully disagree with Commissioner Gifford's statement that lowering physician reimbursements will ultimately result in lower premiums. It just hasn't happened. I am the section chief of plastic surgery at Norwalk Hospital. If this bill passes, plastic surgeons will leave the hospital staff. This will result in a loss of ER call coverage, and in turn, patients with complex dog bite injuries, lacerations with tissue loss, etc., will have to be referred to outlying teaching institutions that receive federal subsidies. In summary, Bill 983 is currently written, limiting all out-of-network physician reimbursements to fixed Medicare rates will limit patient access to specialty care like breast reconstruction and hurt our small community hospitals and small businesses like me. Thank you for your attention.
Boris, thank you so much for your testimony. Do we have any questions from the committee? Thank you, Boris. We appreciate you being here and sharing your story with us.
Thank you.
Next up is Tom Swan. Okay, next up is Mahesh Baya.
Yeah. Good afternoon, Senator Cabrera, Representative Wood, and other distinguished members of the Insurance and Real Estate Committee. My name is Dr. Mahesh Baya. I'm the Legislative Chair for Connecticut ENT Society and a practicing otolaryngologist in Waterbury. I'm testifying on behalf of 800 Connecticut physicians and physicians in training, practicing in specialties such as ENT, ophthalmology, dermatology, and urology. I am specifically here to oppose the language submitted in Governor Bill 983, an act that limits anti-competitive healthcare practices as written. I specifically wish to address Section 310B that seeks to change the current statutes that govern surprise billing. In 2015, a bill that was passed and is now part of Connecticut General Statute not only prevented patients from receiving surprise billing for emergent care, but also ensured that independent solo practitioners, healthcare providers like us in the community receive fair payment for services rendered to an out-of-network patient. This bill promotes unfairly low Medicare rates for out-of-network care and can undermine the entire system. Additionally, Medicare cuts in 2023 and 24 will further worsen the fair reimbursement. These are not the terms which we providers agree to participate with payers. Medical services are frequently complex and often place the provider at risk if the outcome is disappointing. We provide great care in good faith, day and night, on holidays, weekends, when we're on call for the hospitals. If this language is enacted, providers would essentially be bound unilaterally to terms over which we have no control, effectively subjecting us to another take or leave it agreement. While frontline facilities, hospitals, and providers face fee cuts and decreased earnings in 2022, insurers reaped record profits. As Scott Becker recently summed up nicely, it is good to be the house. We are losing physicians through early retirement or other endeavors. Our efforts to recruit young physicians cannot keep up with this attrition, especially if we are fostering an environment openly hostile to physicians. Reimbursement for physicians adjusted for inflation has fallen 22% in constant dollars over the past 2 decades. And this is Medicare. And we continue to get burnt by administrative burdens, prior authorizations. It's really discouraging. Physician burnout has touched every specialty, resulting in early retirement and even suicide in some cases. America does not have a healthcare problem. It has a health insurance problem. This seems hardly the time to further penalize us, frontline providers, who have already borne a disproportionate share of the misery in order to reward a health insurance company. Please oppose Governor Bill 983. The existing statutes properly accomplish the goals of patient and provider protection and will not be improved with these proposed modifications. Thank you for your time.
Thank you, Mahesh. We appreciate your testimony. Any questions? Great. Next up is Bruce Adams.
Good evening. I think I'm the first one. Senator Cabrera, Representative Wood, Senator Wong, Representative Pavlock D'Amato, and distinguished members of the Insurance and Real Estate Committee. My name is Bruce Adams, and I'm the President and CEO of the Credit Union League of Connecticut. We represent about 1 million members in Connecticut, and the number of employees we have is about 2,000. Our median headcount at a credit union is 8, and our average is 25. We are a highly regulated financial institution, and we're pretty good with money. We help people achieve financial independence, and the profits that we make, if any, are reinvested back into our local communities. And we look at this opportunity to support this bill 6710 as a way for us to invest more in our local communities and lift up individuals into financial independence. So I will spare you reading you my words that I put on my submitted testimony, but I would like to read just a couple bits of it. Credit unions offer a unique financial advantage to the financial services consumer. And while our credit unions offer the typical banking products such as checking accounts and savings accounts and auto loans, et cetera, we return those profits, as I said, back into the pockets of the members, largely through advantageous rates, which gives a person greater financial freedom, for instance, to save money, to get job training, to get a better job, to get better health insurance, perhaps at a larger employer that is able to procure higher quality insurance on the private market. So no new insurance product was perfect at its inception, and association health plans were no exception. The time has come for us to refine this product this year, now, after years of concerted effort on the part of Connecticut's small businesses to bring this issue into a place where it is ready to be refined and made workable. What I hear in the opposing testimony is largely, to my ear, outdated and stale information based on experience that happened a long time ago. And it's change is hard. We know that in this business. But we have an opportunity now with a bipartisan coalition, with a large coalition of industry. And I think with the time is right post-COVID, we have an opportunity to actually make a real change in this marketplace, create more choice, which will ultimately favor the consumer, and help Connecticut's small businesses compete with their larger counterparts. When our relative share of our operating budgets is so much higher for a small business, how can we be expected to grab market share against the people that we compete with? So I appreciate all the concerns that have been addressed today, but I would commend this committee to the experience of the Maine Insurance Trust that I attached to my testimony. And I would commend this committee to seize upon the opportunity that we have before us this year. Thanks, and I'm happy to take any questions.
Thanks for being here, Bruce. Really appreciate your testimony. I think we heard some opposition that, like you said, was based on something that may have happened decades ago here, and we're looking to create a product to address those concerns and solvency issues. And one of the things, the story that I want to share with the committee, I shared it this morning in a press conference, is that one of a CFO from one of the community banks, was making a good salary, and he has kids, several kids, and his family deductible is $17,000. And he is one medical issue away from not being able to pay his mortgage. The opposition here today said that he would end up on the exchange. That is not happening. What happens is that your banks take care of their employees. And what it means is everyone that's employed just has a higher premium when a catastrophic health issue happens. They're not firing people and telling them to go on the exchange. And so this is what the association health plans, the stories that your employees have shared with us, that we want to keep here in Connecticut, that we want to continue to employ here in Connecticut and work in these credit unions that are providing valuable service to our community, sponsoring teams in our towns. These are the people that we're trying to help here today. So I want to thank you for having your employees be so involved in this process. They've been very active in helping us craft this bill and making sure that we're moving it in a way that meets their family needs. So thank you for that.
Thank you.
Representative Delnicky.
Thank you, Madam Chair. And thank you for coming forward, Bruce. I think, what was it, 4 or 5 years ago? I think you first raised the issue in a public hearing in banking. You kind of snuck it in to plant the seed. And with any luck, that seed will grow and it will become a tree just like the credit unions grow. And I'm proud of the fact that I served as a board of director at the Metropolitan District Employees Credit Union and as the vice president there for a couple of terms. So I want to ask you a very simple question. If municipalities have the right to go ahead and create this type of insurance, and from my perspective, it has been very, very advantageous in my community, South Windsor. It has been successful. If municipalities have that right, do you think the credit unions and the business community should also have that right?
Representative, in whose voice am I answering? If I am answering on behalf of the credit unions, I should say, of course, we should have that right. If I'm answering on behalf of Connecticut's small business community that's struggling to succeed in a challenging economy, of course, we should have that right. But if I'm speaking perhaps as a policymaker who needs to shore up an exchange that's in a troubled state, I'm going to come up with reasons why that's not right. I think that this is a very sensitive issue that is not cutting across a balanced solution, given all of the interests that are competing here. And so we can't focus technically on, we can't say that the exchange is of utmost importance, that must be protected at all costs. That's not what we do in this business. That's why we call it making the sausage. It's messy and it's human and it's real. And our small businesses are struggling to pay their healthcare cost. I can't compete. An 8-person credit union cannot compete for talent against a 100-person bank. Can't do it. So we're going to continue at 6%, 5% market share as against banks, and they're going to continue at 94, 95%. And we're going to preserve this status quo and not let these credit unions grow and provide the community services that they are designed to do to help people to invest dollars in their local communities. All because some policymakers are telling me that that 8-person credit union has to do its part to shore up the exchange. Doesn't seem right to me.
So then I take that as a yes.
It's a yes, Representative.
And I appreciate the answer because it was a very, very well thought out answer. And you're right, when it comes to credit unions, they provide a service. And for many people, they're the first opportunity someone has to actually borrow money and establish a good credit history. And I think the opportunity we have here to empower small businesses throughout the state of Connecticut to have an option. They don't have to take it. They may want to take it, but to have that option, I think, is key and critical and something that we need to do. And I want to thank you for coming forward. And I want to thank you for the fact that you planted that seed a number of years ago about the example in Maine. And do you want to just make a quick comment about that so that we
about Maine
fully understand what they've done there?
So Maine, I'll start at the end and I'll make this quick. Maine in the last renewal included an extra margin in what they required their participants to pay. And they did that so that they could anticipate the return of elective procedures post-COVID. And so they were there, ready, willing, and able to buy down the renewal cost for their members. And not for nothing, remember that my members of my credit union association are not going to pay me dues if I hand them a crappy program. Not going to do it. I need to inspire people in my leadership as running a trade association. If the 8-person credit union or the 25-person credit union, if those employees are so fed up with their insurance, their health insurance, that they're getting angry at their CEO, I'm going to hear it. And they're going to threaten to pull their dues money from my association. That's another human factor here. I have a business, my personal business, have a business obligation to keep my members happy. And when their employees are unhappy, I get angry phone calls. So what Maine does in carrying out its fiduciary duties to its members is it makes sure that there is extra money when they anticipate a rough renewal season. Just in January 22, they provided a payment holiday because they had such good financial performance that they told their participants they didn't have to pay premiums for a month. This is the whole purpose, is to lift up this community as one, at least in my industry, which is a not-for-profit industry, to fuel their efforts to support their communities and do good work in their state. And in doing so, they've worked out a way for, they had a lockout provision when they formed the entity of 3 years. They had, you had to contribute 3 months of premium. They submitted to all of their insurance department's regulatory requirements. They posted a surety bond. They did all sorts of things, and they have weathered COVID successfully and are still cheaper than the open market and better.
And one final question pertaining to the experience there. Have there been any failures in the plans?
Not to my knowledge. I'm only because I'm a lawyer, I won't promise you, but the answer is essentially no.
Well, I thank you for your testimony, and I thank you for coming forward tonight to talk about this. And I want to thank the chair for the opportunity to ask a couple of questions here.
Thank you, Representative.
Thank you, Senator Wong.
Thank you, Madam Chair. Bruce, thank you for your time. And you did a wonderful job kind of evoking George Bailey in A Wonderful Life, talking about the credit union. And I don't mean that facetiously. I think the membership quota and the kind of commitment and connection you have to your dues paying members are important. And dare I say, you would not lightly go into this in strong support of this program if you've not seen past evidence and understand the mechanics. You're a lawyer and you're a business person. You understand risk and obviously the challenges of the healthcare marketplace. You're not a healthcare expert, but you're a businessman, so you understand. You don't go and take on this risk lightly, because should it fail, it's egg on your face and the betrayal of your members' trust in your ability to do business. Would that be fair?
That would be fair. And I would add one more thing, Senator, that as regulated institutions, if my members made poor financial decisions with where they were contributing money, let's say into an insurance trust that was run shoddily, then they have a regulatory problem too. So yes, the need for success is high, and we are prepared to deliver them that success.
And I appreciate your comment and your answer to Representative Delnicki, and as an advocate, you would support this program. As the president of the association, you would support this program. But as a legislator, you understand the challenges and where we're ebb and flow. Your input representing your membership, the vast majority are small businesses. They're mom and pop stands that are, you find, evoking the stories that Chairwoman Woods had talked about. Successful people, but they can't get the insurance. Right. This is a solution to accommodate a critical need for people that want to do the responsible thing to provide health insurance and healthcare coverage for themselves and their employees. But in some cases, because the unaffordability of it and the continually increased cost and the marketplace that we're in, we have to do something different. And this is something different.
Right.
And we have to be able to provide, because what's going on right now is absolutely unsustainable. You feel the same way as well.
I do. I listen to people like John Carl Casa from the Nonprofit Alliance talking about how, you know, these costs are limiting the social safety net out there, you know, given by our private nonprofits, is putting holes in that net because they can do fewer services, having to pay for higher cost healthcare or not being able to attract and retain talent. The same for us. We have small credit unions, bigger than you'd think, not just the 8-person size, who are making maybe $10,000 a year in profit, right? Maybe. And they can't even hire another lending officer to help people, you know, get a loan. Or they'll say, I'd love to lend money below a 600 credit score, but I can't put the reserves in. I don't have the cash to reserve for that. If we can lower these operating costs for these credit unions, they may be able to be the lender of last resort for more people, instead of driving those people into the hands of payday lenders, et cetera. So that's why this stuff is messy and human and real. And I thank you for recognizing it.
No, absolutely. And you just gave me another example, the George Bailey example. I mean, you are part of the fabric of the community. So thank you for your time, and thank you, Madam Chair.
Thank you, Senator.
Thank you, Representative Meskers.
So I feel I was one up to both a lawyer and a banker. You'll have 2 interviews with St. Peter with that resume. Look, I want to thank you for your testimony. I think it's very meaningful to all of us, particularly the issues about having the credit quality to lend to people. I don't think it should be lost on any of us here in insurance. I sit on commerce. Private insurance, health insurance is going at the rate of $35,000 a year with a low deductible plan for a family. At some point, our corporations are going to look at, and compounding at 7%, at some point, the salary is going to be lower than the health insurance cost. And if we don't get control of it in insurance, and we're going to end up with a public option that just shifts the price burden to the government and doesn't resolve the drivers of price. I understand the insurance companies, you know, they do have conflicts with their pharmacy benefit managers, et cetera, and their purchases of various parts of the equation. But all the parts of the equation are generating ridiculous profits and ridiculous charges to the consumers. And that's what I hope that this bill makes its way through with acceptable clauses and provisions that we're concerned about, because we need more taxpayers. We need a bigger and more robust economy in the state. And the work you do is really important. So I wanted to stop it and thank you. And you'll still get through before I get through. So don't worry with St. Peter.
Thank you, Representative.
Thank you. Any further questions? Thank you for being here, Bruce.
Thank you.
I'm being told that Paul Galena is on the line.
Hello. Good evening, Chairman Cabrera, Madam Chair Wood, and members of the Insurance and Real Estate Committee. My name is Paul Galeno. I'm the Vice President of Finance and Managed Care at Stanford Health. Stanford is an independent nonprofit healthcare system that serves Lower Fairfield County. We employ more than 3,800 people, making us the largest employer in the city of Stanford. And we're committed to providing friendly personal care coupled with the most sophisticated services to all residents in Lower Fairfield County. I'm here today to testify in opposition to House Bill 6620, an act promoting competition in contracts between healthcare carriers and healthcare providers, and Senate Bill 983, an act limiting anti-competitive healthcare practices. House Bill 6620 in sections 1 and 2 of Senate Bill 983 ban certain clauses in commercial contracts between providers, such as hospital payers and third-party administrators. And I'm going to focus my comments on those provisions. These interfere with private party contracts. Both bills insert the state by statute into contractual proceedings of sophisticated private parties. These private negotiations take into consideration many factors that are often impacted by fluid market dynamics. Regulating the contracts by statute will set a bad precedent and have many unintended consequences. A second problem with these proposals are that they significantly advantage the insurance industry and healthcare contract negotiations and really disadvantage your local hospitals. I fail to see how this proposal would benefit patients. There's no tie-in to either of these bills that requires insurance to lower their rates. And given the national scope of insurers and their volumes, not sure why the state would think to tip the scales in favor of the insurance companies. Preserving the ability of hospitals to use these contractual clauses that these bills would ban will ultimately ensure that physicians are ultimately making the medical decisions with their patients and guiding their care. We urge the committee to reject the proposals as one, intrusive into private entity contracting processes, and two, they enormously advantage the healthcare industry over hospitals. Thank you, and I'll take any questions.
Thank you very much, Paul. Any questions from the committee? Thank you for waiting online, Paul. We appreciate it. Next up, we have James Carden.
Good evening, and thank you for the opportunity to speak with you. My name is James Carden. I'm Executive Vice President, Chief Clinical Integration Officer for Hartford Healthcare. I appreciate the opportunity to comment on an act limiting anti-competitive healthcare practices, specifically in opposition to the statutory caps on commercial contract negotiations. In essence, what we do is we care for people. To do that, we have to rent stuff and buy stuff and compensate our dedicated colleagues who enable us to provide that care. Every system is perfectly designed to deliver the care it achieves. Our current system is creating challenges for patients, providers, and payers. Payment models are an essential component that needs to be changed. However, the proposal to statutorily cap commercial negotiations is a misguided solution. Providers struggle to meet the cost to provide care at current aggregate payment rates. That was true prior to inflation's impact on cost of goods and services, and ensuring that we have the resources to attract and retain colleagues to provide care. A consequence of this is that commercial negotiations are necessary for providers to achieve financial stability. Creating a statutorily imposed rate cap at a level that will not meet the cost of providing care to Connecticut residents would result in significant limitations for the provider to meet expectations for access, equity, and excellence. We would be financially unable to provide the care that we hold ourselves accountable for and our communities deserve under the proposed legislation. Our ask is that you carefully consider the proposed legislation with real understanding of the consequences that would inevitably occur. Thank you for your time, and I'm happy to answer any questions.
Thank you, James. I just wanted to follow up on your comment that this would limit access to centers of excellence. Can you just elaborate on that a little bit?
Yeah, I think that importance, those centers of excellence require significant complex care that often requires expertise and capabilities that are not always widely available. And if we are looking at what we need to do in order to meet a predetermined price cap that will influence what we get paid across all of our aggregate payers, there's a very good chance that our ability to afford to attract the talent and the equipment and the needs of those providers to provide that care, that kind of excellence and that kind of quality could become significantly challenged.
Great, thank you for your question, for your answer. Representative Nuccio?
I don't have my hand up, ma'am.
Sorry about that.
That's okay.
James, thank you very much for your testimony.
Thank you for your time.
Next up, we have Ellen Andrews. This is weird.
It's been a while. I'm Ellen Andrews from the Connecticut Health Policy Project, and I want to thank you for the opportunity to express our strong support for SB 983 and HB 6620. In sum, Connecticut's healthcare markets are increasingly consolidated and less competitive, driving up costs and premiums, reducing access to care with no improvement in quality. These bills can level the playing field, support competition, lower premiums, and support value-based purchasing. They actually remove barriers to the kinds of payment reforms that you've heard about. Oh my word, that's me. Sorry. And reduce overall healthcare costs. We also support SB 983's limits on out-of-network bills to Medicare payment rates, and I urge you to support them. Consolidation is something we haven't talked about, but also stresses already overstressed hospital staff and clinical staff. And I hear about that every day because I teach nurses. So I think we don't think about that. It also reduces consumers' choices of care. I live in New Haven. I used to, it was a while ago, when I gave birth to my son and I had a choice of 2 hospitals, I no longer do. You know, my daughter-in-law will not have that choice. There's only one place to give birth in New Haven. And it also lowers the payers' levers to choose better quality for their members. Concerns have been raised about limiting consumers' access to care. If these clauses are prohibited, why can't we have all the hospitals in a network? And you can. Nothing in this stops a plan from contracting with all of them. It just says you don't have to. They can't tell you what your price is. It's just a negotiation. It levels the playing field. And it still allows tiers and steers patients to better quality and lower cost options. In fact, it makes those tiers actually meaningful by not, a provider that comes in that isn't good quality or cost efficient can't demand to be on the best tier. It makes tiers meaningful. It makes value-based purchasing meaningful. While we support it, we recommend a couple of changes. One is we have a concern with a provision in both bills that exempts accountable care organizations, groups that have pay for performance, things like that. That is not the intention, I know, of either this committee on the bill that you put forward or the governor's office. And we are working through trying to find a way to encourage value-based purchasing, but still not make the bill pointless, because every one of the health systems would be covered under one of those waivers. There are a couple of other smaller ones. We also strongly support the out-of-network payment rate limit at Medicare levels in SB 983. This bill builds on and strengthens the Federal No Surprises Act that passed in 2020. It will improve access and affordability of healthcare, eliminate a large contributor to medical debt, bankruptcy, and financial stress on households. Over 95% of doctors in Connecticut take Medicare.
Ellen,
right
I'm
now.
really sorry to interrupt. Your 3 minutes are up. Please summarize.
Of course they are. So doctors are already taking Medicare, so it's not out of the range of what they're already agreeing to. And also the putting doctors, she's not a commissioner, Director Gifford said, we want doctors to be in the networks. One of the things about being in the networks is not just the payment rate, but it's also the quality requirements to be in a network. And I think that's really important. So I'll stop now.
Thank you, Ellen. I do want to ask a couple questions because you have been, really working with this committee. We did a forum in 2020.
We did.
On this, and you've just been a great voice to have at the table. So we appreciate all your work. One of the things that Ted Doolittle said he didn't agree that the CID should be able to waive some of the protections.
Yeah.
What was he referring to with that?
That is in 6620. It allows for a potential waiver from the insurance department.
Yeah.
for a health plan, health system
Yep.
rather, or I guess a health plan if they wanted an all or nothing. I don't know why they would, but, and I think, I understand that this is complicated and having an escape hatch sounds, attractive, but I worry about that, even though that this administration and this CID would probably not do that, you know, just give everybody a waiver. That's not always been the case in regulation in Connecticut. There are many times that, you know, an agency is really very biased one way or the other. And administrations change. And when you're writing a law, you're writing it forever. So I think that's unnecessary. And other states haven't included that in their laws.
That makes sense. The last speaker said that this would limit access for patients and cause hospitals not to be able to afford staff and equipment. Can you comment
Yeah,
on that?
he was also talking about price caps, and I think he might have been talking at that point about the out-of-network Medicare piece, because that's the only price cap I see in those two bills. So I think the continuity of care is that you have choices. The other issue around consolidation is that it has reduced service cuts. For instance, birthing centers have been going away as health systems got bigger and bigger. So that, like I said, I used to have two choices of where to give birth. You no longer do in New Haven. So I don't think that that's a fair concern. In terms of the price cap, he won't be capped if he joins the networks and negotiates a fair rate with them to come in. We don't want to be in the middle of that negotiation, and we want him in the network because we want him to, you know, to be a part of the quality standards that being in a network comes with.
And that's pretty much the same for the plastic surgeons that we've heard from today. I mean, if they're participating in the network, their argument against, you know, not making the same amount of money and employing their staff is really not the same, correct?
Right. Yeah.
Okay, great. Any other questions from the committee?
Representative Nuccio has her hand up online.
Representative Nuccio.
Now I have my hand up, Madam Chair. Thank you. Ellen, I think you just brought up a really good point, something that kind of skipped my mind too. When we look at medical debt, the difference between an in-network and an out-of-network, correct me if I'm wrong, but an in-network and an out-of-network provider is balance billing. If you are in an in-network,
It can be.
yeah, so if you're in-network, you agree to the negotiated rate plus the patient's share of that negotiated rate. If you're out of network and you're charging, you know, 400 times Medicare or anything like that, and the insurance company pays X amount because it's whatever their out of network benefits are, balance billing of anything that is not paid falls back on the patient also. And I do think, you know, I'd be very curious to see how much of the bankruptcy debt that we have was in relation to an in or out of network claim. I don't know if you happen to have any information on that. I know you're pretty well versed on the debt section and such.
Sorry, I don't, but that's a great question.
Right. So so overall, you're supportive of this bill?
Yes.
Yes. Okay. And I appreciate that. Thank you, Ellen.
Thanks.
Any other questions? Representative Pavlik Tomato.
I was just wondering, I don't know if you testified about this, but I have heard about the statistics and bankruptcies, and I was wondering where that information was obtained from.
Interesting. I don't want to geek out on you, but if they old assessments of that, studies of that only looked at things that were in collections. That missed people who had put things on credit cards, people who had payment you know, plans with health systems. And so a new study found that it was much, much higher. And I'll get it wrong if I give the number, but I wrote an op-ed about it.
I was just wondering, because I've been practicing bankruptcy for probably like 20 years, and I know the court doesn't keep those statistics specifically, so
no,
it's
a problem.
It's hard to obtain like exactly what the main reason for bankruptcy filing is, and I'd agree with the credit card. Because yeah, when somebody puts on a credit card, then it's difficult to ascertain,
Was it medical or did
that-
they go to
right,
Disney?
right, because it's listed generally as a credit card, but yeah, I've never been able to, at least in my experience, the medical, as far as medical reasons, it's, for it to be the highest now, I mean, that kind of surprises me, but again, I can't say for sure because I don't know every, reason that somebody files, but at least in my experience, it never has been. It did occur, of course, but not as far as the leading cause of it. So yeah, if there's any resources that you have as far as that goes, I'd
Based on
love
a
to see it.
survey that's done by the census and they added that as a question a few years ago.
Thank you.
Sure.
Any other questions? Senator Wong.
Thank you, Madam Chair, and I want to be quick. Ellen, it's great to see you in person. Thank you for all of your work. I always value and appreciate your perspective, your sincerity. On 6620, is it atypical to have to grant power to the Attorney General to
I was gonna
seeking
get out of here
action?
without having to pick between CID and AG. Is it, what was your question? I'm sorry. Is it typical to have the Attorney General?
Just say whatever you need to say.
Because I will anyway, right? I am agnostic as to how this is enforced. I've said several times, if this ever gets to enforcement, we've already lost. It's something that I hope and has happened in Massachusetts, and it looks like it's happening in Nevada where they passed this bill as well, that this is something that is used in negotiations to say, you can't do that. We would love to have a contract with every one of your hospitals and every one of your, physician practices, but let's start negotiating those rates instead of, you tell us. So whether it goes to the Attorney General or the Insurance Department, I'm agnostic. I will say I've had discussions with the Insurance Department and they don't want it. And the Attorney General's office is still taking my calls. So if that's how I vote.
What a wonderfully politically savvy answer. I'll leave it at that. Thank you, Ellen. It's great to talk to you. It's great to see you in person. Thank you, Madam Chair.
Thank you, Ellen. Next up, we have Rachel Diamond. Rachel, did you bring us beer? Oh, my.
Madam Chair, if I might, there's no reason to hear testimony if there's no beer.
Thank you. Hi, everybody. Thank you so much to the Insurance and Real Estate Committee for having me here today. My name is Rachel Diamond, and I'm the Executive Director of the Connecticut Brewers Guild. And I'm also the Head of Distribution and Brand Development at a brewery in Bethel, Connecticut called Broken Symmetry. I'm humbled and honored to be here today to speak to you on behalf of the 120 wonderful breweries here in Connecticut. In 2019, our guild proposed an association health plan that would help our breweries obtain easily accessible and affordable healthcare. And we had overwhelming support then with 50 co-sponsors here in Hartford. And we truly are grateful that you've kept the torch alive and are allowing associations to benefit from the access to reliable and affordable healthcare. I've listened to in the past few weeks to other trade associations discuss the importance of keeping the costs of healthcare low for small businesses and the importance of enticing and retaining skilled labor here in Connecticut. And these are all very valid points. Small businesses are the backbone of our state, and finding ways to keep costs low and providing a better workforce is incredibly important. It keeps our industry growth moving, and that's just wonderful. However, today I'd like to discuss something a little bit more personal. My brewery employs about 20 people, and being a job creator is something that we are incredibly proud of. We are very small in comparison to the other craft breweries in the state, and these employees are the reason that we exist. They come in every day with positivity, creativity, energy, commitment, and dedication, and we are not unique. Every brewery in Connecticut feels this exact same way about their staff. Without their high level of care, we would not nearly be as successful. Obviously, beer is a business where you get to make a lot of people happy. A lot of people. We see a lot more smiling faces in our industry than probably any other, in the state. But breweries truly abide by their belief in community, local and far-reaching. I know here in Connecticut, our breweries have raised money for local food banks, fundraised for critical causes like leukemia and cancer research, local families that have lost their homes in fires, and even thousands of dollars to the International Rescue Committee to help children affected and displaced by global humanitarian crises. Our owner and head brewer at Broken Symmetry, Chris Sanzini, says beer is family, and our Connecticut breweries live and breathe that. It goes beyond how we feel about our employees and our patrons. It also applies to how we feel about each other. The brewing community in this state is filled with the smartest, kindest, and warmest people. We help fellow craft breweries. In fact, just this week on Wednesday, we had a brewer pull in hot to our parking lot and say, help, we need some can lids. And of course, we obliged and we rely on each other for all sorts of things, grain, hops, yeast. If you need help with recipes, we even send our customers to each other's breweries. If you like this brew, you should try this other person's brew. And we believe that community is firmly established in our little industry. Caring and service to others is a large part of what
Rachel,
we do.
I'm sorry to interrupt. Your 3 minutes are up. Please summarize.
I'm almost done. Okay. Caring and service to others is a large part of what we do, and our employees have waited patiently for us to provide the care that they provide to us. So please help our small businesses, our little community oases, who strive for examples of what industry cooperation care should be, and put us in a position to practice what we preach and care for our workers in return. So we fully support the House Bill 6710, and we thank you for all that you have done to get us this far.
Thank you for being here today and sharing the story. I think it's so great for us to hear really what small businesses are dealing with, how you're working with the community, how you're working with each other. And really, we are putting this bill forward to help businesses like yours. So
Yeah.
thank you.
There's a lot of us that can't provide insurance to our workers because it's cost prohibitive. And we would prefer very much to have something that gives us the chance to provide that to the people we care so much about.
That's so great. Thank you. Senator Wong.
Thank you, Rachel. Your energy is infectious. It's
Oh.
wonderful.
That's without the beer. Imagine what I am.
Well, we're still working, so no beer right now, but for anybody's interested, this location in the great town of Bethel is ideal. It's right by the train depot. It's a wonderful place. You all should go. And we have an invite from you, right?
Yes, it is the old train station.
There you go.
There you
There you
go.
go. But from my experience talking to people that've gone into craft brewing, it's a labor of love.
Really is.
You're not in it to make millions of dollars, but it is a family, and without a lot of margins on your business and the difficulties you've had in COVID, and the unique treatment of it as kind of an entity that's not fully understood. This opportunity to be able to buy affordable health insurance is just, how would you describe that?
I can tell you, I'm a mom of 3, right? So I have a family, and if we have 20 people at our little brewery, just imagine how many moms and dads and families are out there that really need this kind of help. And like I said, they really do put their all into what they do for us. It's not an easy job, and it's not a well-paid job. You do it because you actually really love it, and you love that community contribution that you can provide. We feel America was founded in these types of places, to go and have a beer and sit down and talk over ideas. So we truly, it would be such a relief to provide that for our community, to support the community at large. That's really how we feel about it.
And you represent the guild as well,
Mhm.
and it is a very close-knit group. It's a super cool culture. Part of the appeal of this association affinity group. And make no mistake about it, nothing's ever guaranteed in life. But as part of an association, you know who these people are. And you're forming a group where you understand the risk. And it'd be hard pressed to jump into anything that seems to be too good to be real. You accept that. And I think from the way that you and the association have done the homework, queried, and made sure that every single member is covered to address the concerns that have been raised about exclusion and selectivity. It's really important for you to be able to be part of a program where you can afford to take care of your 3 kids, but also that everybody in the association that wants to buy into it can buy into it to get the insurance and the peace of mind that's so critical.
Yes, and we rely on each other now for so many things to sustain and keep each other afloat, that the idea that we would want to kick somebody out or let somebody down or preclude somebody from having a good quality of life when they have provided and afforded us such a good quality of life, that is not what we intend on doing with this type of healthcare act. We would use it to its fullest, and we would provide for our members.
And that's the unique lure, in addition to the economics, the logistics and the cost, and it is an affinity group that you're all kind of rowing the same way in a passion that you're in the business. And that's another part of the lure.
Yeah. We really do intend to make people happy. That's really all it is.
Yep. Well, for all those people who are listening, right? Broken Symmetry in Bethel, Connecticut.
You don't have
Go
to give
visit.
me a plug. but
I'm happy to give you a plug. Thank you very much. Thank you, Madam Chair.
Rachel, thank you so much for spending so much time with us today and waiting to testify, and we enjoyed hearing from you.
Thank you so much. Thank you, guys.
Next up, we have Karen Siegel.
Good evening, everyone. Thank you for listening to my testimony this evening. My name is Karen Siegel. I serve as Director of Policy at Health Equity Solutions. We're a nonprofit organization with a statewide focus on advancing health equity through anti-racist policies and practices. And I'm testifying today in opposition to House Bills 6710 and 6712. As a result of the consequences of systemic racism, Black, Indigenous, Latino, Latina, and other people of color in Connecticut are disproportionately likely to find healthcare unaffordable. Unfortunately, the proposals before you here today are unlikely to make healthcare affordable, have a high cost, and would erode the quality of health insurance in our state. And for those reasons, Health Equity Solutions opposes these measures. Regarding House Bill 6710, association health plans were outlawed in Connecticut and many other states because they look and seem like health insurance, but do not provide comprehensive health coverage. Given Connecticut's wealth gap and the disparities in health insurance literacy experienced by Black and Latina people in Connecticut, these plans would offer the allure of a lower upfront cost to the very people who can least afford the costs they would incur when seeking care while members of these plans. In other words, association health plans would amplify rather than address the affordability challenges already faced by enrollees in high deductible plans. Let's be very clear, if the plans are not subject to federal regulations, that would, for example, mean keeping people from receiving no-cost preventive care and other vital health care that is required to be covered by state and federal law. Further, some association health plans have been documented to defraud enrollees or end up insolvent, in part because of the lower level of oversight that they receive. And finally, the American Academy of Actuaries notes that creating separate rules for association health plans fragments the market and could undermine the stability of the Access Health Connecticut Exchange. Regarding House Bill 6712, the State Health Insurance Exchange makes marketing and enrollment efforts, manages marketing and enrollment efforts from which carriers profit. So despite far lower spending on healthcare in recent years, all carriers requested large premium increases in 2023, which indicates that those costs and savings are not being passed on to enrollees and would not be passed on in this case either, most likely. Alternative policies are much more likely to improve both coverage and affordability. Connecticut has very high rates of health insurance coverage. Affordability really is the key concern in this conversation. Other bills under consideration in 2023 that are relevant include expanding access to covered Connecticut and Husky health programs, controlling hospital and pharmaceutical costs, and strengthening hospital financial assistance policies. Thank you again for the opportunity to share this testimony today, and I'm happy to take any questions.
Thank you. Any questions from the committee? Great. Thanks for joining us, Karen. Next up, we have JP Weisky.
Good evening. I am JP Weisky. I am with Horizon Government Affairs. I am representing a number of entities here, including the Council for Affordable Health Coverage, a big tent organization, the American Insurtech Council, and the Health Benefit Institute, and other clients in supporting 6712, especially Section 4 related to the premium taxes. In my prior experience, just for reference, I am a former regulator in the state of Wisconsin. I would note that the premium tax as proposed will have three main impacts. It will, in fact, lower consumer costs. It will, in fact, increase the availability and expand consumer participation in the Connecticut insurance market. And three, it will lead to a more competitive Connecticut insurers as they sell across the country in other states. And I'll explain these briefly. So first, premium taxes are tracked inside rate filings. They are a direct impact on consumers. This does not impact anything related to regulatory costs. Those costs go generally into the state coffers and are used to fund other state entities. So this is a straight up reduction in premium costs for consumers. These lower costs also lead to expanded coverage availability, the opposite of the sort of death spiral discussions we've had related to other segments of the market. So this will certainly help that market out. Third and last, and by the way, this applies to all lines of insurance. So this is not just a health insurance issue. This also applies to property and casualty lines, homeowners insurance, as well as coverage for auto insurance. Last, I would note that states have what are called retaliatory taxes. They look specifically at the tax rate that the state of domicile is, and they will charge the insurance company either their tax rate or the state of domicile. So in this case, Connecticut. Lower tax rates means that Connecticut insurers pay less taxes in other states as they look at retaliatory taxes. So this will help make the insurance market more affordable. I will note that in my experience in the state of Wisconsin, in closing, that we frequently had conversations with insurers that were looking to re-domicile, and that was one of the premium taxes was one of the issues we certainly brought up because Wisconsin does not in fact charge a premium tax. I'll stop there and happy to answer any questions.
Hi, JP. Thank you for joining us today. It's good to talk about this bill that we haven't heard any testimony on yet, and
Yes.
really summed it up. I hope everyone was listening to all that. Wisconsin has kind of taken our steam away as the insurance capital.
Yes.
And your last statement there was that Wisconsin charges 0 premium tax and Connecticut is at 1.5%. The goal of this bill was to encourage insurers to domicile back in Connecticut. As you know, in the health insurer carrier space, we have some plan designs, especially in the small group market where carriers have left. So what we're trying to do with this bill, which you've summed up wonderfully, is encourage more competition in this space. We're also trying to do that by bringing more options to the small group market through association health plans. So we're not looking just for a silver bullet here. We're looking for many different options that this committee can work on to help increase competition and ultimately lower costs for people in the state of Connecticut. If you can just expand on what the lowering from 1.5% to 1% could potentially mean in attracting new insurers to domicile here. Would we be high compared to other states, or are we in a space that's more competitive?
Now, I think, so in my written testimony, I provided a link to the retaliatory tax guide. If you're having trouble sleeping, that may be a great thing for you to take a look at. It's very detailed. But I think in summing up, there are about 4 or 5 states, I believe Nebraska, who again is another state who is coming for Connecticut, Ohio, Iowa, and I believe one other state have lower premium tax rates than what you're proposing to do, or excuse me, than where you're at now. This would make you more competitive. I would note that when we look at a number of the Wisconsin domiciles, we have some large carriers domiciled in Wisconsin who have multiple insurance licenses in multiple states, and we have seen them shift business from that domicile into their Wisconsin domicile because of the competitive nature and retaliatory taxes. So it does provide some advantage. It does potentially provide some employees that will come, workers that would come back into Connecticut. And the lower premium taxes has in addition to helping with the competitive nature of locating in Connecticut as a state of domicile, it has a secondary effect by lowering those overall insurance costs. It makes it cheaper for consumers to buy. And by making cheaper for consumers to buy, that makes a risk pool better. It broadens the risk pool. It means people are able to better afford lower deductible policies. We're talking about a really high health insurance deductible policies. This won't solve all the health insurance problems, obviously, but it is a small piece. And it is a direct consumer gain by having those lower taxes, because premium taxes are a piece of that.
Do you think we'd be able to attract more carriers to the exchange if we lower the premium tax?
I think it will help with the underlying cost base. So it again, by making insurance cheaper, even with the subsidies, by making insurance cheaper and making the administrative costs cheaper for the insurance entities, it makes Connecticut more attractive to be both in the exchange and out of the exchange, and to provide coverage across the entire market. So health insurance, certainly, but auto insurance, homeowners insurance, and other lines as well. It will help across the board in attracting carriers into those spaces to be a little bit more competitive. Yes.
And I know you do have experience in Wisconsin, but last NQIL meeting, I was sitting next to a legislator from Wisconsin who was sharing with all the legislators how low costing her car insurance was. And she was naming, I think there's several dozen car insurance carriers in the state. So because of the competition, she was actually shocked when we were sharing some of the auto coverage and pricing, that we have in Connecticut here. So if you can expand on that a little bit.
Yeah, I would note that in the state of Wisconsin, we have roughly 330, I believe, domestic insurers operating in the market. And we have over 2,000 insurers generally across all lines in the market. So there's a significant competitive marketplace in Wisconsin. And we always like to view, it's a very consistent regulatory market, similar in some ways to the consistent regulatory regime that your insurance department has. And we try to be tough but fair from a regulatory standpoint. But again, taxes are a big piece of that, and lower taxes mean it's less expensive to provide coverage in the state, and that attracted more carriers in.
Thank you. Any questions from the committee? Great. Thank you so much for joining us here today.
Thank you.
Next up, we have Rosanna Ferraro.
Hello, chairs and members of the Insurance and Real Estate Committee. Thank you for the opportunity to testify this evening. I'm Rosanna Garcia Ferraro from Universal Healthcare Foundation of Connecticut. We are committed to a Connecticut where health justice is truly achieved for everybody. I'm here to voice our opposition to HB 6709, HB 6710, and HB 6712. For us, universal means everybody, and these three bills do not help everybody. These three bills don't address the underlying prices of healthcare, harm the insurance market, and ultimately, and most importantly, hurts people who rely on private health insurance. The warnings of the state healthcare advocate and others are exactly our fears. We don't need any wiggle room for further destabilization of the small group market, for potential discrimination based on pre-existing conditions, for plans that will effectively kick folks off when they get sick with high premiums, or plans that don't cover important healthcare services. You put HB 6710 together with 6712, which puts the onus of funding Access Health CT on the state rather than with the insurers. And 6709, which seems to bypass Access Health CT entirely for the selling of qualified health plans. It looks like a trifecta of bills that weaken Access Health CT and worse, consumer protections in private health insurance. There's a reason that in Connecticut, Access Health CT exists and association health plans do not. There's a reason the Patient Protection and Affordable Care Act passed. It was needed. It's not perfect, but it does protect folks that rely on private insurance. What concerns me is not the testimony of those who stand to profit from association health plans or the other bills. I'm most concerned about the people, the families who will be harmed by these proposals. And I'm thinking more broadly about everyone who relies on private health insurance in the state, not just those that would be covered by association health plans. HB 6710 is a risky way forward. We've seen this game before and people lose. I don't want to watch the replay and urge the committee to reject these proposals. Thank you for your time this evening.
Thank you, Rosanna. Any questions from the committee? Representative Pavlik-D'Amato.
Thank you. I was just wondering, I know you said that the current system or the Affordable Care Act wasn't perfect, but I guess I'm a little confused because I mean, do you think that the high deductible health plans, I mean, that is working? I'm just curious as to why we're here. If it is working, then I'm not sure why we're putting forward this other legislation. So maybe you could clarify just your statement previously. Thank you.
Absolutely, no problem. Thanks for the question. What I meant about it not being perfect is that there are some issues around affordability that I think personally can be addressed with some of the other bills you have before you today, and not 6710 or the other two bills I mentioned. I do think that the Affordable Care Act did do well was protect folks with private insurance coverage. If there hadn't been problems and abuses in the system, there wouldn't have been necessary protections from those mechanisms that were making getting care under private health insurance really difficult for some folks. I understand that it is not a favorite of everyone, but I do think that the private health insurance protections are incredibly important. And we have concerns around 6710 and the other bills really weakening them. And like I said before, I think it's a risky way forward.
Thank you very much for your time, Rosanna. We appreciate it.
Thank you.
Next up, we have Patience Crozier. Next up, we have Catherine Crashell.
Thank you. Hi, Senator Chair Cabrera, House Chair Wood, and Insurance Committee members. My name is Catherine Crashell, and my wife and I live in Mystic with our 2-year-old son, conceived with lots of love and a little science through in vitro fertilization or IVF. I teach the Reproductive Rights and Justice Clinic at Yale Law School and have served as the executive director of Yale Law School's Health Law Center for the past 5 years. I'm very encouraged to see language in Section 11 of SB 1039 that would change the state's current law requiring private employers to cover particular types of fertility care, such as IVF. SB 1039 removes the age 40 limit in the current law. This change will codify compliance with the important anti-discrimination provisions of the Affordable Care Act. However, this is just one way in which the current law needs updating in order to make the state's requirements for fertility care coverage more equitable. In collaboration with other reproductive rights and justice and LGBTQ advocacy organizations, including Planned Parenthood of Southern New England, GLBTQ Advocates and Defenders, Equality Connecticut, Resolve New England, the Center for Reproductive Rights, and the National Health Law Program, we have formed a campaign, the Fertility Access Connecticut, or FACT, to support HB 6617, our bill. This bill is sponsored by Representative Curry and is one of the priorities of the LGBTQ caucus and part of the Reproductive Rights Caucus's agenda for this session. HB 6617 would further improve access to fertility care by doing 3 main things. First, it would provide access for Connecticut residents who receive their care through the state's Medicaid program. Second, it would explicitly require coverage for the medical care single and LGBTQ people need in order to build our families, and importantly, to do so without medicalizing members of the LGBTQ community. Third, it would clarify the coverage required for people who need fertility preservation before undergoing medical procedures that can compromise their fertility, such as gender-affirming care or cancer treatment. These additional changes will bring the state's fertility care insurance law into step with other provisions of Connecticut law that recognize the many ways we build our families and provide coverage for the medical care needed to exercise our reproductive autonomy, whether we receive our care through private or public insurance programs. In so doing, HB 6617 stands to address racial disparities in accessing fertility care, since Black and Latinx people disproportionately access their care through Husky, while also being disproportionately likely to experience infertility. I hope the committee will consider additional suggestions to 1039 in the coming weeks and worked with the FACT campaign members and members of the LGBTQ caucus and reproductive rights caucus to improve Connecticut's laws regarding coverage for the medical care we need in order to build our families. Thank you for your time.
Justin, any questions?
Yes, Representative Nuccio has her hand up.
Representative Nuccio.
Thank you, Madam Chair. Thank you, Catherine, for coming to testify. I've been working also as a side bill on the insurance aspect of the fertility piece here for the last couple of years. Started with Jeff Curry last year, and now I'm working with the Department of Insurance. And there will be other language that will be going in here to handle the insurance aspect of this, which is what our purview is here in insurance. And it will be to follow along with the other states that have put in non-discriminatory practice, which will open up infertility, or fertility, as I call it, not infertility, fertility treatments for members of the LGBTQ community, and have reference to non-discriminatory language regardless of sexual preference, gender identity, etc. So there's definitely more work going on here that will expand that, but only in the insurance arena, which is what is under our purview right now. So thank you for coming in support of that. And hopefully you would be supportive of the additional language. And I have been working with the advocates with that language. So it's not just me coming up with it. It's a language that has been determined with other advocates from last year also.
Also, for the one group, the Affordable Families Coalition, that one particular group, or
Fertility for All, with a few other people too. There's been Mario and Davina and a few other people that I've been working with since last year on a bill proposal for this.
yeah, so I think something that's very important and that's in our bill when it that, you know, again, has been worked out with some of the national reproductive justice orgs and with GLAAD and the Representative Curry, is that the mechanism by which our bill would make sure LGBTQ people are included, carefully make sure not to just force us into a definition of infertility that medicalizes queer people, which is something we've fought against literally for decades. So I really hope that should the insurance committee go down that path, that we can work together to make sure it's inclusive. And I'll just say that it is, you know, the FACT coalition of PPS, Planned Parenthood Southern New England, Resolve, GLAAD, the Yale Reproductive Justice Clinic. It's really important to us that we include all LGBTQ people, which would mean including people on Medicaid, because those aren't two distinct groups. So I really hope that we can find common ground and move forward to make sure that we're really including all of the LGBTQ community when we push ahead this legislation.
So that's why I said it's fertility and not infertility, right? So it's not a matter of infertility, which is a medical diagnosis. You're right. Like, this is just a matter of, from the insurance perspective, which I like to keep them very clear because that is our purview here, is the insurance area. It is just opening up access to benefits that people with insurance are already paying for and are already actuarially included in. So that's the purview that we'll keep focused on in here, is just the insurance aspect, and from a fertility and an equal access perspective from the insurance benefits that they already have. So, you know, that's the purview of insurance. So the other bill is in human services because that's their purview. So We are continuing, like I said, to go down for language, and we'll be probably amending this bill to add that language going forward. So thank you again very much.
Great, Catherine. Thank you for being here today. Next up, we have John Calkins.
National Association of Benefit Insurance Professionals here in Connecticut. We have over 150 independent insurance agents who sell principally in the small group market. And while I appreciate the lady from the Brewers Association, and they are 20 or 40 or whatever, 120, whatever, we probably have 2 or 3 or 4 or 5,000 small groups that have similar issues in trying to offer their employees health insurance. And that is why we're here to support the association plan as another tool to allow us to get insurance to our clients. Right now in Connecticut, you have a small group market, the guaranteed small group market, it's spiraling to a death spiral. The healthy employers who are moved out of that to level funded or self-funded, and have left most of the groups in there have medical issues. If we don't have another and by the way, those are the groups that you heard about who got the 25% rate increase back in September. And that'll continue higher if we don't offer other alternatives, such as the association plan. It's another option. It's an option that's available to other employers in Connecticut. Partnership is an association plan. The Connecticut Independent Insurance, Independent Schools Consortium. We have municipal consortiums. We have MEHIP. We have a number of other association plans already that are being operated. This one is another one for the small employers in Connecticut. When I say small employers, we're talking about under 100 life employers. I'm sorry, employees. They can, for the CBIA did a fantastic job in outlining the bill and how it would work. Julie and I's position is we're talking to you about our clients and what our clients need, and we need options. Julie, you have anything else? There is one last thing I'd ask. In the CBIA bill, the current, I call it CBIA, I'm sorry, the 6710. One of the other recommendations we would like to see added is that the association plans require a licensed broker to be the agent on any plan sold. That way there you have full consumer protections, you have the full licensing of the state of Connecticut, et cetera, in the sale of these, and that you will appropriately have an evaluation for the employer. Does the association plan meet your needs versus maybe the small group one for whatever unique reason does, or a self-funded or level funded one does. These independent agents represent all the carriers in Connecticut and can offer that advice, professional advice to them. We also
Hi, John. I'm sorry. Your 3 minutes are up. Please summarize.
Okay. Two quick points. We're going to withdraw our concerns. We've had discussion with the carriers about 6712. No, I'm sorry, 6709. 6712, we also support for the obvious reasons of how it can lower premium costs here in Connecticut.
Great. Thank you for, coming and sharing your story here today. And, we hear you. We hear what's going on in the small group market. Those of us on the committee that have spent the time visiting small businesses in our district and around the state are hearing the same stories over and over again. And I just don't know where the opposition is coming from. It's almost rehashing stories from decades ago. And I'm sure you heard from testimony that we're really trying to work with all advocacy groups, as well as several departments and state government to make sure that the plans are run efficiently and effectively. and address solvency issues. We've already heard as well that they will comply with ERISA laws if they are self-funded. And if they are in the fully insured market, will comply with several parts of the Affordable Care Act. So we appreciate your testimony and staying and hanging out here all day. And we do hear the concerns in the small group market and appreciate you sharing your story. Senator
Just
Wong.
one last thing. One concerning is some of the opposition just doesn't seem to be based on the bill. I mean, we talked about affordable care, the ACA requirements, and the lady just here just said it wasn't going to be. It's astonishing to me about that, but we are trying to comply in all ways.
Well, we do hope people read the bill because a lot of those concerns are addressed in there. Thank you for pointing that out. Senator Wong.
Thank you, Madam Chair. One of the key components was to allow the independent brokers to be able to sell this product with the associations, because you've been selling the product from the get-go. I think we've instituted training and understanding the ACA product. You have been selling the product from the get-go. You have explained it. You're on the front line of exchanging. And I really appreciate you waiting for the duration of the evening and offering the feedback, because you know the product, you know your customers, and you have validated the fact that there is a tremendous need. And this is a solution that has been vetted and, in combination with the expertise of your members, be able to provide a viable and sustainable product. So I just want to say thank you. I appreciate having the weight of your association and the membership that understand the insurance product and business. And you are the main interface for so many of the small businesses and individual policyholders that would benefit from this, to be able to have a product that you can sell and provide to your customers. And so I wanted to thank you for staying the late night, but really kind of encapsulate it, because when it's a good product and when there's a tremendous need, you succeed. And that's a win-win for everybody. So thank you, Madam Chair. Thank you for being here.
I do think that it's important to note some of the stuff that came up where, oh no, people are going to get thrown out of this plan and they're going to go into the exchange. These are groups. So the group isn't going to go into the exchange. They're going to go into that small group market again. So those are some, and you also had asked about, well, how many of these plans failed when you were talking about municipalities? It's not that they fail. It's just that self-funded doesn't work for them anymore and they go back into the fully insured market. I mean, that's just what happens. And when we're talking about these groups that are going into that fully insured part of this bill, if you do anything in the middle market with employers that have 50 or more employees, guess what? They're looking at their claims, and you have one person in that group and they have a high claim, they're going to get a big rate increase. And so it's happening today. And I think allowing these association plans to come together to have that larger pool is very important. And I think that's important to understand.
And I think you raise a very important point that the group doesn't go into the exchange. But contrasting other plans, there's no penalty for people to exit the plan. That's important, right? It's a freedom of choice. You don't have to lock in periods and pay a penalty if you want to leave it. If the product's not performing, if whatever the whim is, you don't feel it, or you don't think it serves your need, you don't have to join it. You can exit out, unlike other plans. Would that be fair to say?
Yes. And then when you start thinking about the level fund and everyone's worried about, oh no, what happens if something bad happens? There's stop loss insurance. So nothing was talked about what those stop loss, what's the individual stop loss limit going to be? What's the aggregate limit going to be? So there's all protections there. I know people were worried about this coming back on the state, and I just don't think that's a concern, because there is an insurance part to all of this.
Thank you very much for your time. Thank you for your work. Thank you, Madam Chair.
Representative Pavlik Tomato.
Just quickly, I agree with what you just said. And I did kind of whisper stop loss at one point to one of the questions here, but when some people were asking questions before, I wasn't sure whether we were talking about the partnership plan or whether we were talking about the plan that's before us because they sounded so similar and the issues and, you know, where are we going to go for, you know, if it falls short? And yet we just had the partnership plan get $40 million, right? Was it 40? From the state. So that seems to be an option for some, but not the other. And I guess I'm just overall confused. So that's all. Thank you.
Well, what's nice about this is it's not going to come from the state. It's going to come from insurance that was purchased.
Thank you both for your time today.
Representative Nuccio has her hand up online.
Representative Nuccio.
Thank you, Madam Chair. I just wanted to say thank you very much for that last bit there that you mentioned. I think there's people who are against this who are, again, like I'm listening to the same stuff everybody else is hearing, and there's a lot of misinformation out there. You know, in regards to the stop loss policies, which are fully insured policies, and how they aggregated an individual, like, you know, that's two different kinds of stop loss, but we're going to get way too technical if I go down that path. But also just, you know, saying that this is happening. This happens all the time, right? And our own policy, our own partnership plan is looking at doing it, and our e-chip plans are doing it. And it happens in industry all the time. If you have a high amount of claims, you're re-rated, and you know, all insurance is based off of claims. That's literally the basis of any premium. So thank you for pointing out what for me is always the obvious, but I don't always do a good job of getting it down to the public hearing level. I think you did a wonderful job of pointing out the flaws in some of the arguments that we've heard today. So thank you.
Thank you.
Great. Next up, we have Representative Delnick.
You're not done. Just a real quick comment. I suspected that would be the answer when it came to the municipal piece of the puzzle. Because municipalities, they've been doing it for years. And we had the stop loss. We have a stop loss policy there. And you confirmed pretty much what I thought was the case, that there weren't failures per se, but there could be a situation where a municipality might want to say, hey, we want to do it differently, but no failures per se. Thank you. Thank you, Madam Chair.
Thank you, Representative.
Okay, just a-
Yep. Can you just hit the button right there, just because we have someone on remote? Thank you. Next up, we have F. Scott Gray, Dr. F. Scott Gray.
Thank you. I hope you can hear me. I'm unmuted.
Yes, we can hear you.
Good, thank you. Distinguished members of the Insurance and the Real Estate Committee, my name is Dr. Scott Gray, and I'm a foot and ankle orthopedic surgeon in private practice in the Danbury area. I serve as the current counselor to the American Academy of Orthopedic Surgeons from Connecticut, and am a past president of the Connecticut Orthopedic Society. The orthopedic community strongly opposes Section 3B and 3C of Senate Bill 983. It limiting anti-competitive healthcare practices, the governor's bill, which would gut Connecticut statute governing surprise bill 38A hyphen 477, the current general statute, and the protections that have been serving our patients and Connecticut residents since its enactment in 2016. Limiting out-of-network reimbursement to 100% of Medicare, while Medicare continues to cut reimbursement yearly, will have a negative impact on patient care if independent physicians, especially orthopedic surgeons, no longer choose to provide coverage in the emergency room for out-of-network care. And since when on call, we don't cherry pick, we take all comers, this means no longer providing emergency room care. There are many reasons a physician may choose not to join any given network, especially ones that make the pre-approval process so onerous that it ruins our relationship with our patients. Connecticut's No Surprise Bill, currently coupled with the additional protections found in the federal No Surprise Act, offer patients and physicians a comprehensive and fair solution to surprise billing in Connecticut. It's been running smoothly, protecting patients financially and their access to expert emergency care since its enactment. The Orthopedic Society in Connecticut is not aware of any incidents of price gouging on behalf of orthopedic physicians since the current statute was enacted, as referenced by the governor's statement in Senate Bill 983. The current statute leaves patients out of the equation, thus no surprises. It is a falsehood to state that the current statute is injurious financially to patients, as there is no balanced billing in the emergency room setting. The current statute forces the insurance industry and treating physicians to negotiate within clear guidelines that have been acceptable to both parties, leaving the patient out of the equation. The Connecticut Orthopedic Society urges members of the Insurance and Real Estate Committee to oppose the section of this bill referenced above to ensure patients continue to receive access to timely emergency room care from orthopedic surgeons, and that physicians receive fair, agreed upon by statute, in place reimbursement for the treatment and care they provide, and continue to leave the patients out of the financial equation regarding surprise billing in the emergency room setting. Thank you.
Thank you, Doctor. Any questions? Senator Anwar?
Thank you so much for your testimony, Doctor. I just wanted to ask you, you mentioned about the access. Can you just expand a little bit how the access is going to decrease because of this part of the bill, please?
Physicians currently have accepted the current statute, which allows us to negotiate 80% of the prevailing usual and customary fee rates based on our zip code with the insurance company, or accept their street rate, which is never a real street rate. But if we are forced to accept Medicare rates from an insurance company that we don't participate, usually with good reasons, we can't do that. It's not fair to us. I'm not even sure it's legal. And therefore, we will likely choose to simply not provide care in the emergency room across the board, because we don't cherry pick. When we're on call with our hospitals, we take all comers. And the only way to avoid this situation is not to take any comers. So we would not participate in emergency room call. And that's how the access would be severely curtailed. And what a horrible access problem that would present. And we would not like to see that.
Thank you so much for this. Do you anticipate some of the other specialties acting in the same manner?
Well, I've been online for a long time. I actually liked hearing a lot of the testimony. It's very informational. But I think you heard from a plastic surgeon the same thing, that they would no longer be able to provide kind of care. Now, he was talking kind of across the board. There is a difference between this situation in the emergency room setting and a patient who comes to a provider's office with out-of-network benefits, knowing ahead of time, unsurprising, what they're in for. And there are statutes that require the physician to be completely open regarding what their responsibilities will be. That is a choice a patient will have if they go out of network, with or without out-of-network benefits. They have no choice when they get injured and end up in the emergency room. So that's a big difference. And so the current statute protects them and allows them to be out of the equation. So I think you heard from the plastic surgeon that this is unacceptable to his particular specialty. I suspect it would be the same for any specialty, but I can only suspect. I speak for the Orthopedic Society that it's unacceptable and will very likely have severe access implications.
Thank you so much for your testimony. This is helpful because I think we didn't touch on this as much when Dr. Gifford had testified earlier. But thank you so much for your testimony, and thank you for sharing this perspective. Thank you, Mr.
Thank you for allowing me to testify. Thank you very much.
Thank you, Senator. Any other questions? Seeing none, thank you, Doctor, for your testimony today.
Thank you.
Up next, we have Alexandra Martinez Garcia, followed by Olivia Rinkies. Neither are online. Okay, so we'll move on. Is Jay Stutz online? Mr. Stutz?
Hi, good evening.
Welcome.
Thank you. And thank you, Senator Cabrera and Representative Wood and distinguished members of the Insurance and Real Estate Committee for having me. My name is Dr. Stanley J. Stutz. I represent the Connecticut State Medical Society, and as a board certified emergency physician, treat patients 24/7, regardless of their ability to pay. I would first point out, as Dr. Gray had mentioned, that it's been discussed tonight, that there's this narrative really doesn't apply to out-of-network emergency physicians. Through the Connecticut No Surprise Act and the federal NSA, it's illegal for physicians to balance bill a patient in Connecticut. Patients are not harmed. In tying out-of-network rates to Medicare, Bill 983 will greatly damage the healthcare network adequacy and access for patients. Senator Looney pointed out it will increase consolidation and act in an anti-competitive manner, which is ironic considering the name of the bill. My Democratic Emergency Medicine Group, of which I'm the CFO, we employ 75 people over 5 hospitals. We all live locally and are members of our communities. We have continually had top benchmarks for patient quality, flow, and satisfaction since 2008. A well-run business can save money and lives. We prefer to be in network, but this bill will remove our leverage with payers. We'll have to agree to a rate that will either force us out of business or force us to join a hospital system to stay afloat. That will increase costs. In addition, our business costs have skyrocketed with inflation. Medicare has been flat for decades, as Dr. Gray had mentioned. It would now act as a benchmark for our entire book of business. This bill will create a dramatic fall in revenue for providers across the state. Emergency providers will be affected especially hard, and average reimbursements will fall by upwards of 40%. Many of our best emergency medicine providers and other providers will leave Connecticut for the other 49 states that don't have a bill like 983. We already have a nursing staffing crisis. This bill will further trigger physician consolidation and workforce instability. Bill 983 will increase already long wait times for care and extend lengths of stay. Both directly contribute to patient morbidity and mortality. Patients will die in waiting rooms across the state. The number of emergency department boarders, those who need inpatient level of care but don't have a hospital bed available, will increase, especially in rural areas. Due to staffing shortages within the last year, I've already seen a patient with a positive troponin in the waiting room. That's an indication of a heart attack. I've seen a patient with abdominal pain who waited so long, they ruptured their appendix while sitting in a chair. So what are emergency departments going to look like if we can't even staff them at these strained levels? This one-sided bill simply protects insurer profits, and the effect of this bill on the medical community should not be undersold tonight. Medicare pays 2% of expenditures to administer claims, yet commercial insurers spend between 12 and 18%. Getting control of those wasteful expenditures would create massive savings. Commercial insurers do not cure a single patient. This bill won't address increasingly high deductibles, and it won't force premiums down. Bill 983 and using Medicare rates as a benchmark is a radical experiment that will damage Connecticut's healthcare system and injure Connecticut citizens. It's frankly upsetting that the governor and the Connecticut legislature would not only hurt our patients, but also the professionals who put their lives on the line and whom our government looked to in the middle of a global pandemic before vaccines were available. I urge you to do the right thing and vote against this bill. Thank you for your time.
Thank you, Doctor. Any questions, comments? Yep. Representative Pellegrino.
Thank you, Mr. Chairman. Just you had mentioned the shortage of nurses and staff, and I was wondering, it's not something that we've talked about a lot in this committee and how it's affecting the underlying costs and issues. So I was just wondering if you could address that and maybe clarify a little bit more what the impact of that is on the whole system and the bill and anything else that you think is helpful. Thank you.
Sure. Medicine, especially emergency medicine, relies on the team. That team includes the physicians, the APPs, nursing staff, and the techs. We all work together to treat patients. There's been a huge nursing shortage recently, really since COVID, and it makes things very difficult, both in the emergency department and in the hospital in general. We have flow issues that have been hard to solve. Those boarding patients I talked about partially are in the emergency department because they don't have beds upstairs because there's not enough nurses to staff those beds. What happens is those patients in the ED are in a place where they're really not designed to be seen in the ED because they're admitted patients who are acute enough to need an admission. They need a higher level of nursing care, including med reconciliations, et cetera. And we're not really set up to do that in ED. So not only do they take staff resources in terms of time, but they also take space. It pushes people out into the emergency department, waiting room. Sometimes we can see patients out there. We try to do that, but obviously it's a Band-Aid on an extremely dangerous problem. So this would make that a lot worse, this bill.
Thank you.
Thank you, Representative. Any other questions? Thank you. Seeing none. Thank you very much for your testimony.
Thank you.
Up next, we have Mr. Jeff Shaw, followed by Paul Kidwell.
Good evening, Senator Cabrera, Representative Wood, Senator Wong, Representative Pavlock D'Amato, and members of the committee. My name is Jeff Shaw. I'm the Senior Public Policy Advisor at the Alliance. The Alliance is a statewide association representing community nonprofits. Thank you for the opportunity to testify on House Bill 6710, an act concerning association health plans. The Alliance supports the proposal, which would create new ways for trade associations and their employer members to obtain more affordable, high-quality health insurance. Community nonprofits are 46% behind where they were in 2007. During the last biennium, the legislature stepped up and provided 2 cost of living adjustments to nonprofits. But over the last 2 years, nonprofits have been hit by historic 16% inflation, which has entirely consumed the gains of the last biennium. Likewise, the cost of health insurance has also increased significantly over the last 2 years. The ability to pay competitive wages and offer adequate benefits, such as health insurance, is critical to retaining and recruiting employees to the nonprofit sector. With funding increases from the state budget, again, having been eaten entirely by inflation, the workforce shortage for health and human service workers is getting worse, with some nonprofit providers reporting 30% vacancy rates. Many smaller nonprofits are struggling financially and want to provide high quality, more affordable health insurance for their employees. This proposal could give them and their workers the same safe and regulated choices that large employers have. Currently, most trade associations have limited options to purchase health insurance to offer their employees. Most trade associations have 50 or fewer full-time employees, meaning they're forced to buy health insurance from the small group market. Similarly, many small and medium-sized nonprofit organizations also fall into the small group market where options are limited and costs are high. In a 2022 Alliance member survey, 80% of respondent organizations said that their rates increased during the last health insurance renewal period. Also telling, 75% of responding organizations did not switch vendors in their last renewal period, as there were no better options on the small group market. Further, of those organizations that did not switch vendors, 38% increased the employer contribution, and 30% increased the employee contribution, both necessary due to the increased cost of the plan. This proposal seeks to address affordability and quality by allowing associations to band together with their employer members and become one employer. Small employers can enjoy the same benefits large employers enjoy in the large group market. These large group plans are no different than the plans the majority of employer market enjoys today. Health plans must abide by ACA requirements like not denying care due to pre-existing conditions, minimum plan standards, preventative care coverage, et cetera. This proposal would create more options for small and medium-sized organizations to purchase high-quality healthcare. Nonprofit employees, many of whom provide essential services on behalf of the state, deserve these options. Thank you so much for listening to me.
Thank you very much. Representative Wood.
Jeff, thanks for sharing your testimony today. It was really important for our committee to work with your group and understand the struggles that the nonprofit community is going through in providing healthcare. One of the stories many of the stories are people who want to support people in the nonprofit world. And a lot of them are on high deductible plans, which I'm sure you're very much aware of. And it's almost like acting uninsured, because the salaries don't really cover, the cost of those high deductibles. So as Representative Metzger says, it's almost like catastrophic care. So this is just another option in the market. It's not saying that all nonprofits are going to go, for association health plans. So what we're trying to do is just offer another option to help with those costs. You can continue doing the work that you do and also take care of your employees. So I thank you for reading the bill. And thank you for, acknowledging that we've worked on the things that are important to all of us here in the state.
Thank you.
Thank you, Representative. Any other questions, comments? Nope. Thank you very much for your testimony. Mr. Kidwell? Good evening.
Good evening. It's nice to be with you. And as my colleague Jim Akabelis noted, I wanted to spend my time talking about the out-of-network caps in SB 983. My name is Paul Kidwell, representing the Connecticut Hospital Association. It's been said before, but I think it's worth just noting what the state and federal law currently provide for out-of-network care protections. So if you walk into an emergency department in Connecticut today, and you need care, obviously you will get it, and you will only be held to your in-network cost sharing. For those non-emergency visits at a hospital, an in-network hospital, if you are treated by an out-of-network anesthesiologist, you will only be held to your in-network cost sharing. There are significant protections already in state and federal law for out-of-network billing and protections for patients. It's really important context for this conversation. What we really think this is about is giving leverage to national health insurance companies over Connecticut's hospitals as they negotiate inpatient or in-network inpatient and outpatient rates. And if you haven't had a chance yet to read it, I'd recommend Pat Charmel's testimony from Griffin Hospital, a small community hospital in Derby, Connecticut, who I think appropriately describes what that would mean for his hospital. The consequences of moving commercial in-network rates closer to Medicaid or Medicare, pardon me, would be financially devastating for hospitals in Connecticut. It would mean upwards of billions of dollars of losses annually. And if those rates were moved towards Medicare in 2022, most hospitals in Connecticut would have double-digit negative margins. That's the consequence of moving to Medicare. Last year, hospitals lost $1.1 billion in Medicare, lost $993 million in Medicaid. Earlier today, we need to talk about everyone's participation in this problem. What this bill only looks at is commercial reimbursement. If Connecticut hospitals only get paid 80 cents on a dollar for a Medicaid or Medicare patient and 68 cents on a dollar for Medicaid patients, there is enormous subsidization in the commercial market. If you move that payment to Medicare, every part of the book of business will be losses for hospitals and health systems. The math doesn't work. Senator Anwar earlier said, and we agree, that for 3 years, the state has relied in partnership with hospitals in the pandemic and the pandemic response. It was because hospitals entered the pandemic in a place of relative strength. We were able to basically shut down I'm sorry to
operation.
interrupt. Your 3 minutes are up. Please summarize.
Thank you, will do. Shut down operation to treat COVID patients in 2020. In summary, I think we don't feel that the Connecticut state government needs to provide leverage to national health insurance companies that made $37 billion in profits last year, while Connecticut's hospitals as a sector lost $164 million. We lost $164 million last year. So I welcome additional discussion and questions, but certainly that's how we view this bill. Thank you.
Thank you. Questions, Representative Meskers?
Thank you very much for the testimony. In some way, I don't think you were completely explicit in that, as I understand your description, the problem exists right now is that I go into the emergency room, I get treated, and I'm getting an inpatient rate, but the reimbursement rate will be an out-of-patient or out-of-network rate, and that's subsidizing the hospital, right? So I'm not arguing that that mechanism is working to subsidize the hospitals today. We passed a bill last year, or the year before, I can't remember, on insulin, where we capped the cost at $40. When we cap the cost at $40, we cap the cost at $40 to the ratepayer. But the insurance companies were picking up the $350 or $450 for each insurance, for each dosage of insulin, because the pharmaceuticals certainly weren't giving us a $40 rate. And I understand your concern here because the hospitals apparently are precarious financially. I guess the question is, how do we drive down costs, right, in the system, right? And I've got hospitals that are all nonprofits, but that have all grouped into large agglomerations with good price negotiating power. I've got insurance companies that are buying pharmaceutical companies or policy benefit managers. And I've got drug companies that are charging me 4 times what the rest of the world is paying. So we're trying to wrestle with the issue. What I hear from you clearly is your concern is that we're hitting one of the weaker links in terms of profitability. And I mean, is that in essence the argument?
I appreciate that. Maybe two answers. One is, yes, hospitals are in precarious financial situation. 3 years of the pandemic response with soaring costs. When you can't negotiate commercial contracts, but every 3 to 5 years, and your Medicaid and Medicare reimbursements are not in anywhere keeping close to the cost of care. Absolutely. And if we want to be prepared to deal with those types of public health emergencies, the hospitals need to be in a better position than they are today. That said, I think your most important point is, but we do have to do something together. And so I would respond in 2 ways. One is the General Assembly did adopt the cost growth benchmark in legislation last year. This year is going to be the first year where publicly reported data is available. And we're going to understand with more transparency, are we hitting the benchmarks? Are we not hitting the benchmarks? Why are we not hitting the benchmarks? And arguably that's a better measure than the APCD, because the APCD doesn't have the self-insured data in it. It has the fully insured market, it has the certainly Medicaid and Medicare. So we think that process should continue to play out. And we've been at the table since the first day. I think beyond that, we as a sector are thinking about how do we make more robust investments in the upstream drivers of health. So not just those social determinants generally, but what does transportation do for health? What does housing do for health? What does economic development do for health? Because we all have an incentive to keep people out of the most expensive place you can get care, which is in the hospital inpatient setting. We can design programs, and certainly we're talking to our colleagues in insurance, talking to the state about how do you design a system where we play a part, where they play a part, where our community collaborators play a part to keep people well before they need hospital care. So that's how we're approaching it. We think that this is a blunt tool that will weaken the industry even further than it is.
And just as a last comment observation, I think, at some point it's going to be incumbent on the medical industry, particularly the hospitals, to look at more pricing transparency on the transactions that we engage in. 80% or 90% of the knee replacements and hip replacements and shoulder replacements are standardized procedures. And I'm not suggesting that the person who does it is not a skilled surgeon, but I can't shop and price my deductible or price my procedure with any clarity. It's enormously difficult to figure out where we price our services in the healthcare industry. And I think that's part of why we have the problem versus the rest of the world.
I tend to agree with you. I think we're getting closer to that transparency. So there is federal transparency law that requires, I think, 2 things. One is that we have to post all of our negotiated rates in a machine readable file, which frankly for the consumer is not that beneficial, obviously. But all of our hospitals have price estimator tools on their website where you can go in and put in your insurance and put in the procedure. Could those be more easy, sort of user-friendly? Absolutely. I think we're headed in that direction.
Thank you. No further questions. Thank you to the chairs for the indulgence.
You're welcome, Representative. Any other questions, comments? Senator Huang?
Thank you. Thank you very much. And thank you for the diaper drive today. I was just asking a question. Are all of our hospitals still under the protection of immunity as a result of COVID?
The civil immunity.
The civil
protections?
immunity.
So no, the civil immunity order expired.
Okay.
All
right. Thank you. Thank you, Mr. Chair.
Thank you, Senator. Any other questions, comments? Thank you very much for testifying
Thank
today.
you. Thanks for the evening.
Have a good evening. Okay, we've got Greg Shangold.
Yes, hi. Good afternoon. Obviously, this was written, right? So good evening, Senator Cabrera, Representative Wood, and the distinguished members of the Insurance and Real Estate Committee. My name is Gregory Shangold. I'm a practicing emergency physician in Connecticut for the past 20 years and a current resident of Storrs. As a counselor and a past president of Connecticut College of Emergency Physicians, representing over 500 emergency physicians in Connecticut, I'm here to testify in strong opposition to Senate Bill 983. As an emergency physician, we treat all patients regardless of their insurance status or ability to pay. Under the 1986 federal law EMTALA, which is an unfunded mandate, emergency departments serve as the safety net for all patients. We embrace this duty to our communities and want to have the resources necessary to provide high quality emergency care. Just a few months ago, we were touted as heroes for the work we did and continue to do during and for COVID. However, now we're here today defending our most basic ability to provide everyday emergency care. In 2016, Connecticut passed landmark out-of-network legislation. It's Public Act 15-146. This protected patients that have the fully insured insurance plans. And now the federal government enacted on January 1st, 2022, protection for all self-insured plans. All patients, as other speakers have said, are protected from out-of-network bills. There is no balanced billing by physicians in Connecticut. Section 3 of this bill is a threat to fair negotiations. And furthermore, this proposal does not provide any further patient protection than what we already have. If passed, it will damage patients' access to care and erode our emergency care safety net. For the past 5 years, we've discussed other problems like the high deductible health plans, but we haven't found any solution for that. We should focus on the solutions that will truly help patients and not ones that will just benefit insurance companies. With all due respect, the testimony earlier from DOI and OHS is just simply wrong. As Senator Looney writes in his testimony, this out-of-network provision has many problems. And there's been confusion about the language, about hospital services, inpatient and outpatient. There's no definition there. And the way it reads, this applies to all medical services, which would include private physician groups like myself, like Dr. Gray with the orthopedists, and like many of the other doctors. We're seeing a net exodus of physicians from clinical practice, and we're having difficulty retaining our residents we train. One of the stated reasons has consistently been the practice and reimbursement environment. As physicians, we dedicate our lives to the care and health of our patients, but we cannot do it without supportive government policies. We cannot complete our mission without fair and equitable business practices and the ability to fairly negotiate with insurance companies. On behalf of the Connecticut College of Emergency Physicians, I urge you to reconsider the language of this bill and maintain the current statutory language in Public Act 15-146 that governs out-of-network emergency services and exists to protect patients. Thank you very much. And if you have any questions, I'd be happy to answer.
Thank you very much for your testimony. Senator Anwar.
Thank you so much, Mr. Chair. Hi, Dr. Shangold. Good to see you. Dr. Shangold, earlier Dr. Gray was saying about the access issues that will change. Now, You talked about EMTALA. By federal law, we cannot change the access. You have to see every person that is going to come to the emergency room. But can you break it down for the specialty care and also the EMTALA services that you're going to provide within the emergency department?
Sure. Nice to see you, Senator. I think Dr. Gray said it, where some specialists have a choice of where they provide their services, whether it's in the hospital or surgery centers. And those choices is how we decide who's on call. If a doctor is not on staff at a hospital and they're not on call, then we won't have those services available. And so if they're forced to take Medicare, and I think one thing that hasn't been said tonight is there's no reason to assume current contracts are going to exist. The current contracts are going to be canceled, and insurance companies are just going to offer in-network contracts at Medicare. And doctors are going to say, we can't take those. The numbers don't add up. And so they will not provide those services, and then they can work out with patients. In regards to emergency medicine, we are also a business. The amount of doctors we can hire, the amount of APPs we hire is based on who we have to, on the revenue we get. Right now, Medicaid, and in the specialties, we rank 42nd in the country in our Medicaid reimbursement. We still have self-pay patients, which in general are patients that don't pay anything. And as Mr. Kidwell just said, Medicare still runs at a loss. That adds up to about 70% of the patients seen in the emergency department. So if you now take the 30% of that cost shift, there won't be enough resources to hire board certified emergency physicians and excellent PAs, and staffing will go down. And I believe the part Dr. Stutz said with the nursing crisis is the hospitals use the money that they get to hire nurses. We already have short shifts. So it's not that we won't see the patients, but they'll wait in the waiting rooms because there just won't be enough staff to see them on an expedited manner, which is what we want to do. I want to see everyone as soon as they get to the hospital and determine if they have an emergency medical condition, as EMTALA says, and stabilize that emergency medical condition. That's what I train for. That's what I go to work for. And a law like this would just decimate our resources, and we just won't be able to provide that care. And I won't be able to recruit doctors that I'm competing from Massachusetts, New York, or all over the country. We already don't retain our residents here in Connecticut. You know, we've been trying to get them, and people are going to choose not to come to this state.
Thank you so much. There is this other conversation that's going on about the cost of healthcare. Can you allude to that? As is the emergency care very expensive, and the care that we are providing much more expensive? And is this one way to try to reduce that cost?
So a couple things. One, I participated in that forum and I gave examples. We haven't talked about the medical education and the malpractice environment. Those are two of the major reasons why healthcare in the United States is different than in Europe. So that's one of the cost drivers. Two, we have underfunded Medicaid since its inception in 1965. I think my slides from the Healthcare Forum are available on the Office of the Healthcare Advocate to show in detail how, as a government, Medicaid has been underfunded, and it's created this cost shift. So that's another reason that's driving cost up. So those are two of the major reasons why I think cost is, and what we can do for other cost issues here. I don't know how you do medical education. Residents that come out, they have $500,000-$600,000 of debt between college and medical school, and that gets wrapped into the cost of the current reimbursement schemes.
Thank you so much for your testimony. Thank you, Mr. Chair.
Thank you, Senator. Representative Wood.
Thank you, Dr. Shangold. Good to see you again. And I do just want to leave you with the medical malpractice insurance issue. You are speaking to the Insurance and Real Estate Committee. And I know we've spoken about this in the past, but let's continue to have that discussion. Thank you.
Anytime, Representative, happy to do so.
Thank you, Representative Wood. Any other questions? Seeing none, thank you very much for your testimony this evening.
Yes, thank you.
Up next is Dr. David Emmo.
Good evening, Senator Cabrera, Representative Wood, and members of the Insurance and Real Estate Committee. My name is David Emmel. I'm a practicing ophthalmologist in Wethersfield, Connecticut. Thank you for the opportunity to represent the 4,000 physicians and physicians in training of the Connecticut State Medical Society in opposition to the governor's bill SB 983. Last week, one of my patients said to me, she said, "You know, Dr. Emmel, I liked you a lot more when you were on your own before you joined this big group you're in now." And I had to laugh. I said, you know, I liked me a lot better then too. And the reason should be obvious. You know, when I had control of my own practice and it was a small practice, I could take care of all my patients' needs much better and in a much personal way. But the fact of the matter was, economically, I was driven out of it. It got to the point where my overhead was so high, I wasn't even taking home a paycheck for myself anymore. So I was forced to join a large group. Providers are not responsible for the cost of healthcare in Connecticut. We're not the cause of the problem. Providers are responsible for just 20% of all healthcare costs, and a lot of that cost has to do with administrative burdens, many of which have been imposed on us by the insurance industry. Things like prior authorization and high deductible health plans, as many of you on this committee know. It is also worth noting that Medicare rates have severely lagged behind both the cost of living and the rapidly rising costs of delivering health care, in part because Medicare has no mechanism to keep up with costs. And contrary to the testimony by Ellen Andrews, no practice would be able to survive if it was limited to Medicare. It is also true that the problem of surprise billing and out-of-network billing is largely due to the creation of narrow and tiered networks, provider networks. While I recognize that SB 983 appears to be limited to inpatient and outpatient hospital services, the language is ambiguous. And we are absolutely concerned that if this bill passes, there will be spillovers to providers that are not connected to hospitals. And if so, the section on caps on out-of-network rates at 100% of Medicare will be the death knell for independent practice in Connecticut. Providers will be forced to leave the state or join the large entities, and we will struggle even more to attract the young physicians that we want to come to our state or stay in our state because we train them here. I urge you to oppose Senate Bill 983. Thank you, and I'm willing to take questions.
Thank you, Doctor. Senator Anwar has a question for you.
Thank you so much, Mr. Chair. Thank you, Dr. Emmel, for your testimony, and thank you for your presence in many of these conversations. Dr. Emmel, could you speak a little bit about what the Medicare reimbursements look like and how are they sustainable to be able to have staff in your office, whether it's a small practice or a larger practice?
When I started out, I actually was able to do everything I needed to do with just myself and one person, happened to be my wife, but we were efficient and we didn't have all these extra needs. I now require about 6 full-time personnel, including one who's almost full-time doing prior authorization. And throughout that time, Medicare, especially in my field, ophthalmology, has lagged way behind. On top of that, Medicare rates for the primary surgical procedure I perform, cataract surgery, have gone steadily down from $2,500 when I started in 1985 to now about $800 at the most for a cataract operation that restores sight and allows people to retain their function.
Wow. And I think if I'm not mistaken, we were having a conversation that if you were to see a Medicaid patient, you're losing money every time you're seeing a Medicaid patient and doing a surgery on them.
That's absolutely correct. The amount we get for a Medicaid patient doesn't cover the costs or overhead costs. And sometimes the service we provide is paid for at a lower rate than the cab driver got to bring the patient to our office.
And if the small percentage of the commercial payments decrease, then basically you might as well close shop.
Well, I think that's what's going to happen. We're going to see premature retirements. People are just going to give up, and or they will leave the state for states that have more generous policies. And the young doctors, that are getting out of medical school, and especially the ones that are finishing up their residency programs and fellowships, they pay attention to what they see on the internet. And if we want to put Connecticut on the map for the absolute last place to come, that will be the way to do it.
Well, we're 47 right now, so we're 2 points behind that. Okay, thank you so much for your testimony. Thank you. Thank you.
Thank you for the opportunity.
Thank you. Any other questions? Seeing none, thank you, doctor, for your testimony this evening. I appreciate it.
Thank you.
Okay, last one, Sue Halpin, you're up. Welcome.
I'll say good evening, everyone, and thanks so much for sticking it out here tonight. Really appreciate your patience, your endurance, your diligence, and your dedication. Means a lot to folks that wait around all day, so thank you. I'm Susan Halpin. I'm here on behalf of the Connecticut Association of Health Plans, that is Aetna, Anthem, Cigna, Connecticut, and United Healthcare. I act as the executive director, and I'm here today to speak in support of 4 bills, Senate Bill 983, the governor's bill, HB 6620, the committee's bill, and the 2 exchange bills, 6709 and 6712. You heard a lot today about the governor's bill. I wanted to applaud the governor and the committee for raising this bill, and also for recognizing and addressing the major cost drivers in health insurance, and which comes from the underlying healthcare costs. It isn't always easy, frankly, for the health carriers to deliver data to the OHS and to others. But I think it's been a really important part of this dialogue, because I think it has demonstrated where those cost drivers are. And I think you've heard it time and again that the primary cost drivers in the system are hospital costs and pharmaceutical costs. The bills before you today, I think, take some important steps forward in terms of kind of changing the narrative a little bit and changing the negotiating power and structure given recent consolidations in the market. The provisions come from a national model from NASHP, the National Academy of State Health Policy, and they are really changing a little bit of the balance of power, I think, to what exists today and for what we're all struggling with. I want to echo the comments of Dr. Gifford and saying, it's about finding that correct balance between the two. And we certainly appreciate the effort to find that balance, and we look forward to being a part of that dialogue going forward. Just very quickly, because there are 2 bills that haven't been discussed too much today. And those are Act Concerning Access Health CT and the assessments on the exchange. With respect to the first bill, the next 12 months that the exchange is going to experience the biggest challenge of its lifetime here in Connecticut, as 400,000 members currently under Medicaid coverage due to the public health emergency have to go through the redetermination process. So if you think about it, there's about 100,000 members on the exchange today. Doing the eligibility requirements for, let's just say, half of that number, 200,000, is a huge endeavor, huge undertaking, and something that's going to be really, really challenging. I think your bill that allows for the carriers to work towards enrollment and marketing goes a long way and basically means all hands are on deck. And I think that's what we should all be striving for so that folks make that transition from one program to another and don't land uninsured and going to the hospital or going to the pharmacy and finding out their Husky card doesn't work. So I think we really want to focus on that. Also, really want to commend the committee for drawing attention to perhaps a lesser cost driver than the hospitals and the pharmaceuticals that we've been talking about today, but the fees, taxes, and assessments that are charged through the carriers to policyholders. One of those is the exchange fee, probably unknown to many people in the building, not necessarily this committee, is that the exchange is funded via an assessment on every fully insured policyholder in Connecticut, not just those participating on this exchange. And that's about a $30 million assessment right there. So, you know, I put some figures in here. I'll summarize. Yep. You know, for a family of four, that's about $244 a year. There's other assessments. Back in the day, I'm going to finish quickly, Justin, Sean, I promise. But during a deficit spending year, the Department of Public Health, a number of programs were transferred over to the insurance fund. Those were fundings like, programs like Easy Breathing for asthma, educational funds, lead prevention, needle exchange program, not directly related to the insureds that we perhaps represent, could be, may not be, but about $11 million was shifted into the insurance fund for Department of Public Health programs that the carriers now pay. So you already heard about the premium tax, you know about the assessments that the carriers pay for the insurance fund, the Office of Health Strategies, the Office of Healthcare Advocate, all of which are paid for. And we just want to thank you for drawing attention to that in these bills.
Thank you so much, Representative Wood.
Thank you, Susan, for being here today and talking about these two bills. We really haven't heard a lot of testimony on today, but the goal of this committee is really to prop up the exchange. Just like we are trying to create more options out in the private market, we're looking to make the exchange a more beneficial place for people to go to for health insurance. We heard during an Access Health informational forum a few weeks ago, a little bit scary how unprepared they are for the redetermination process, meaning people can potentially fall through the cracks. We also heard that millions of dollars in marketing funds were spent within the past year, and this would have offered subsidized health insurance plans for thousands of people in the state of Connecticut. And last year there was 106,000 members, and this year there's 106,000 members. So we are not recruiting anyone to the exchange. We're not bringing in new members. And these two bills are looking to bring in additional carriers on the exchange by lowering the premium tax and making it a more competitive place, thus providing more options in the small group, fully insured market, which is, again, the most sensitive market here in Connecticut. We are also looking to take the $30 million and give that directly back to the people on the exchange. As you said, it can be upwards of $200 a plan or a family. If the state of Connecticut is serious about the exchange functioning, the state of Connecticut can pay for that through the general fund. We are serious about looking at ways to lower health insurance costs for people here. And I'm just kind of going through those bills because no one's really talked about them. But allowing the carriers to go directly to people on the exchange and recruit for the exchange, I think is so critical because it's not being done currently the way we have it set up. And as you said, people falling through the cracks and just the ability to enroll people on the exchange just means we have more people that would benefit from subsidized plans. Again, more options, more of those people that are currently falling through the cracks in the system. So I just kind of pontificated to you, but just if you can elaborate on how the insurers, how the carriers would be able to enroll people on the exchange, just for the committee to understand that.
Sure. And I'll give you a perfect example. I think the theory behind it is probably a good one, right? It's no wrong door. You go into a website, you put in all your financial information and you get routed to Medicaid or you get routed to the exchange. Right now, if you get routed to the exchange, as you all passed in the past session, there's the Covered Connecticut program, right? That is zero cost sharing, zero premiums if you fall into a certain income threshold. Right now, there could be thousands of people getting no cost health insurance, but it just, for whatever reason, is not working. One of the reasons we know it's not working, and we suspect it's not working, is there is on the website, it does not appear as no cost or no premium insurance until you get to, you know, the checkout cart, right? So I think a lot of people probably abandon the process thinking, why am I going to go through this? I'm not getting no cost, no cost health insurance. So I think there's a lot of things, but what better time to try a different approach than when we're heading into this redetermination time period where it's critical, right? There are different ways that they could do it. They could auto enroll folks from Medicaid that meet the income threshold that are determined ineligible for Medicaid, and they could automatically enroll them into the exchange. The governor's budget actually provides not only for the Covered Connecticut plan, but also a couple of months premium to go into the exchange. So that seems like an easy route and something that we should look at. But clearly the marketing isn't as robust as it could be or not aimed at the right places. This is something you see the carriers nightly, I'm sure, on your television screens, if you're lucky enough to be watching television at this time of night. You know, they do this, they market, they work with brokers, they're enrolling people, even doing a soft handoff to the enrollment broker is not allowed. You can't walk somebody through it or help somebody out. You have to have, you know, be granted special approval in order to do that. You know, this is stuff that carriers do every day. I think it would go a long way to help get people enrolled and get that number up above where it is today.
Thank you. Senator Onwar?
Thank you, Mr. Chair. Hi, Susan. How are you?
Hello, Senator. Nice to see you.
Good to see you too. Susan, I wanted to clarify, you mentioned about the balance of power. I wanted to explore this balance of power because you named about the various insurance companies that you represent, which are each is probably close to $1 billion each in power. And then if you were to look at the largest two hospitals within our state, let's say Yale New Haven and Hartford Healthcare. Yale lost $300 million last year, and Hartford Hospital may have made $14 million despite all of their footprint in the state of Connecticut. And then if you look at even the earnings of the heads of the CEOs of the insurance companies alone, if you put the dollar amount of just the salaries of the few executives, they're more than the entire budget of some of the hospitals. And I'm trying to see, how do you think that this bill is going to equalize the power? Because I think it's making the insurance industry more powerful rather than equalizing the power. Again, but I'm new at this, so maybe you can help me.
Thank you for the question, Senator. I think first I would say that the companies that you're representing are global companies in many respects. They, you know, reach, and some of them are home, are domiciled here in Connecticut, and they are international companies. When you look at the profit margins for these companies, despite the billions numbers or the other numbers that are in the press, you're looking at about a 3% to 5% margin. I think if you compared that to some of the other stakeholders in the delivery system, particularly the pharmaceutical companies, I think it pales in comparison to some of those figures. I would also add that the insurers, unlike other stakeholders in the delivery system, are subject to rate review and approval by the Department of Insurance. I know you've participated in some of those hearings. They're also subject to a medical loss ratio standard whereby they have to spend a certain amount of the dollar on medical services or rebate it to the consumers or to the employers. So I think in this industry, there's been a lot of legislation and regulation that has been levied at the carriers. I don't think it's been an equal opportunity regulatory structure, for those outside of the carriers. And I want to add one more thing to, I think, to the out of network conversation. It's been talked about in this conversation today numerous times that this would erode the surprise billing statutes. As I understand the bill, and we can all get better clarification, the surprise billing statutes stand today. When you, as the previous speaker said, when you go into an emergency room, it's not the in-network price that the emergency room gets, but the Fair Health Standard, which is a clearinghouse that's in law. If it's a service outside of the emergency room, there is a surprise billing law, but you only have the benefit of that surprise billing law if you had been informed that you might be incurring an out-of-network cost. This legislation, as I read it, puts an out-of-network limit, which I do think that Dr. Gifford was very clear that, you know, perhaps Medicare isn't the right standard. We could be looking at, you know, higher, we could be looking, you know, at different numbers, but that's an added protection that includes balance billing, because I'm going to use out of state as opposed to in-state here. You could go to you think you're going to an in-state hospital, but the emergency room is run by a private venture, and you could be going to an out-of-network emergency room and not even know that you're going to an out-of-network emergency room. You also could go in for surgery with an in-network doctor, but oops, something goes wrong and you do need that reconstructive surgery. That reconstructive surgeon could be out of network. That anesthesiologist could be out of network. I think all of these things are meant to bring this in. We have just a couple, maybe more than two, but a couple, 3, 4 large hospital systems in Connecticut currently. And I think what we have to recognize is that there's a huge, we have to have those hospitals in our network when we're selling products. It's very difficult not to. So I think this shifts the balance a little bit. Is it right at Medicare? Certainly that can be a conversation going forward, but I do think it's an important thing to have on the table.
So I'll go back and ask my question a different way. So what would, in your mind, be good enough losses for the healthcare systems to be able to say, hey, your 500 million you've lost is good enough and now we are even? I mean, in other words, you have healthcare systems that are losing money, or one made 14 million despite being so large. And now with some of the proposals, they're going to lose a lot more money and they will have to lay off people. And while you're representing billion-dollar conglomerates and so on, they're not dying, but healthcare systems are at risk of getting worse and the quality being impacted. So that's directly linked to the patient's well-being as well. So I'm trying to see, okay, 300 million is not enough for us to worry about for one healthcare system. Is 500 million going to be a cutoff where we say, well, maybe it's time for us to, I'm just trying to understand what would be the cutoff where we will as a body say, okay, that's enough losses and that's going to cause this healthcare system to get worse. So let's stop. Do you have a figure? Does the insurance industry that you represent, do they have a figure that they will be satisfied with?
I think I would turn the conversation around. I think I would say that you have to let the data drive that conversation. And I think that's exactly what the Office of Health Strategy has been set up to do. I think that's what benchmarking is looking at. I think you have to include the entire system, not just the motherships of the hospitals, in the center. You have to look at the whole delivery system, the outpatient places that are in the suburbs, et cetera. And I think that's what the whole, it's hard to have those kinds of conversations in an environment like this, because we may agree to disagree. We all have our positions that we have to represent. But if you let the data drive the conversation, and I think what you're seeing through OHS and through what Dr. Giffords proposed and through what the governor proposed is the data driving the conversation. They're looking at the numbers, they've got the numbers, and that I think is what's led them to the proposals that are here today.
So on another topic, is your testimony today that many of the people who spoke, they read the bill wrong when they said that the surprise billing was going to harm the access to care and emergency room services?
I mean, I think we can always benefit from further discussions, but I think that you hear that a lot up here from different folks, and in the end, what as I think it was from the credit union said, the sausage making kind of yields a different end result. So I think it needs to be discussed. I think we are discussing it. I think that is the challenge, right? We have to address the cost drivers, because if you have the health systems and nobody can afford the health insurance to go to the health systems, then nobody has access already.
So, and thank you so much for your answers. I appreciate your indulgence. And another perspective is that this is based on sometimes newspaper and information that, and also, of course, the rate setting conversations. Many of your clients or the people you represent, they would ask for 18%, 25%, 16%. And then I see that that's what the ask is. And many of the times the Connecticut Insurance Department and others sometimes are thinking that through and looking at what would be the safe amount. But when your contracts and information with healthcare systems are looked at, the increase is 2%, 3%. So what is this difference between the 2% or 3% that goes up in the payments to the healthcare systems and your ask for 25%? Where does that 23% go?
I'm going to do my best to answer this without, I can't speak to the details of the various rate submissions, but I think there's a number of components. I think you know as well as anyone what trend is a part of that equation, right? I think that there are new services, new technologies that are coming on board every year. 10 years ago, we didn't have genome sequencing. We didn't have 3D mammography. We didn't have all of the things that we have today, which are terrific. We didn't have, $100,000 drugs on the market, that are being advertised every evening, on television. So there's some component of this that is going to continue to increase. There's no question in my mind, but where does the rest of that go? It goes to utilization, it goes to unit cost, and predominantly unit cost. That's where the dollars are going.
Okay, so in other words, of the total amount that's raised by the rates, not all of that ends up going to any healthcare delivery system. There's a percentage that goes into the overheads, significant amount, actually majority. But the increase at times is because we have far better technology. Yes, the medicines are life-saving, but their cost is killing. So I respect that part, because when I look at the cost of medicines that are there, it's you start to sweat how much what some of these medicines are, but they do wonders for patients. Okay, this is very helpful. Thank you so much for your testimony, and thank you for answering my questions. Thank you, Mr. Chair.
Thank you, Senator. Any other questions? Representative Meskers.
Susan, I want to thank you for your testimony. I know it's always hard to be the last one in the group on the testimony, and I know my other representatives and senators will look at me if I go on for too long.
I was counting on that.
And but I guess the observation that you left me with is that you've got an insurance industry that's negotiating with three major hospital groups, and that you need coverage in all of the hospital groups in order to sell a policy in Connecticut. So there's a strength in the negotiation of the price and the reimbursement that the hospitals get as they sit there in each one of those ranges. And I think that's probably in the negotiation. I think that's worth bearing in mind, that, that we've allowed the industry to consolidate, and they've gained a bargaining edge in your mind, and at least from the industry's mind on that. I think the other structural issue that we have, which you won't appreciate as much, is the 15% MLR. And it's a very simple analysis. You get 15 cents on every dollar. And I'm not going to argue whether 15 cents is fair or not. Senator Anwar would probably wrestle me on that. But I think the problem is that when the bill goes to $2, you get 30 cents. And when the bill goes to $3, you get 45 cents. And so if the bill went from $2 to $1, you'd go from 30 to 15 cents. And I think what we haven't built in the structure of the MLR is an incentive for the insurance companies to make more money when they save money, we're basically encouraging every component of the system to run more water through the hose. So nobody makes less money if the bills continue to go up by 10, 20, or 30% a year. And that structurally is unsustainable. So I think probably at some point, not in front of the public and not in front of the TV, I'm going to ask for what's a rational guideline for profit sharing for the insurance industry on cost reductions, because I think they need an incentive to reduce costs, and we need to give them the structural ability to reduce costs. And I think we have a negotiation process on the Medicaid reimbursement versus the other reimbursement rates that the hospital industry doesn't want to hear about either, and the private practice doctors don't want to hear about it. And I have nothing but respect for the industry. But I think those conversations need to be had going forward. So I appreciate your late night testimony, and I'll leave you with that.
And if I could just briefly respond, I won't keep the committee too long. And I anticipated that question because you and I have had that conversation numerous times, and I always appreciate having that conversation on the MLR. I do think there are additional checks and balances that the industry is subject to, rate review and analysis, and frankly, the marketplace. You know, we have an incentive to keep prices lower because we're competing, or my carriers are competing. I like to talk about us as one, and I think we're as one many times when we're lobbying you up here, but these are fierce competitors in the market, and they're trying to sell a product at a reduced cost that's high quality. So I do think there are different additional checks and balances in addition to the MLR. I think the MLR is important for guidance, but I do think there are other pieces, and not to mention benchmarking that's also happening on the other side of the building over there in terms of a cost growth target, et cetera. So while I might agree to disagree on the MLR, if I took you at your took your point, I would also say that there's additional safeguards that are in the market.
And just as a response and comment, there are safeguards, but none of the industry suffers with increased costs. They're all racing for the finest line margin of profit, but with an 85%, every extra dollar of revenue is incremental profit. So driving the cost down doesn't necessarily, it may build the market share in the short term, but it doesn't translate into the bottom line with a 15% MLR. If I can charge $10 million and $5 million at 15%, I'd rather charge 10 million. It's a structural incentive to the industry.
I guess I would, if I could just respond briefly. I think when you're talking about the fully insured market, you are seeing the migration, as you've heard today, into other markets like the self-insured. I lost my train of thought, but I do understand what you're saying, but I do think that there is an incentive to keep the rates low. I also think it's really important, and I perhaps should have started with this, but you hear a lot about the ACA and rate requirements in the small group market. The carriers can only rate on certain factors, right? They can only rate on age. They can only rate on geography. They can only rate on size. They put it in the mix master, and that's not just one group, right? When Anthem or United or Aetna or whomever rates their small group market, they are pooling all those lives together. They're putting it in the mix master, and they're putting out a rate. They only can rate on those three factors. And the idea behind that is that folks that were sicker weren't going to pay as much, and folks that were healthy were going to pay a little bit more, right? It's a adjusted community rating. That's the whole idea behind it. So that they are very much held to those standards, and that's what the Department of Insurance looks at during rate review and approval. Oh, you're done? Well, I know we'll
Thank you.
continue this at another time.
Thank you, Representative Meskers.
Thank you.
Any other questions? No. Thank you, Sue. Appreciate your testimony.
Thank you so much. I appreciate your
And I
time.
apologize to the committee. I made a mistake. We have one last testifier who had technical issues. Doris Maldonado Mendez, who's on Zoom, I believe. Last one, I promise.
My apologies and thank you, everyone. Good evening,
Doris.
buenas noches. Hello. Dear co-chair, thank you, co-chairs, Representative Wood and Senator Cabrera, Attorney General Tang, and distinguished members of the Insurance and Real Estate Committee. My name is Doris Maldonado Mendez. I'm a Latina born with disabilities, serving as chair of the Connecticut Council on Developmental Disabilities, an agency entirely funded by the Federal Administration for Community Living. And I'm the statewide bilingual health information specialist and community health worker for PATH Connecticut. Connecticut's Family to Family Health Information Center, F2Fs, are also federally funded programs providing crucial services to families with special health care needs. We support HB 6620, an act promoting competition and contracts between health carriers and healthcare providers. One of the main reasons of our state's rising healthcare costs is consolidation in healthcare markets, which is limiting access to coverage and increasingly unaffordable for consumers, employers, and businesses. I've personally experienced as a marginalized community member throughout the lifespan with disabilities that we are more likely to experience medical debt and forego treatments and prescriptions due to the cost of care. Our communities experience disproportionate burdens of having higher rates of insurance, and exacerbated social determinants of health consequences. Most individuals with developmental disabilities now live in home and community-based settings where they rely on the generic healthcare system for primary care and many specialties. Though ADA should ensure access to healthcare for these individuals, not all healthcare providers provide the necessary accommodations. Choice of healthcare providers is an essential means by which individuals with developmental disabilities find practices that offer them healthcare in manners that suit them. The consolidation of the healthcare industry, where 80% of primary care providers are now owned by large corporations, threatens to limit the choices available to us and those with developmental disabilities. Hospital monopolies are also associated with lower quality of patient care and adverse outcomes. Connecticut's hospital markets are among the most consolidated in the US. Please empower meaningful patient-centered participation and level the playing field, support competition, lower premiums and overall healthcare costs by prohibiting anti-competitive contracts clauses to lower healthcare costs and insurance premiums. Thank you for the opportunity to submit this testimony and speak with you. Nada sobre nosotros sin nosotros. Thank you.
Thank you so much. Any questions? Seeing none, thank you very much for your testimony this evening.
Thank you. Good night.
Good night. Okay, now for real. That was the last one, promise. This meeting is adjourned. See you all Thursday.